network suddenly loses its coherence. There is a term which you will repeatedly read. It is called as a high entropy. If you understand the 12th physics, the law of thermodynamics, entropy is the number of randomly molecules which are colliding with each other. So a higher entropy state would be higher number of molecules. In our case, it will be the higher number of thoughts crossing with each other. And over a long term, the repeated release of this high glutamine, it increases the brain-derived neurotrophic factor, it increases synaptogenesis, it increases the resilience of the synapses, and it increases the potentiation of these synapses. So, what basically you are doing is, it's like a bar. So, all the default mode network has created certain pathways in the brain, and your brain continues to run along those pathways. It does not look beyond those pathways. But now, because there is now a flood, and all those old pathways are being flooded, being obliterated, so you have to find other ways, go through new regions to reach that same brain areas. And there is a lot of new association which happens because of this flooding. So the available drug for esketamine is Spravato, not available in India yet. It is available as a 56 or an 84 milligram dose to be taken twice a week, and the patient self-administers, but he is supervised by a clinician for at least 2 hours so that there are no obvious side effects with the patient. But it is not a standalone drug. Continued use of SSRI, SNRI, whatever the patient is taking, is a must whenever you are trying esketamine for the patient. So what esketamine does to this default mode network is that it dampens the circuitry. So you have a brain which is negatively tuned about itself. A person who's always negative about himself, the person is, because that default mode network has created those pathways where the person always feels himself inferior, negative. So these frontal lobe connections are dampened, but there is an increased flooding and there are new pathways, especially leading to the parietal lobe, and which opens up new ideas. So normally the brain regions which were not communicating earlier are now communicating with each other. So basically it normalizes a negatively tuned DML. And is it always going to be a positive experience? Not likely. But there are chances that there might be new breakthroughs. The other psychedelics that we know about, the classic psychedelics, psilocybin, which is what is called as magic mushrooms. Then LSD, the most famous one, the Hare Rama Hare Krishna movement. It was synthesized by Albert Hoffman, and there's a lot of stories on the internet regarding the accidental discovery and the subsequent effects of LSD. Then you have this Amazonian drink called as ayahuasca, which contains dimethyltryptamine DMT. So it is more of a ceremonial brew. It is drunk during the festivities in the region. And there is a mescaline which is a part of a peyote cacti. So these classic psychedelics, psilocybin, LSD, they have a different mode of action as compared to esketamine. These act as a serotonin 2A agonist, and they flood the brain with huge amount of serotonin. So that leads to a sudden rush. The other psychedelics, one is the dissociative, which can be loosely clubbed under the topic of psychedelics, but they act via NMDA. And then we have this category of drugs called as empathogens and entactogens. So the classic example is MDMA, also called as ecstasy or ice or other known drugs. So basically, ecstasy releases a massive rush of all three monoamines: dopamine, norepinephrine, as well as serotonin. But what these psychedelics do is that because of this massive rush of serotonin and other neurotropics in the brain, the difference between the self and the other fades, the ego boundaries, they dissolve. And then the functional connections between the brains are flooded because there is so much neurotransmitter to go around.
So maybe misuse or again the addiction potential is very high. So this is another risk.
So is there anyone in the audience who has done this or have some experience about it and whether they can share it with us?
So I have a person from borderline personality disorder who was refractory to treatment. So this is something that the father found out on his own, got fruits, and whenever, according to whatever their definition is, that she gets this dysregulation kind of episode, or she has another episode of depression, they usually just give it to her. And it works really well for her, and it's usually like more like a ad hoc whenever needed kind of.
Right, left, and center. So they nearly use esketamine for every patient because especially the ease of use. Means now because of this nasal spray, it is much more easier.
And blood pressure because of calcium hypertension. What is your opinion for that?
D5 and D1 do have some role in memory and attention, but it's not well understood. So what happens when we use D2 antagonists? So that is how the antipsychotic history begins with D2 antagonists. What they do is normalize mesolimbic at the cost of hypodopaminergic state in all other dopamine drugs. So the side effects are EPS, which is drug-induced Parkinsonism, lack of pleasure as it acts on mesolimbic, hyperprolactinemia and tuberoinfundibular, negative symptoms and cognitive symptoms because of the mesocortical blockade. So overcoming these problems, what we have done so far are SCDs, serotonin dopamine antagonists. The serotonin part takes care of probably hypodopaminic states in many brain areas. Rapid D2 dissociation being used by something like aripiprazole, which works and reduces the extrapyramidal symptoms, and the dopamine partial agonists, so which are supposed to be the solutions. So you get a patient with Parkinson's and psychosis do predict dementia. So it's like that. So it's about 50% neurobiological sharing in these two conditions, which is Parkinsonism and dementia. So what are the non-dopaminergic treatment options? So we need to understand about what is the psychosis network. Psychosis network is essentially the communication or crosstalk between the neurotransmitters, which are serotonin, glutamate, GABA and dopamine. So how does this go? From raphe nuclei, 5-HT serotonin projections go to pyramidal glutamate neuron in prefrontal cortex. Another set of pyramidal glutamate neurons sends GABA inhibitory signals to that same area of pyramidal glutamate neurons. The net result leads to glutamate projections to ventral tegmental area and visual cortex, and from VTA to emotional and motor stratum we have dopamine. So dopamine is kind of a downstream effect of serotonin, GABA and glutamate. Is that enough? No. There is a relationship between acetylcholine and dopamine. There is a reciprocal. It's kind of simplified. It is not as simple, but for a simplified reason, you can presume that whatever increases cholinergic tone in striatum, whatever increases cholinergic tone reduces dopaminergic tone. And the anticholinergics directly cause relative increase in dopamine. We know that, right? Because we treat OPP and with atropine we do have psychosis. So anticholinergics are known to cause psychosis. Cholinergics can reduce psychosis. This means dopamine can be indirectly modulated by, or a dopamine is a downstream effect of serotonin, glutamate, GABA and acetylcholine. So this means for treating psychosis in a non-dopaminergic way, we can modulate serotonin or glutamate or GABA or acetylcholine. So what the options we have? Modulating glutamate, what I have done is I have searched the literature and the drug which has been most tried or was most close to success, I have tried to mention it here. So levetiracetam is a DAAO inhibitor. It increases D-serine. It promotes NMDA receptor activation, and the phase 2 data as per 2024 study is mixed. This 2024 study got published in 2026, the data being mixed, but still it's kind of a promising drug. Now, this mechanism of NMDA in schizophrenia is not an alternative to dopamine hypothesis. It's like the NMDA hypothesis says that NMDA's downstream actions regulate dopamine. So NMDA receptor acting drugs do have effects on dopamine, and this drug has been tried as a part of that with mixed success. Selective GABA A alpha 2 or 3 modulators are being studied particularly in cognition, but unfortunately the results in schizophrenia are not mixed, they are negative. So what happened was, in medicine we do have a lot of things being discovered accidentally. So this now has got potential relevance in cognitive inhibition, cognitions, cortical inhibitions, cognitions and anxiety. This kind of drugs are being tried in epilepsy and panic. Now this is upcoming, and we should have, I was talking to some company and they should be having this drug in India in about 5 to 6 months, which is xanomeline and tropsium combination. This works as M1 and M4 receptor. Xanomeline is M1 and M4 agonist. Now we know that we have got M1, M2, M3, M4. To be very precise, M1 is mind, M2 is myocardium, M3 is muscle, and M4 is movement. So xanomeline is M1 and M4 receptor agonist. So agonist means it pushes acetylcholine. So as we said, increasing acetylcholine will reduce dopamine indirectly. So this works. Tropsium is peripheral anticholinergic. Now that we are promoting acetylcholine everywhere, we will have cholinergic side effects peripherally. Now to block that, we need to block the M4. And so tropsium is a peripheral M4 blocker. So this is a combination of two drugs which act on the same system, one being agonist and one being antagonist. This is approved by US FDA in September 2024 as fixed dose combination for schizophrenia treatment. So it's already approved and we are likely to have it in India. The last mechanism which can be modulated is serotonin. 5-HT2A antagonism or inverse agonism. Inverse agonism essentially is strong antagonism, nothing more than that. So it's kind of antagonism only. Has significant role. 5-HT1A partial agonism or 5-HT1A agonism is like 5-HT2A antagonism. The effects remain same. And 5-HT7 antagonism, which is a drug which we do use as lurasidone, which has got role in cognition. So lurasidone is supposed to be pro-cognitive. This is a road which in the picture the road is called the Death Road, which is in Bolivia, which is one of the difficult motorable roads in world. The PDP challenges such a narrow therapeutic road. So what can be the solution in PDP? Is it serotonin, GABA, glutamate or acetylcholine? What will help in PDP? Now this is where we started. Let us know what happens to this in PDP. Neuropathology in PDP and dementia. We know that there are beta amyloid plaques and neurofibrillary triangles and Lewy bodies in dementia. Do they appear in PDP? Yes, in about 50% or 60% of the cases. Even in PDP, this is there. Now what happens is, this blocks the GABAergic inhibition to 5-HT. Now presume this initial diagram, what has now happened is 5-HT is stimulating glutamate. There is a lot of glutamate poured in, and that glutamate indirectly is increasing dopamine. Now you see that offshoots to that visual cortex, so which can explain the visual hallucinations Parkinson's disease psychosis has, because there is a direct connection to visual cortex. and that glutamate increase does lead to visual hallucinations. So what we do here is we block 5-HT2A. Now this balances that GABAergic drive. As a part of that balanced GABAergic drive, now that glutamate becomes normalized and the dopamine becomes normalized. So this is how 5-HT2A antagonism will work. So 5-HT2A can be the solution PDP. In PDP, the options we had so far was clozapine. What I have, the red arrows indicate dopamine and 5-HT2A action, and quetiapine. Comparing these two actions, the more the green line between 5-HT2A and dopamine, D2, it will have lesser EPS, because 5-HT2A blockade will reduce EPS. So the green line is similar, but what is problem is the problem in these drugs is the flashing rectangles. The flashing rectangles suggest that there will be lot of H1M1 action before even that 5-HT2A is clicked in. Because of that H1M1 action, you will have a lot of unwanted anticholinergic side effects and unwanted postural drop, even there is alpha 1, and unwanted sedation. So that's the problem. So current options have their own problems and they aren't complete solutions. So we need something better. So now we have the first non-dopaminergic antipsychotic without dopamine receptor blockade, that is pimavanserin. So this is typical Stephenthal icon of pimavanserin. Very clean drug, very targeted drug. Only two actions, 5-HT2A and 5-HT2C. 5-HT2A being about 6 times stronger than 5-HT2C. It's a 5-HT2A inverse agonist and 5-HT2C antagonist. As I already said, inverse agonism is strong antagonism. Now, what does 5-HT2A actually do with dopamine? So, from prefrontal cortex, glutamate goes to substantia nigra or ventral tegmental area. From there, second dopaminergic neuron activates and goes to emotional stratum, which causes positive symptoms. The moment we block 5-HT2A, what happens here is glutamate drive reduces, dopamine drive reduces, and there is reduction in positive symptoms. This is how the antipsychotic action triggers. 5-glutamate neuron from prefrontal cortex goes to substantia nigra, but in there is a GABA interneuron which goes to motor stratum. The earlier was emotional stratum. So this reduces. Since GABA gets activated, it cools off dopamine. So there is extrapyramidal side effect because there is lesser dopamine in nigrostriatal tract. The moment we block 5-HT2A, the glutamate drive reduces, GABA is inhibited, and inhibition of GABA increases dopamine drive. So this reduces EPS. And the last and third mechanism is glutamate goes to ventral tegmental area. There is another GABA interneuron. Because of GABA's inhibition, dopamine going back to prefrontal cortex is reduced because GABA inhibits that dopamine. The moment we block 5-HT2A, there is reduced glutamate, reduced GABA, and increased dopamine because now GABA's brakes on dopamine have been lifted. So more dopamine flows to prefrontal cortex. So now there is no emotional blunting. So there are three mechanisms through which 5-HT2A antagonism helps psychosis. It's antipsychotic, it's reducing EPS, and it's reducing the negative symptoms also. 5-HT2C, it increases dopamine, norepinephrine in prefrontal cortex, striatum, and nucleus accumbens, which are the reward centers. Affects symptomatic improvement and mood improvement, but it also has got action in hypothalamus. It actually blocks the satiety centers. The 5-HT2A, 5-HT2C blockade blocks the satiety centers, so patients eat more. So they have got good weight gain, better appetite regulation. And in amygdala as we all know is an anxiety center, it reduces anxiety. Coming to quick pharmacokinetics, it's absorbed on oral dosing, Tmax is around 6 hours. Food might increase peak concentration by 9%, particularly high fat meal, but increases area under curve by 8%. So this should always be given with meal because now we don't have the peak dose related side effects and better exposure of the drug to the body. Protein binding is high, 95% distributed widely in bloodstream, crosses blood-brain barrier. It's got long half-life of 57 hours. So one can use it trickily as a drug which can be given alternate day also. Now that we do have only one fixed dose range. Now if you want half the dose, you can give it alternate day. Steady state obviously takes longer time because of longer half-life. Metabolized by 3A4. It has got active metabolite. Quick clinical trials. It's approved in PDP. It's approved based on phase 3 results. DRP, dementia-related psychosis, Harmony trial showed significant relapse prevention, but FDA declined approval due to lack of consistent benefits across dementia subtypes, because dementia has got multiple subtypes and it did not show good results across subtypes. In Alzheimer's disease psychosis, phase 2 trial showed early benefits, but the benefits did not last, so it wasn't approved. In negative symptom schizophrenia, phase 2 advanced showed modest benefits, but phase 3 advanced 2 and enhanced trials did not meet the primary endpoints. I mean, they were not effective, so it's not been approved. Autism related irritability, early phase safety trials conducted, but no definite evidence of efficacy yet. Safety has been established. As an adjunct to major depressive disorder, the Clarity trial showed positive results. However, phase 3 follow-up did not show statistically significant improvement. So this has been tried in many conditions.
hypotheses and the intervention modalities primarily focusing on that, but not all cases may fit to this particular intervention. And so challenges in traditional psychopharmacology necessitate innovation and focusing on other axes of intervention. We now also realize over a period of time that the non-communicable diseases, particularly of medicines, GABA PAMs and GLP-1 agonist. GABA PAMs mainly work on neurosteroid binding site on GABA channels, and GLP-1 are basically targeting the incretin system, GLP-1 and GIP. The treatment gap that I was mentioning earlier. So the postpartum depression, 1 in 5 new mothers in India suffer from significant postpartum depression, and rapid intervention is important for better feto-maternal bonding, infant-maternal bonding, and better future outcomes neurodevelopmentally for infant as well. And in that, we are usually trying antidepressants which are taking 4 to 8 weeks. There is some use of second generation antipsychotics also, and these frequently cause weight gain. Similarly, many of the patients don't even respond to traditional options. So the research started focusing on GABA A receptor PAMs. For purpose of brevity, I will be calling them PAMs. They are, I think we don't have pointer, but the blue part, the cell wall membrane part, near there is neurosteroid binding site. This picture is not totally accurate, but the main point I wanted to highlight was that the structure of GABA channel, GABA A particularly, contains alpha, beta, and gamma subunits when it is synaptic, and extrasynaptic GABA A's contain delta unit rather than gamma subunit. And the binding site is nearer to alpha unit as per the research. By that, it helps restore GABAergic tones, and so it can have some effect like benzodiazepines, but there are some differences. And one of the purported differences presented is that they have less withdrawal because they are more tonic in nature, as we'll see in further slides. The way PAM acts, for our purpose of discussion, even benzodiazepines are positive allosteric modulators. They don't directly open the channel, but they increase the probability of channel opening. And particularly with regards to benzodiazepine, they are thought of as more of pulsatile or phasic. And compared to that, these neurosteroid related PAMs are more tonic in nature, elevating the tone and thereby supposedly have better and safer treatment intervention. And first of them was the brexanolone. Now, what are the neurosteroids? Basically, testosterone, progesterone, estrogen, this whole chain. One of them is allopregnanolone, and this allopregnanolone has sites all over brain also. Structurally, brexanolone is practically identical to allopregnanolone, and it is to be given single 60-hour IV infusion. Effect has been noticed to be lasting more than 30 days. There have been two main studies to approve it. Phase 3 studies doing 60 microgram per hour dose and 90 microgram per kg per hour dose, which showed significant reduction in HAM-D and some 4-5 points differentiation from placebo also on HAM-D, with headache, dizziness, and somnolence being the commonest side effect. But the route was IV. So then the research focused on oral part. If you can look at the top right corner, that nitrogen part is the extra part different from the allopregnanolone molecule. And this durazonolone was studied in various trials from 21 to 23ish and ultimately got approval in August 2023 by FDA for postpartum depression. It is distinct 2 weeks oral dose 50 mg per day. The main trials that led to approval was Skylark trial and Robin trial, but we are also the researchers are also exploring its use in other conditions. For example, Soulline trial is assessing whether it has a long-term benefit in major depression, non-postpartum onset. Safety-wise, overall it is considered safe molecule. Sedation is commonest, so driving-related and other instructions do apply. Boxed warnings are CNS depression. It has to be taken with fatty food to ensure proper consistent absorption. Adherence is likely to be better because of distinct 2-week course rather than longer months-long course we see with traditional antidepressants. In future, it is also being considered for bipolar depression because we are concerned about switch and we have limited treatment options in bipolar depression as compared to mania. And people are also looking at long-term course rather than 2-week episodic course and see whether it can help with anxiety just like benzodiazepines do. Now moving on to the next class of agent, GLP-1 agonists. So primarily they came into highlight for their role in obesity and type 2 diabetes mellitus, but the weight loss is quite significant and it seems to offer other health benefits also. In psychiatry also, first it was focused for antipsychotic induced weight gains, but later on the research is also showing that it has effect in dopaminergic reward pathways and potentially it has neuroprotective effect also, so it can have some role in all the conditions that fit the neuroinflammatory hypothesis, all the psychiatric symptoms, including neurodegenerative ones like Alzheimer and Parkinson's, as we'll see in future. So what was the impact in weight? Most impact that has been seen is with semaglutide. That was somewhere around 9 kg. Liraglutide is almost half of that, and that metformin is even half of that, 2 to 3 kg, which matches our clinical experience. How does it cause weight loss? Multiple mechanisms. There are central mechanisms, there are peripheral mechanisms also. One of them being the gastric emptying is slowed down, the insulin resistance part is taken care of. Centrally, there are other effects apart from satiety, but the primary effect for weight loss is satiety at hypothalamic nuclei. However, if you can see this slide, red dots and yellow dots indicate various areas where the GLP receptors have been found in various studies. So it not only acts on hypothalamus, it also acts on ventral tegmental area, nucleus accumbens, even the prefrontal cortex. And this prefrontal cortex part is primarily important for executive functioning and probably the prefrontal inhibition that is improved, and thereby having indirect effect in addictive disorders and other psychiatric conditions also. So all in all, it will restore the glutamate and GABA imbalance, which is one of the current uh, kind of a marker of research of inhibitory excitatory imbalance. Via action on VTA NSA circuit, it decreases dopamine spikes. So the high sudden spikes were now attenuated, and thereby it seems to have a role in addictive disorders. It also seems to promote hippocampal neurogenesis, and that may have implication in depression and other psychiatric conditions. So that the amplitude part we were talking about, now that the amplitude is decreased subjectively, patients describe that thoughts related to food and that intrusive or compulsive thoughts about eating, that is reduced. And similarly, it has been seen that it also reduces in context of other substance uses also. That's why it has been studied in alcohol use disorder and nicotine use disorders also. People have been starting to study it in other addictions also. For example, opioidergic substances. This is one of the preclinical model. Now the thing is, we do have rodent model data, but human and rodent brain has slightly different distribution of GLP receptors, so it is not directly extrapolatable, but still this is the best we have in terms of preclinical data. The important part is that nucleus rectus solitarius, laterodorsal tegmentum, both directly affect posterior VTA and reduce the activity. Now, there is a line, anterior VTA, posterior VTA. The rodent study showed that anterior VTA injection of these agents did not have any effect, but posterior VTA did. So, first step is NTS and LTDG is reducing the activity of VTA itself, which in turn sends activity to NSA, which is again further reduced, and that's how the spikes are reduced. Coming to anti-inflammatory and neurocognitive benefits, as we can see, it has intracellular cascading effect, and by that what ultimately ends up happening is reduced microglial activation, the inflammation goes down, there is reduced oxidative stress, so cell longevity improves. It has potential to improve executive function as we saw before. How it does? This is essentially the diagrammatic representation showing its effect on Crab binding protein and how it helps in synaptic plasticity and neuroprotection. It also acts via AKT, PI3 AKT pathway.
My question is that a lot of patients these days are on semaglutide or tirzepatide, and one of the major actions that it has is it reduces the gastric emptying time. So the question I have is, how does it affect the absorption of psychotropics that we generally prescribe? And is there any studies?
Energy is just used to bypass resistance of scalp that we have. So for electrical stimulation in ECT, we need to use higher voltage or a higher electrical current because we want to bypass scalp resistance, which work as an wood. But in RTMS, these magnetic waves can bypass scalp directly. So the stimulation required for electrical intensity or magnetic intensity is very less. So it based on principle of electromagnetic induction, where one energy, that is electrical energy, is converted into magnetic energy into one coil which is placed on brain, and brain itself act as a second coil which convert this magnetic energy into electrical energy again. So that's what principle of electromagnetic induction is. So indication of RTMS. RTMS has been approved by US FDA in treatment of resistant depression in 2008. So it's almost been now going to be 20 years. It's been US FDA approved for treatment of resistant depression and major depressive disorder. In OCD, with another coil, with a deep stimulation coil, it got approved in 2018. It is also been commonly used in many other indications, not US FDA approved yet, but then in negative symptoms of schizophrenia, results are very good. Refractory auditory hallucinations, again, results are good. Migraine headache, I have not tried any, but then yes, it got US FDA approval in 2013. Post-stroke aphasia results are great. We tried using it in post-stroke aphasia in many old cases, and it works well in post-stroke aphasia. It is also commonly been used in other indications like in addiction, in other neuropsychiatric disorders like PTSD, also in many other neurological indications like post-stroke recovery. But then at our center, we are limiting its use for two major indications: depression, resistant depression, and resistant OCD. So now, we need to know basic, and probably still it is not penetrating into day-to-day clinical practice because of lack of awareness and cost of machine. So we'll discuss about that later in question answer session if anybody has that. But then these are the three coils which are available with RTMS. The first coil is circular coil. This circular coil actually, is commonly used in neurostimulation. So in psychiatry, we usually don't use this coil. The second coil is figure 8 coil. It has a tendency to stimulate brain area very pinpoint. So you can define brain area and you can stimulate whenever we want a selective stimulation. This figure 8 coil is commonly used and commonly used in depression as an treatment selective coil. And double cone coil is for deeper penetration. Nowadays we have deep RTMS also. So the RTMS machines, they had a limitation of not penetrating brain area more than 3.5 centimeter. So with the help of this double cone coil, now we can reach deeper areas also. So we can penetrate more than cortex. So now the accessibility to inner areas like up to certain 5.5 centimeter depth we can penetrate with the help of this third, which is double cone coil. They actually look like this. I don't have circular coil, but then these are actual pictures. The first coil is figure 8 coil and another two are double cone coil, which are slightly curved for deeper penetration. And this is typically how RTMS machine looks like. So it has 3 unit, software unit with screen. Second is an stimulation unit, which is a hardware. And third is an cooling unit because it generates lot of heat while converting electrical energy into magnetic energy. The coil needs to be cooled continuously, and it's oil cooled or air cooled coil machines that we have. Oil cooled are considered to be having a better performance. Now, these are the parameters that we commonly use. When you read article about RTMS, these terms we are going to come across commonly. Single pulse is a single stimulation, one single tick or one single stimulation of underlying brain area. That usually we use in brain mapping and diagnostic techniques or while getting motor threshold. Repetitive pulses are used in therapeutic practice for a longer lasting effect. As I said that we use two parameters. One is stimulatory parameter and another one is inhibitory underlying brain area. So when we use frequency of RTMS more than 5 Hz, it is stimulatory for underlying brain area. And when it is less than 1 Hz, either 1 Hz or less than that, it is an inhibitory protocol for underlying brain area. For depression and OCD, we usually use stimulatory protocol. Frequency actually ranges between 10 to 50, but then commonly machines which are available in India, we have 10 to 20 Hz frequency as an protocol to be used for treatment of depression and OCD. 50 Hz machines are too costly. Probably people will go for deep RTMS in that cost rather than getting RTMS machine. Pulse is an stimulation duration that we continuously stimulate underlying brain for, but then as machine get heated, we take a pause and we call it intertrain duration, or the gap between two pulses. And duration of session varies from protocol to protocol. There are standard protocols available, and sorry. Nowadays, they come in a software. So on screen, you have a standard protocol saved. You don't have to, go around and keep adjusting machine every time. You just need to select protocols. There are two sets of protocols: USFD approved protocol and Brain Stimulation Society of World approved protocol. So there are multiple protocols which are available. You can select. You just need to go on in software, click the protocol, select it, and you can apply. Usually, different protocols have different duration, different frequency that they use. So commonly duration of one session lasts from 10 minutes to 45 minutes depending on protocol that you use. So common areas of brain that we stimulate with RTMS, it's dorsolateral prefrontal cortex in many indications, including depression, negative symptoms of schizophrenia, PTSD, in addiction. We usually stimulate left dorsolateral prefrontal cortex over here. I get this question from a patient side also every time, that whenever we know they refer down and probably they will be off medicine, but then we don't recommend that. Even though the results are great in few cases, but then yes, we need to continue with the pharmacological intervention and other therapies parallelly to RTMS. I combine both approach, continue medicines. If results are great, then over a period of 3 months to 6 months, then I taper down medicine rather than doing.
And since then, I have observed his practice very closely. As his practice started growing, and he started coming late, very late in the evenings, and then also, he was very firm on one point that every patient deserves the unhurried and quality time of doctor. Now, if the number of patients is where psychiatrists should focus on, it has the 5 stages. Maybe first rapport building, then gathering the history, then creating the MSc, then after creating the MSc, you may go for a diagnostic decision making, and then you finally come up with some treatment plan. Now, these are the stages, and this is the psychiatric assessment where psychiatrists should be able to focus. But other areas are there which prevent from, they eat up most of the time of the doctor or consultant. Now, those tasks which eat up such time and time and efforts also, so those are pain points. Now, the main pain point is documentation. Now, creating MSc or documenting MSc, you may go for creating the MSc by writing. Now, if it is handwritten, then it is most of the times illegible. Again, it may occur interpretation delays over there. Then it may lose some clinical accuracy. If we go for typing the MSc and all the details, in that case, I have seen most of the doctors struggle with keypad. Then it is error prone also, and it also requires cognitive efforts. So, and apart from this, it requires physical storage. As your practice grows, you need to make arrangements for huge storage of physical documentation. And then another point here is it can be accessible from one physical storage of such kind. And one more thing point there is retrieval of any patient's data from these physical hard copies is very, very hard. So, on this we sufficiently brainstormed a lot. Then I jotted down each and every parameter that you consider for each and every parameter that you consider for the MSc and all those history and even chip components and everything. And then BrainMatter provides the auto completion and smart drop downs. So your time is saved and creation of MSc is just matter of seconds. Otherwise, it could have taken few minutes. Then another here about this MSc creation with BrainMatter, experience shows that if BrainMatter is used for such generation of MSc, then the rapport building, this particular process is complementary to rapport building. And can I look at that? Okay. So, okay, fine. So, basically, all the prescription typing is also another pain point where you have to put some, which could be error prone also if you are typing or you are handwriting that prescription. So, here also drop down, some smart drop downs are there. You just type O and then Olazepam or other medicines will show instantly. Now this only just few seconds. This technology is this BrainMatter is using latest technology and it is evolved along with the technology and it provides the speech to text conversion. So if you don't want to type, few doctors say that they don't want to lose eye contact. Then you just speak and your speech will be converted into the text notes. This can be used for follow-ups also. And even for prescription, there is just one button, carry forward, and it carries forward. You need not have to type any medicine name. So all these things are there. I would like to promise 3 things here. With BrainMatter, your data is secured and safe completely, and you always own your data. If you discontinue using BrainMatter, still it is. If you discontinue using BrainMatter, still your data is always with you.
We are now entering an era where data-driven insights, digital biomarkers, have the potential to fundamentally reshape how we understand, predict, and intervene in psychiatric illnesses.
To chair this session, we are honored to have Dr. Manjeet Santre. Sir is a professor and head department of psychiatry, YCM Hospital, Pune, guide to 15 plus psychiatry residents, former medical officer at AFMC, and sir has a special interest in de-addiction psychiatry and community mental health. Our second chairperson for the session,
a very informative, enthusiastic, entertaining, and very novel podcast series where he invites all.
It functions just like a human brain. Now, special thing about deep learning is that it can process large data sets, complex patterns, and again, come at the same thing, that some decision that we're taking using AI. Natural language processing, NLP, is again very relevant for all us psychiatrists because let's face it, we are all dealing with language, dealing with speech, dealing with text, and natural language processing is an important technology for us to take a lot of decisions, be it in our clinical practice or even beyond that. And finally, generative AI, I think this is something which we are all very familiar with. We all use Claude, ChatGPT to create content. It's essentially you talk to an AI machine. So you give some inputs and you get an output. You generate content from that. So using this basic terminology, let us now move on to a very important part. Why is psychiatry suitable for AI? A patient who comes with decreased speech output, poor sleep, decreased social interaction, we know that the person might have depression. So it is very important for us to understand that psychiatry is something which is full of patterns, and we use these patterns to take decisions in our clinical practice. And what AI does is, it is like a continuous monitoring, like I said, because otherwise you are depending on retrospective recall. A person comes to you, say, once a month, and he gives you certain symptoms that he would have probably experienced in the last 1 month. Compare that with someone wearing a wearable device which is tracking the sleep. The data will be much more reliable because it does not depend on recall. So psychiatry is about patterns, and these patterns can very well be used for AI. Now, the current applications of AI in psychiatry, we'll be talking in these 4 heads. The first one is about diagnosis and prediction. The second one is about digital phenotyping. We'll be discussing this in the subsequent slides. Precision psychiatry, and finally, AI-assisted interventions. Now, AI for diagnosis and prediction, there's a whole range of things that AI can be used to diagnose, but I somehow thought that these 4 are the major things, more remarkable and more discussion-worthy things that we should be taking about today. Coming to detection of depression. Now, this is a systematic review that I have quoted from the Journal of Affective Disorders. It reviewed almost 100 studies. This was done back in 2024, so I'm sure in the last couple of years there have been more studies that have been added to this.
In psychiatry, we have decades of neuroimaging, genetics, proteomics, and neurochemistry data available, but unfortunately, nothing has crossed the clinical threshold of diagnostic utility at the individual level. Now, this is something that we have probably never taught. While we joined psychiatry residency, we were given DSM and ICD and told that you have to have 2 out of 5 symptoms to diagnose schizophrenia. We need to have 5 out of 9 symptoms to have a diagnosis of depression. Who told us this? This was decided by a committee of experts. Again, something that we are honestly not sure of. What if the patient does not have 5 symptoms and has 4 symptoms? Or what if the patient does not meet 2 weeks criteria, just 2 days short? Will we not treat them for depression? What do we do in our clinical practice day to day? This is the problem, because most of our patients are not ready to accept the diagnosis, because the continuum is so closely connected. Normal and abnormal is literally at the same graph itself. And what about the monoamine theory and the dopamine theory? We know that quite a lot of patients, even with the best antidepressants that we think of prescribing, don't respond well. And a lot of patients of schizophrenia do not respond perfectly well with antipsychotics. And this is proven by theories. All of this has a lot of sources and studies being done behind it. And the problem with our psychiatry to diagnose is that the brain is a fortress. Anything else is accessible, but brain has so many layers to reach to. We cannot access it, and whatever choices we have are not very clear. But combined together, it shows a magic, which I'm going to show. But before we do that, while I've spoken very negatively, I also need to speak of the fact that no, psychiatry has done great lot too. Lithium has shown 80% reduction in suicides. Clozapine is an amazing treatment for treatment-resistant schizophrenia. CBT is still something that effectively prevents relapse in depression, and ECT is still life-saving. So psychiatry has a very strong hold, but we haven't been probably utilizing it in the best manner. And these are the main barriers that I think we face, to pin it down to 3 points. The diagnostic fragility, the investigative void, and finally the biochemical uncertainty. Isn't that the way we explain it to patients? I have heard it from so many of my friends कि तुम्हारे दाल में थोड़ा नमक कम है, या भी से कि तुम्हारी गाड़ी में थोड़ा पेट्रोल कम है. That's the only thing that we can tell patients. We cannot show them an ECG and tell them ये देखो तुम्हारा T wave ऐसा है, तुम्हारा Q wave ऐसा है. And so I come to my talk. That is signals and silence. I call it signals and silence because signals are the digital biomarkers that AI can very well use to predict a lot, and silence is the human part of it, which is the most important part of it. The deciphering of the silence is what I think is most important. So, my 2 main questions, which are rhetorical questions, are what can technology see that we cannot? And what does technology miss that only we can see? And giving another example, again, this example is going to sound very similar throughout my presentation. A 34-year-old software engineer, 6 months post mild depression,
sleeping better, back at work, PHQ 9 is 4. He smiles, you smile. We all know in private practice, literally we don't sit for the time that is usually something that they think of that we want to give them or they want. And then we write a brief clinical note, sometimes we write a follow-up that okay fine, continue the same. But what did the machine hear? The machine heard its voice, the sleep data, the phone usage pattern and the typing speed, and finally flagged it as a high risk suicide. And the same thing happened. This is a study which has been proven actually, a research. So the point is the algorithm sees something that we do not. It sees a risk, and why not use that risk? Why not prevent something that we can prevent? Smartphones are an amazing tool to use apart from just scrolling for Instagram or something like that. In fact, that scrolling itself is useful. A person who has been scrolling, the phone has actually understood that this is the scrolling speed. And if the scrolling speed reduces, the phone can alert the treating team before a fully relapse becomes visible. So, this presentation is on 3 questions. How will AI reshape daily assessment and triage? Next important, yes, ethics is important. Who owns the patient's most intimate data and who is responsible when the algorithms fail? And finally, what remains exclusively human in the era of automated prediction? This relapse gap is the maximum use AI we can make of. And this is literally like an iceberg where 25% is what we can do in our 15-minute visit. And I say 15 minutes is a lot too. There are so many psychiatrists, even today that I had met, were telling me that they're seeing 100 patients a day. 100. You really think 15 minutes is something that they can give? No. So the bottom 75% has a lot of data which, again, like I said, AI can use. So to be completely precise on what AI can use is the electronic health records. How many of us really are using it? It's collected but not used so much. The symptoms, the dosing, the hospitalization, then the neuroimaging data, fMRI, structural MRI, DTI, PAT, genetics, speech and language, digital phenotype, physiological variables, and lastly the biomarkers.
So if any center call patient is there, we get immediate alerts. So a lot of things are doing, a lot of SOPs and everything. AI can do repeated work. So whatever the diagnostic you can use easily. So that's how AI currently is. So I want to ask you, how to use the agentic AI? The next level they are coming now, a lot of people are using. So that's why I want to ask about insight.
I'm not aware of this term agent AI.
So agentic AI is the new generation of AI. So till now the repetition everything is there. So in agentic AI usually what happens if we create one agent for me. So I have created different agents. Like one agent is for my clinical SOPs, one agent for developing some clinical protocols. So different and if we give order to the agents, they do the work automatically. So automation is there. This is the next level now.
That is in India, which is building this algorithm, because most of the data or the black box these algorithms are created in the western part of the. So it will be like Eastern data or the basic genomics is something different, and so if we use that algorithms in India, so it might be might have different effects or it might have different way of, we should use it I think differently, or we should have our own data or own algorithms based on the
Respected Chief Guest, Dr. T.S.S. Rao, sir. Guest of honor, Dr. Mohan Abache, sir. Honorary General Secretary, Indian Psychiatric Society, Dr. Arun G. Marwale, sir. Dr. Jyoti Prakash, Dr. Brigadier Raju, sir. K.K. Mishra ji. Sorry if I miss somebody's name. We always say Pune tithe kai Pune. Traffic is the main Pune thing in the Pune. It is always increasing stress, pressures, and disturbing sleep of the others. So that's why it's a beneficiary for our branch. I shouldn't say it like that. We hope today's conference will be informative, engaging, productive for everyone.
All the dignitaries and dais, my teacher, Professor Mohan Agase sir, Professor Rao sir, Dr. Marwale, and all my dear friends, my team members, my friend Brigadier Jyoti Prakash, who has been the dynamics CME chairperson, who has curated all the program, and the organizers, Professor Dr. Kendre and Amar, and all these peoples, and all my dear friends, my students. It has been a journey almost for last 8 months, and this planning has been going almost for last 4 to 5 months, where Amar and his team, along with our CME team, Brigadier Jyoti Prakash and all the members associated with him, had curated a academic program which has been enriching, and we involved at this time all the young peoples, all our young colleagues, those who are really oriented to the AI. I welcome all my friends, those who have come as speakers, those who have come out of the zone, like Dr. George, and all those people who have come out of the zones. And I welcome all the Burma peoples for their support. And within the last month, I am not going to detail, but this last 8 months, we have planned majorly 2 things in the zone. Number 1, we have for the first time in the Western zone, we have started a psychotherapy course for all the younger people, because we know though we are lacking in the psychotherapy component at the training levels. And the second thing, we have planned something newly for the zone, making history, because history is very important for the point of view as over the period of time people forget the contribution of our older generation, those who have attributed or those whom we have supported. So these are 2 things we have planned for, and we are proceeding in that. And I think by the end of this month, we will be starting the course in CBT and psychotherapy in association with Indian Association of CBT. And another thing, the history part, we have already tuned the books with all our older and senior peoples, those who know about the history of the IPS OS zones. So detail about whatever other the subcommittee action and all those things will be deliberated by our secretary. And before ending, I pay my tributes to all my teachers, Brigadier MSBK Raju sir, Brigadier Chakrabarti sir, Brigadier Sudarshan sir, and all those people who have framed me and who has tuned me over the years to be in front of you. And I thank all the members of Wisdom for giving me this opportunity. Thank you. Jai Hind, Jai Hind, Jai Shri.
For your inspiring address. May I request all the dignitaries for the ceremonial lamp lighting, but due to the hotel's no smoke policy, may I request the dignitaries to water the tulsi plant kept in front of them.
this is just a teaser, and we will release the book at the Goa during the West Zone conference. And I congratulate all the team members for the active and President Brigadier Raju sir taking active initiative in this process in writing the book chapters. Thank you very much.
At the outset, I would like to thank organizing committee for taking this responsibility of organizing 35th midterm CME of Psychiatric Society very soon. And they have organized this wonderfully, as you all can see. Coming to the activities done by Psychiatric Society of Western Zone till date in this tenure, it's started with the midterm CME, the PG CME at Sion Hospital. The theme was Silence to Science, Navigating Psychosexual Disorders in Psychiatry. This was for PG students in the zone. At Sion Hospital on 13th and 14th of December 2025, organized by Dr. Amar Shinde and Dr. Sagar Karia. Activities for psychiatrists, PG students, and awareness activities for general public. 4 activities each done by Women Mental Health Subcommittee and the PG Psychiatry Subcommittee. 2 each by Art and Cultural Subcommittee, Doctors Wellness Subcommittee, Rural Psychological Health Subcommittee. 1 each by Research Subcommittee, Quiz Subcommittee.
Hosted at Ritz-Carlton in association with IPS Pune branch and the Pune Psychiatric Association, this landmark event centers on a profoundly vital theme: next gen psychiatry, innovations in clinical practice and care systems. As we gather under the guidance of our organizing chairman, Dr. Kendre, and organizing secretary, Dr. Amar Shinde, we embark on a 2-day journey structured to challenge our perspectives, enhance our skills, and foster collaboration across cutting-edge scientific sessions and panel discussion. Pune holds a singular holistic place in the narrative of Indian psychiatry, making it a perfect crucible for a CME focused on the future of mental health care. This city has long been an academic and medical powerhouse, serving as a beacon where traditional medical ethics meets revolutionary clinical progress. From pioneering psychiatry institutional frameworks at prestigious centers to nurturing generations of exceptional mental health professionals, Pune has consistently championed holistic care systems. The city's historical willingness to blend deeply rooted clinical practices with modern psychiatric education has established a legacy of forward-thinking mental health advocacy that resonates across the country. This pioneering spirit is fully alive in our scientific menu curated for the CME, where we transition from institutional legacy to futuristic solutions. Our discussion spans the frontier of clinical revolution, actively tackling breakthroughs through such as ketamine and psychedelic-assisted therapies, non-dopaminergic antipsychotics, advanced brain stimulations like RTMS, and the emerging capabilities of AI and machine learning in predictive psychiatry. This CME deliberately pushes past traditional constraints by exploring digital therapeutics, prescription apps, and virtual reality-based interventions for complex trauma. Pune continues to advance the cause of psychiatry by serving as a testing ground where these highly advanced global technology paradigms are evaluated for practical clinical deployment. Ultimately, the true measure of our advancement lies in how these innovations translate into community care, rehabilitation, and long-term recovery models. Let's draw inspiration from Pune's legacy of innovation to shape a compassionate, resilient, and technologically advanced future of next-gen psychiatry. In the end, I'd like to sum up in Hindi. हम जाते हैं सलाम करके, कई और हमारे बाद आएंगे. CME जब भी ऐसी होंगी, हम आपको याद आएंगे. Thank you.
Thank you, sir, for beautifully setting the tone of the conference.
All the dignitaries on the dais and all the delegates. It's exactly 50 years since I did my psychiatry. So I see more than 5 generations here. So I'm a bit confused about the title. Next generation means which generation? Next to X, next to Alpha, or next to Alpha after next. But the gap between the generations is reducing so rapidly that by the time a student finishes his post-graduation, the new batch comes is a new generation. Now today when I was listening to all the lectures, I realized how ancient the psychiatry was which I learned. And so Many times when I listen to such lectures, I have to request my young colleague to explain it to me. Like an old teacher, so all the next generation psychiatrists have become my teachers, and I look forward to be updated now and then, which seems more difficult. One thing is certain, that with the technological progress, I am worried about the affordability and accessibility of our services to the society. I think we should also take care of the same film about schizophrenia, and I was very impressed how the next generation has caught the language very well. And it's really indeed nice to know, see, because our formal education is completely biased by cognitive development. Because the medium of education is a written word.
CME of West Zone. President Dr. Mishraji, incoming President Dr. Shah, teacher of teachers, and we grew emulating certain ideas and sir, for you, all the dignitaries on the dais and in the auditorium. Greetings from Indian Psychiatric Society again. Pune has a special place in my heart. I came from America, San Francisco yesterday, and after 10 hours, started my journey to Pune for the simple reason that I love Pune. My first visit to Pune was in 1973. That means 53 years ago, and many of you, the new generation, what Dr. Agash was talking about, I think you were not born at that particular time. Possibly even your parents were not romantically involved at that time. So, very long story. And personally speaking, I am a papa case of national integration because Hina Merchant was telling, are you Marathi? Yes, I am Marathi. Born in Karnataka, studied in Tamil Nadu, look like a Malayali, and everybody confuses my name for Andhra Pradesh. So you can't think of, in fact, this type of combination. Yes. And coming to the inauguration of this particular CME, the title chosen is something extraordinary because this is the occasion where we have to look into, as it was been told earlier, the primitive psychiatry, or call it the earlier psychiatry to the modern psychiatry, a whole lot of water has flown. And unless we get used to these developments, we are likely to land up in problem. And Indian Psychiatric Society is very well aware of this, and this is the reason we have technology to many other subcommittees which are dealing with a lot of activities, what we basically call the progress that has been made and how our, what we basically call the human touch of psychiatry, what is necessary to the technology can be wedded and we can flourish. As the president of Indian Psychiatric Society, definitely I need to tell you about few developments that are actually happening because many people ask questions. And as president of Indian Psychiatric Society, I have tried my level best to see that these developments are what we basically call democratic and what we call everybody is involved in range of decisions that have been taken. One important thing is actually this registration which was pending for a long time. We are almost on the verge of being successful. Maybe it will take about a month or two. And second most, because our Honorary General Secretary is here, this unified membership. Many people had doubts, and even here some people are asking whether it is actually going to help or not going to help, and many such things. And I don't think we should be having any doubt on that particular point. It was a very difficult process we have gone through all these years. And now we have reached a stage where you pay at one particular time. Automatically, when you are eligible, you become fellow. And you will become automatically the member of a zone, state. And this type of convenience, it is very difficult to bring about unless we go for this, what we call unified membership. Because of this, what happens? Many people who are eligible to become members, they were not becoming members. Many people who are becoming eligible for fellowship, they were not becoming fellows. And a little bit of small change itself, I think we have added almost about 1,500 members to the society. And my guess is maybe from June 1st, once it gets implemented, my idea is another about 2,500 to 3,000 people should get added.
Diagnosis. So ICD, DSM diagnosis immediately can come with the use of AI. So I think we should integrate AI with the psychiatrist so that we can develop a very good social system for the psychiatry. So today we are in the we stand at the threshold, so we can change this psychiatry into a different new world. So I think this CME definitely will take you to the next level, and everybody will start implementing the things in their own practice. I thank you, Dr. T.S.S. Rao, who is chief guest and President of Indian Psychiatric Society, for attending this program. Dr. Padma Shri Mohan Agashe sir, he was there because he is my teacher, and I think he is teacher for everyone. I sincerely thank IPS Secretary Dr. Arun Malwari sir, PSWZ President Dr. K.K. Mishra sir, and Executive Committee Member Secretary Pai, Abhijit Pai, then Treasurer Dr. Nakul, then Editor Dr. Hina. Thank you very much all your committee. Then CME Chairperson, I thank Dr. Brigadier Jyoti Prakash sir and his team for nice guidelines. I think he was sending everything with AI. So that's how we have formulated our program. A very special appreciation goes to the organizing chairman, Dr. Dharmendra Kendre sir, scientific chairperson, Dr. Himanshu Pense sir, then every member of organizing committee. I think they have done, come on, everybody on dais. So everybody has done a lot work. They have night and day they have together. Dr. Pranav is there, Pankaj is there. They are behind the scene. They are not in front of camera. Even Pense sir is also behind. So they have justified this conference. I think I would request henceforth also every speaker will do the justification for this CME. Also, I thank all the delegates, all the students. There are 23 posters they have presented today. Also, I thank, of course, all these things will not be done without volunteers. So, volunteer, technical staff, Mr. Ketan Bide is there, his whole team. Then hotel management, they are working tirelessly behind the scene. Conference of this scale is possible through the discussions, new ideas, and renewed vision for the future of our beloved profession. Thank you everyone for coming to this program, and I think you will all enjoy the venue, the food, the CME, the lecture, the discussion. Thank you all.
The end of the inauguration ceremony, and I request all of you to stand for the national anthems.
I'm going to speak about prescription digital therapeutics today. Prescription digital therapeutics is not just an app. It's a software that delivers an evidence-based therapeutic intervention. So there are 4 unique characteristics of a prescription digital therapeutics. The first one being it's a software driven. Second, it is clinically validated through rigorous RCTs. Third, it is not for general well-being. It is for a specific psychiatric diagnosis. And fourth, it has received a approval from the regulatory agency. So when we look at hierarchy of evidence, we find at the bottom a lot of wellness apps which are good for general mood tracking and all, but these are unregulated and have got no clinical validation. Higher up, we have mental health apps which have got variable evidence. And at the top, we have prescription digital therapeutics which are cleared by the regulatory agency and which requires a prescription from a doctor like you and me to access these apps. So why do we need digital therapeutics? It is because the burden of mental illness is catastrophic and the conventional treatment, and for the conventional treatment, it is mathematically impossible to meet. So software is something we can scale. So looking at the historical timeline of this digital therapeutics, 2005 was when the boom of smartphone happened, and thereby we started having more and more mobile health apps. 2017 was the landmark event when the first prescription digital therapeutic app was approved by the US FDA. This was Reset, the first app for substance use disorders. And this current era is driven by AI, digital phenotyping, and software medical devices. So, when we look at the ecosystem of these apps, we have a lot of unregulated apps, whereas there are only a few apps which have got RCT level evidence, and only just a handful of apps which have got approval from the regulatory agencies. So how do these apps get approval for clinical use? The first step essentially is if an app or a software does something medical, then it needs to be classified as software as a medical device. This is what triggers the regulation in first place. So once the software gets this level as software medical device software, then there are two pathways. The de novo pathway is the gold standard. This is for truly new, first of its kind device for which the manufacturers or the innovators have to prove from scratch through rigorous RCT of its efficacy and its safety. Once it receives its approval, it serves as a predicate for followers. There comes the 510 clearance route, which is of course the most common pathway. Here, the innovators don't have to prove the evidence from scratch, whereas they have to show that their device is substantially similar to the predicate. All right. There comes another new pathway, which is pre-certified program. This is a newer program in which the FDA it evaluates the company rather than evaluating each app one by one. So once the company passes,
one of the thing in psychotherapy is we don't do psychotherapy for psychotic patient. Unfortunately, we kept the name as psychotherapy. Maximum we do in neurotic patients. So in this regard, we have to change the name. That was the thing when I got this responsibility of doing psychotherapy chairperson at NIMANS. So we should think of changing the name. That was the first thing which came into my mind. But anyhow, we will discuss this later. Now the question came is, what is the role of psychiatrist in psychotherapy? There was a case in South India against a psychiatrist for doing psychotherapy. But anyhow, at the end, at NMC, we were able to convince National Medical Commission telling that yes, psychiatrists are supposed to do psychotherapy. But looking at the evolution of psychotherapy, start from the origin of psychotherapy starts from doctors. If you look at it, it started from a talking cure by a physician. If you take Sigmund Freud, he is a neurologist. Aaron Beck, CBT, psychiatrist. Gerald Klerman, who brought in IPT, along with Menno Wisman, Viktor Frankl. You name, majority of the psychotherapy was born by psychiatrists. If you look at the well-known psychotherapies, 60 to 70% of them is done by psychiatrists. Even if you take grief therapy, like ink blot, Rorschach is not required, but anyhow, even sunset focus, it's by gynecologist. That is William Master and even if you talk about family therapy, Salvador Munchen, again a psychiatrist. It goes on. If you coming back to India, Girendra Shekhar Bose is MBBS doctor. He is the one who founded Indian Psychoanalytical Society, which continues to exist now also. But unfortunately, we as a psychiatrist have moved away from psychotherapy. So this we need to reclaim back. But now the question comes, sir, how to do psychotherapy in a busy private practice? This is one. And also even in a medical college, even Dr. Jyoti Shetty may ask, how can I do therapy in my busy OPD? So let's be very clear. The contemporary psychotherapy does not require 5 years. Brief psychotherapy is the way to go now. 1 to 6 sessions, sometimes 3 sessions. Now there is something called a single session therapy. Like the patient comes, he has an issue where he has a good defense mechanism, but he's in a distress mode. Single session therapies are working very well. Many a time, many patients who come there for therapy, after 2 or 3 sessions, they drop out. The reason is many a time they say, I'm doing well. Whenever the next crisis occurs after 6 months, they will come back. So these are the therapies which are done in 1 to 6 sessions. Now the question comes is it 45 minutes? No. 15 to 30 minutes is the session duration which is being able to do. And now the question comes is, sir, it should be a Western, a modification combining with yoga, Eastern methodology works very well. No, sir, I would like to do a complete therapy session, maybe CBT, 15 to 20 sessions. Yes, it also can be doable, but it requires some amount of dedication and building a psychotherapy ecosystem in our private practice or even in the medical college. If you consider psychotherapy, there are different types of patients we get. Some patients who require only psychoeducation, brief workup. For the second level, who require a psychotherapy which will be around 15 to 20 sessions. Level 3 requires a person who have been well trained in psychotherapy to be handled. Level 1 and level 2 can be dealt at our OPD level, easily doable. Who are those people who can do it? There are N numbers, even a nurse can do various behavioral therapy. A simple activation procedure, what we call it as behavioral activation. We all talk about behavioral activation as a big Western model, all those things. If you look at our Eastern model, what is behavioral activation? You go to Ayurveda doctor, he will say, every morning you have to get up at 6 o'clock, you have to go to the temple, you have to do 7 pradakshina, and then do puja and come back. This is a behavioral activation where the patient feels relaxed or maybe a newer phenomena which arise. So again, behavioral activation is done in Eastern phenomena also. But anyhow, that kind of, we have to come up with a newer interpretation. And in busy OPDs, how we can go about? Either we can have our own videos or videos who have been done by our own colleagues can be used. Prescribing those videos, having brochures. Psychoeducation is very essential when we start psychotherapy. So these sessions can be completed either by giving a simple booklets, Q&A can be given to them. And sometimes the patients are well educated. You can give self-therapy books. These self-therapy books, like best is, I was working in OCD clinic almost 15 to 16 years. We used to suggest brain lock book. that is by Jeffrey Swartz, where we used to tell the patient you have to read the whole book as a novel first time, because many a time OCD patients will be stuck in the first page, so we have to tell them how to read. So we used to prescribe those books. So again, in busy OPDs, we can plan these kinds of things. Now the question comes to, why is it so important, sir, psychotherapy in the era of AI? There are two important landmark Supreme Court judgment. Again, my forensic psychiatry starts working here. Amit Kumar versus Union of India. Unfortunately, two IIT students from a backward community committed suicide. That became a PIL. Next one was Sukhdev Saha versus State of Andhra Pradesh, 2025 and 2026. Landmark judgment was given by the Supreme Court. What did the Supreme Court say? Here it says, every schools where there are 100 students and above should have a counselor, and a referral mechanism has to be there where the child or the adolescent has a mental health issue. So this is a wonderful opportunity for our psychiatrists to start liaising with the school. So that school psychiatry is one which is an upcoming field where we need to work and see how we can work with the schools, colleges, and make sure that 7.5%, that is what the National Mental Health Survey says, 7.5% of child and adolescent psychiatry children have mental health issue. That is from NMHS. But if you look at Dr. Savita Malhotra's meta-analysis study, it says at the community level 7.5%, the samples taken from the school, it is 20%. 20% of the children in the school have mental health issues who require support. If you look at the WHO, it also says 20% of the children who are going to schools have mental health issues. So there is something seriously wrong in our education system, either it is in India or abroad. What is that we need to sit and discuss? So there is an amazing opportunity for our psychiatrists to liaison with the colleges, schools, and see how the referral pattern can be done, how we can handhold psychologists, social worker, nurses to provide support to the children. So these are how we can go about this school psychiatry which I am talking about. I would rather say school and college psychiatry, promotion of mental health in the schools, colleges, yoga, life skills training, emotional resilience, basically recognizing emotion, how to deal with emotion, prevention of mental illness, studying skills, stress management, gender sensitization, sexuality sensitization, substance use, non-substance dependence, early identification and treatment of psychiatric illness. So the whole package can be delivered to the college, training the staff, teaching staff and non-teaching staff plays a very important role. So moving further, so digital psychotherapy, I will not talk about, already the two important topics have been done. And again, telepsychotherapy can be leveraged. Don't believe only in-person psychotherapy or only telepsychotherapy. It is the combination, that is, we have to choose hybrid. The patient can be started with in-person psychotherapy, slowly shifted to telepsychotherapy, or if the patient can be on telepsychotherapy, slowly can be shifted to in-person. So this is based upon the requirement. But another very essential psychotherapy which is missing in our population is group psychotherapy, where majority of our population who requires support is in group psychotherapy. Group psychotherapy, do we require a huge amount of training? No. Group psychotherapy, invariably the therapist will act as a moderator than the psychotherapist. But anyhow, and also the next important comes is which is revisiting.
And allow me to present Mastishk, the Brain Wellness Super App. So imagine suffering from a severe chronic illness. Instead of receiving empathy, the society shames you. When you try to get help, finding a doctor takes months. Finding a good doctor takes years. Your insurance refuses to cover your bills. Your family is forced to navigate a confusing legal nightmare to keep you safe. Mental health disorders are rising on an alarming pace, yet millions of Indians are suffering to get access to proper care. Today, I'm not presenting to you just another app, but I'm presenting to you a solution to one of the biggest silent epidemics which affects 150 million people in India. Before I move on to the topic proper, I've been doing psychiatry for 15 years, but for the last 8 years, even before telepsychiatry came, a patient suggested that I do telepsychiatry. Only then did I realize the issues. To get a doctor, get a booking, get medication, honoring of prescriptions, insurance, it's a huge headache. So what is Mastishk? It is India's first mental wellness super app and aggregator. It is a one platform, one ecosystem where you have access to the entire mental health care journey. What is our USPR? Unique selling point. Privacy, accessibility, and a pan-Indian reach. What are the 5 pillars of Mastishk? It is an ultimate aggregator which brings everything under one roof with the absolute privacy, luxury, and safety of your own home, where the patient gets a 360-degree solution in just one click. So, what are the 5 pillars? First is medical access, where we onboard psychiatrists, psychologists, speech therapists, occupational therapists for a seamless telehealth and home consults. What is the second pillar? It is hyper-local pharmacy, where we aggregate online and offline pharmacies to ensure discreet, rapid home delivery of critical and hard-to-find medications. The third part is financial inclusivity for healthcare insurance. We partner directly with health insurance companies so that you get mental health coverage. And fourthly, the fourth pillar is legal empowerment, where we onboard mental health savvy lawyers for providing immediate counsel on admissions, certifications, advanced directive, estate planning, and guiding families through the darkest hours. The last pillar is the rehab marketplace, which is totally confusing. So it's going to be a very transparent aggregator for rehabilitation, de-addiction, long-stay homes, allowing families to compare, review, and choose the best facility with a total peace of mind. What is the business viability and scalability of this model? Mastishk is a high margin, asset light B2B2C, which is business to consumer, marketplace aggregator with a pan-Indian reach. Our revenue model is highly diversified. We generate revenue not just through commission on professional consultation and pharmacy, but leads through generation fees from insurance and legal partners and a marketplace fee for a rehabilitation facilities. What are the key advantages of this model? It is not a single thing reliant, stream. Diversified, not reliant on one stream. Recurring, which is refills, follow-ups, subscriptions. Defensibility. It is a full patient journey from therapy to meds to insurance to legal to rehab. So there is huge switching costs, so you can retain the patient. So it is basically a high growth, sustainable business in a booming sector with more than 18% CAGR. So we scale profitably, delivering value. So we have the entire problem. So instead of tackling just the entire problem with online therapy, we unlock a lifetime customer value, which is about 5 times more than any other mental health app available. So instead of being just a comprehensive healthcare aggregator, we want to ensure us to be a specialized practo, where we add doctors, consultants, etc. A specialized 1mg, where you get medication, insurance aggregator, where you get policy bazaars like stuff, plus things like legal, rehab, long stay support. So while others offer pieces of the puzzle, we assemble the entire puzzle into a seamless private pan-Indian existence. Some pieces of the puzzle like WZB give AI support, Your Dose gives counseling, Practo books doctors, 1mg delivers medicine, but ours is the only platform which assembles the entire puzzle into a seamless private pan-Indian experience. So finally, Mastishk replaces fear with convenience, public stigma with absolute privacy, and chaos with single trusted platform. We are not just launching an app, but we are building India's missing infrastructure for brain wellness. So if you're interested, invest in Mastishk. Let's bring healing, dignity, and world-class care to millions of Indians across India. Thank you.
Thank you, Dr. Vivek, sir, for informing about these innovations personalized to psychiatry. May I please invite Dr. Karanskar, sir, to felicitate Dr. Vivek.
I will be speaking on why social media for psychiatrists, why to do it, the value it carries in your day-to-day practice, the value it carries in your brand building, in your credibility. After me, it will be Dr. Rashi who will be speaking about how to do it, the tips, tricks, the elements. And then there are certain guidelines, there are certain rules and regulations made by our respective National Medical Council, the ethics, that what not to do. So I'll start quickly with why social media for the psychiatrist. Why do we need to do this? We have done this workshop in ANSYS this year. We have been doing this in many places in the country. So is it a need or a necessity? 10 years back from now, the number of people on social media were around 1.5 million. Now it is 10 million, 20 million. Everyone is there on social media. And has become from a need to a necessity. Previously, out of 100 practicing doctors in the hall, 10, 20, 30 were on social media. Now it is vice versa. 10 are not on social media. 80 to 90 are. So I think it has become a necessity. Why are we doing this? Who are we doing it for? First priority is our existing patient. I talk about credibility. A patient of schizophrenia comes to you, consults you, walks out of your chamber, types on YouTube, Google, WhatsApp, chatbot, wherever, even ChatGPT, your name and then schizophrenia, or schizophrenia your name. A video should pop up there. A content should come up there. And if that content has come up by some other doctor, that is not credible. It has to be. There are 20 to 30 psychiatric disorders which we see in day-to-day practice that are 90% of our psychiatric diagnosis. It takes just 1 day, 2 days, or maximum of 3 days to build up those 20, 30 videos so that your existing patient get confidence. So our existing patient confidence is the first priority why we are doing it. Then second is to get more patients. Yesterday a patient consulted to me, sir, I saw your video on acromegaly. The ChatGPT told him that he is supposed to be acromegaly. I made these education videos for students, but it is seen by patients. A day before yesterday, a patient consulted, I saw your video on ADHD and I want to consult for my child. Yes, we do get more patients. For our friends and family, when you share these videos, all of us are not from medical background, or even if you have a medical background, we have people in different branches who would like to hear from you about your branch, about your patient, about what you do. Yes, our friends and family are the people who are seeing your content, who are seeing your online presence. For general public information, mental health awareness is a part of a psychiatrist. If you will not speak about psychiatrists, we are not mental health influencers, we are influencers. We are supposed to educate. And like people say, rationalizing, attention seeking. You are doing this for attention seeking. Even if it is, we are okay with. Little bit just a big plus. So omnipresence. Where are we supposed to be present? Social media presence is omnipresence. These are the 7 areas where you have to be present. And I have arranged them in order of priority. What helps most in the practice? Number 1 is Google. Understand, Google is not just available from Google Map. Google Map, Google Profile, Google Reviews, everything matters. Everything matters. Even the ChatGPT sources its information from Google. And second in the line comes Instagram. Instagram is second in the line. Facebook is sixth in the line. You check it out. The number of Instagram users are far more than the number of Facebook users. And the patients who are consulting, you are checking. Third comes YouTube. Fourth comes your own website. Your own website gives you a lot of credibility. I explain each and every one. But I would like to know, are there people who are present on only channel? If I ask about 100 psychiatrists in the house, how many of you are present on all the 7 channels? 1, 2, 3, 4, 5, 6, 7, 8, 9. 10%, less than 10%. And omni-channel presence makes a difference. Makes a difference. You are searchable. Every particular channel has its own significance. I talk about Google profile. Although my number of reviews are less because I have changed the location, but why Google profile is required? Why Google profile? It is essential for every practitioner. Google Maps is the most commonly searched location tracker for you. It is a review-driven market. Yes, we are commoditized. We are rated by reviews. Just like any other person, we are also rated. This doctor has better rating. And now I have started using AI for Google profile optimization. I have listened to a few of lectures. So how I am using AI for Google profile optimization? There is a tool called Rexa, which I am using. So what this Rexa does, I have made my own WhatsApp chatbot who takes care of my queries and answers the patient when I am not available. And this Rexa optimizes that in your area, I practice in Dwarka, people are searching psychiatrists near you. So that tagline, whatever they are searching, should be available on my Google profile. This is done by AI. What is the most common search thing? What is the doctor most common sought after? People don't search for psychiatry, people search for their problems. The most common search thing is I am having premature ejaculation, I am having erectile dysfunction. So So you have to mention these keywords in your profile. And who will tell you what to mention? AI will tell you. What are the people searching for? And we are doing this Google profile optimization using AI. Then I talk about Instagram. When I talk about Instagram, you must be knowing that the younger generation of population is more searching you on Instagram. Instagram is the only platform where you don't have.
And you're like, okay, why is she here and why is she telling us about all this? So, I'll just quickly tell you about the types of content and platforms about how and why we are covering this. So, a lot of you would have seen a lot of short form videos, which are reels and shorts. Long form videos, as Sir discussed, are on YouTube. Written content, a lot of us are good writers, listeners, storytellers, so we also write well. And again, live content. Lot of people like to go online live where they are like, okay, I'll take up questions and queries of people in the real time and they will be satisfied after that. Coming to content creation, people come and ask, I'm actually not a content creator. How do I do it? Content creation is not something uniquely different or like I need to learn about it. It is just the knowledge we have and we are willing to share it with everybody. We are very close-knit circle, so we feel that everybody probably might know it, but that's not actually the case. So quickly discussing all the platforms. So Instagram, a lot of us are aware about it and are using it. Used mostly for posts and for videos. YouTube mostly for shorts and also long form content. Mostly queries are about LinkedIn. Initially, I think probably when we were studying or when we were graduating, post-graduating, we would have heard this term LinkedIn from our IT friends. And they're always like, okay, I got a job from LinkedIn. Okay, I connected with my seniors on LinkedIn. But we have very rarely seen medical professionals using LinkedIn. It is a very, very big untapped resource and can do really, really wonders if you can and do right well. So I really encourage a lot of people, whoever I meet, whatever thought you have, if it is socially and politically right or at least suitable in the sense that it can be put out on a public platform, please do it. This is a very rough overview of my LinkedIn profile. So basically, if anybody comes to it, so they can know what I do. So it says I'm a psychiatrist. I'm a mental health educator. I have these many followers on Instagram. I have founded this and this. And these are the societies I head. And this is what I've got. So this establishes me at least an expert in my field and also adds some credibility that across platforms I'm also available. Also that I have a little bit achievements here and there which adds to my credibility further. Again, why should we do it? There are a lot of companies, lot of corporates, lot of magazines and newspapers which find and want credibility. So generally they don't pick up people from either Instagram or Facebook or YouTube because they feel that they cannot verify credentials. But they pick up people from LinkedIn because they can easily verify where you work, what kind of expertise you have, and actually what you are doing. I'll quickly go over AI. How many of us are using AI for any kind of, I would not say patient seeing, but content creation or just like for our queries? Any kind of. And what is the most common one? Anybody would like to tell me? What is the most common AI platform? Meta, because I think it's on our phone and we don't need to log in into a laptop or a bigger device. I have been using Meta for a pretty long time, again because it's on the phone. What I have felt in this, recently Meta has seriously upgraded itself. So if I would say even just 3 months back, you would write something on Meta and you are like, okay, can you rewrite this for LinkedIn for me? Or can you rewrite this? I'm not saying asking it to give you original inputs, but writing something and asking it to rewrite it for you. Initially used to give very crude answers, or I would say that were not publishable. This is a very recent screenshot that I had. It gives such precise answers and says, you want me to also make a shorter, punchier version for more engagement? Like LinkedIn algorithm usually rewards posts under 1300 characters. Imagine it knows what you are doing and how you can be better. So this is just one of the things I recently noticed. I thought would share it with all of you. Meta is seriously improving. If you would write more things, like if you would Write a patient query, for example, my patient is so and so suicidal. Or if you would want to write something about self-harm and suicide and you want to quote it in the sense, I feel this, it would stop answering you. It would not give you answer, it would say sorry. So this is how they are upgrading their policies because it does not differentiate if you are making content or if you are actually seeking help. So this is a plus thing and a recent change that I have generally noticed. Again, coming back to the first question that I started with, why do we want to do it? What is the benefit and how will it benefit me? A very, very simple milestones which I feel I would not have achieved if I was not doing content creation, which was being awarded by big newspapers, companies, having big corporate talks, and also big recognition in the community, which generally does not happen, especially in tier 2 and tier 3 cities where people are not aware about mental health issues. So forget about being aware about psychiatrists where people are not even acknowledging it. And this is something we all are dealing with day in and day out. Quickly going over, these are stats. A lot of you would not have gone into your algorithm. If you would post anything, you can go under these stats and check what is my audience. Though I put a lot of feminine-centric content, a lot of my audience is males and somehow they don't run away still. So they also somewhere connect to that. What is the actual timing that I need to post? This can be specific for whatever content you post. You can go under your post and check it out. What is the reach that I'm getting? I'll go into further intricacies and I would love to discuss if anybody wants to personally come and show this to me. This is how we check performance for any of our reel or any of the posts that I have done. Which is a good graph, which is a bad graph. Ideally, we need graph 2, means people are coming to your page, seeing it and staying there. The algorithm awards staying rather than number of repetition and views, which everybody is after. Retention is the key rather than the views. I would just like to quickly wind up with saying again, question 1 again, what to post? I don't know. I'm not a content creator. मैं करूँ क्या? I'm so confused, I don't know where to start. You have the answers within yourself. You have so many mental health concepts, you can just keep on making video about things as simple as anxiety and depression. Clinical pearls are practical insights, any case-wise learning without giving patient details. Compassion, in the sense, making it more empathetic and separating, I would say, the medical from the illness. Conversations, be like, okay, how many of you think this is A, B, and C?
Speakers have said that we have solution to the problems that people cannot even name. They don't even know what this thing is. And we are the ones who are solving those issues day in and day out. Now the only problem is they don't know we exist, we don't know they exist, and that is why social media is important for our visibility. Otherwise, there are a lot of life coaches, healers, practitioners who are doing the same thing under the name of mental health, and that would do more harm than good. But then we say with great power comes great responsibility, and that is our responsibility when we are there as content creators. I would like to reiterate what Dr. Sachin sir said, that we are not influencers. The point of influencing somebody is that telling them what they should do without letting them know what is good or bad for them. What is good for you is what you're making them do. You are selling them a product by influencing them. But that's not what we are doing. What we are doing is we are providing information about mental health, scientific, verified, research-backed information, so that they can make better choices for themselves. And that is why we are supposed to be influencers. So psychiatrist's voice is needed online because we all have been fighting stigma for years together, and I think we would be fighting stigma for years coming ahead. We are combating a lot of misinformation. Anybody would just come and say something about mental health, something about anxiety, something about depression, and we are like, ab ye raita hame sametna padega because this is too much, and people would want to believe those things also. We also want to build trust about our community. You all must have seen some patient coming to you and saying ki आम्हाला या सायकॅट्रिस्टचे ट्रीटमेंट जमत नाही, आम्हाला यांनी सांगितलं हे बरं नाही, ते बरं नाही, दिस इज नॉट गुड फॉर अस, दॅट इज नॉट गुड फॉर अस, या गोळ्यांनी झोप येते, या गोळ्या आयुष्यभर घ्याव्या लागतात, we'll have to take these medicines lifelong. So we have to build trust in patients, and we have to combat these myths that people have and educating the public. But there are certain things that NMC says. everything that you are doing offline in your clinic applies online as well. So whatever ethics, do no harm, is one of the basics of medical ethics, right? Compassion, autonomy of the patient, doing justice to the patient are basics of mental health, but more in postpartum women because they have had childbirth. I feel does not apply there. I have to know that there is a research if I'm saying something because I am the person that they trust to know what research is and how to read that research. So I cannot go and give I think, I feel kind of statements. I can cite researchers saying that this study has come up in Indian Journal of Psychiatry, and as per this study, we have found that this is common. Second thing, we are doing public health education. A lot of people don't even know what are symptoms of depression, what is anxiety, right? They are experiencing it day in and day out, but they don't know how to name it. So it's our job. You know, one of the most common question, one of the most earliest question that people will come and ask you, how many of you have been asked this? What is the difference between a psychiatrist and a psychologist? Right? People, we have something called as, we have a bias, a knowledge bias. If we know something, we think everybody knows this. But then things start from as basic as what does a psychologist do and what does a psychiatrist do. And that is generally the first video that we should go out and make. And it is very important to stay within our own expertise. We would not want a gynecologist to come and talk about post-stroke depression, right? We would not want a physician to come and talk about why the medicines of erectile dysfunction are not good for you. Because we know that everybody should talk about their expertise. I cannot go out and talk about what should be done before a kidney transplant because I don't know about it. So we need to know what is our expertise and we need to hold our branch together, our data set together because there's so much work that developmental pediatricians are doing, there's so much work that neurologists are doing, there is so much work that physicians are doing. So we need to know that we are talking about our field of expertise because that shows our confidence when we talk about it. And there are certain things that are a big no-no. No public prescribing. You cannot tell somebody in the comment section that it looks like depression, take fluoxetine. No, you cannot do that. No public prescription, and no public prescription also means that you cannot send them medicines in their chat box. When they DM you that my psychiatrist has given these medicines, is it okay for me? No, we are not handling it there. No patient media. Now NMC says that you cannot even post before-after pictures. You'll see a lot of pediatricians sitting with the patient and uploading that video of how the child is smiling. But that is violation of patient's privacy. How many consents would you keep in your clinic if you are posting about your patients? Even an X-ray, if it is uploaded, it becomes a public, once it's on social media, it's a public domain and anybody can take it and do anything about it. So it's a big no to post anything about patient. No case discussions. Yes, we can educate the people. And if some people are uploading case discussions, but then you put in the in your caption, you put somewhere that disclosure, this is a modified case or this is not patient confidential, it is maintained while I'm discussing this case. A lot of people feel that jitne zyada followers honge, utna acha lagega. We all have this sense of importance that we feel, so we'll go after followers, we'll go after how many views, what is happening. When you start creating content, this phase would automatically come at some time point. But NMC says you cannot solicit patients directly or indirectly. आप patient खरीद नहीं सकते. आप जानबूझ के अपनी advertisement patient के पास में भेज नहीं सकते, so that brings you patients. So that is not allowed. Getting impressive, posting about only impressive results, only testimonials ki what good I have done to the patient. No, that is not allowed. You cannot purchase or manipulate the algorithm, and you have to maintain the decorum. Social media is the digital doctor's lounge. So the way you would communicate with the doctors in your fraternity, in your medical college, in your workplace, that is exactly how you are supposed to communicate with others. That is exactly how you are supposed to talk to them. They might be from homeopathy, they might be from Ayurveda. If I don't know, I am nobody to comment on this. Maintain the decorum. So in public place, we can create awareness, but we cannot do individualized patient care. In public place, we can have we are a public person, but when somebody comes, we need to know that they are coming. If you are seeing somebody on telemedicine online, we need to know that this is a verified person and I am a verified person. Strictly no prescription, diagnosis or prescription are only allowed in telemedicine and consent has to be taken. It's not applicable on social media. What to do when patient texts you? You are not soliciting the patient if patient is directly coming to you, because that is an implied consent. You can send them the link to your online consultation or address to your clinic or number of your assistant कि आप इनसे बात करके अपॉइंटमेंट ले लीजिए, मैं इस दिन पे आपको डॉक्टर मिल जाएंगे. But you cannot tell them, you cannot see them in the chat box. Somebody would text you कि नहीं अभी मैं suicidal हूँ, the first thing I do is 14416 टेलीमेडिसिन का नंबर है, टेलीमेडिसिन पे कॉल कर लीजिए. If you cannot afford, then go to nearest government hospital. If you can't go there, I'll ask where you are from. I'll recommend them. सूरत में ये डॉक्टर है, इनके पास चले जाइए, मेरा नाम बता दीजिएगा, मैं इन्हें जानता हूँ. So we have to protect the therapeutic alliance online as well, क्योंकि आपको देख के पेशेंट आपके पास आता है और आपके पास आने के बाद पेशेंट आपको जाके देखेगा. So patient would go back and search you. So again, we cannot talk about patient. The patient would see the content, and if I'm saying today I saw a 28-year-old female with depressive disorder, she would say he's talking about me, and the patient would feel cheated. So we can't do that. What happens if there are missteps? In case we are doing anything wrong, then NMC says that there can be permanent removal happening from the register. So far this has not happened to anybody, but 10 साल की degree is not worth a like, worth a follow, worth a patient. So we spent 10 years to get the degree of MD DNB. So please don't do anything that would make it worse for you. What is the checklist? Does it protect the patient confidentiality? Is my information verifiable? Is it professional? Does it uphold the dignity of me, my profession, and medical field as a whole? And what is the purpose? Why am I posting it? Is it to gain patients or is it to inform the people?
To our beloved Dr. Nilesh sir, who promised me he would be here today. And he advised me, he gave me some of his tips, his style of delivering, so it might reflect today in some manner.
Short and critical information between medical professionals. So instead of telling a fellow colleague that, I saw a patient with hyper-religious behavior, hypersexual behavior, singing and dancing, disrupting the entire household, spending a lot of money, I simply can tell my colleague that, I saw a patient with bipolar disorder today. And my fellow colleague sitting in the UK or US or Canada, they will understand. That's the strength of DHL. It categorizes and classifies mental illnesses in such a way that patients with similar symptoms they can be grouped together for the purpose of clinical research and formulating treatment guidelines. But however much internet reliability and use of contextual exchange DSM offers us, there are certain trade-offs. Most important one being the DSM categories, they are broad and heterogeneous. So let's take an example of a triangle. When we speak of a figure with 3 quarters, automatically a triangle comes to mind. But not all triangles necessarily need to be the same. They have different shapes, different sizes, different angles, different symmetry. Yet they are all brought together under one label of triangle despite having different properties. Similarly, when we talk about 2 patients having the same psychiatric illness, let's say schizophrenia, they might differ enormously with respect to their psychopathology, their cognitive vulnerabilities, their trauma response, their treatment response, their functional decline, their genetic coding. However, despite this, they are somehow pigeonholed under one common heading of schizophrenia, despite the fact that their illness trajectories might be completely different. And that's why we have to introspect here a little and ask ourselves the real question: is psychiatry becoming too diagnosis centric? Or rather, has it become too diagnosis centric? So, like I said, as per the guidance of our beloved psychiatrist Dr. Nilesh sir, I took a case-wise approach and I have discussed a few real clinical cases that I have seen. First case, the 22-year-old who fell one symptom short. So this was this 22-year-old woman who was brought by her mother to my clinic with 10 to 12 days history of significant social withdrawal. She was staying isolated and alone at home, interacting minimally with family members, and refused to go to work. Sometimes she was also noticed to be crying alone, and this all started after there was a significant interpersonal stressor, interpersonal disruption, and some work-related mistakes that she had committed, and she had some political tiff with some senior, and all of this resulted in her having autoimmune symptoms. Now, this girl's sleep was okay, she was eating well, her self-care was intact, she had no history of substance use or any self-harm ideas or any family history of psychiatric illness. On her mental status examination, what we noticed was she had somewhat reduced psychomotor activity. Her affect was sad and constricted. She reported anhedonia. What was noticeable was her marked preoccupation about the worries and guilt related to the mistake that she had committed at workplace. Otherwise, there was no perceptual disturbances or thought disorders. Now, this patient has depressed mood, anhedonia, a reduced psychomotor activity, and guilt. She meets 4 out of the 5 required DSM diagnostic criteria for depressive disorder, major depressive disorder. What do we do now? Do we diagnose her anyways and start her on treatment, on the appropriate treatment, or do we go on to say, hey, I know you need help, but I can't treat you. You're probably depressed, but then you're falling one simple criteria short. So maybe come back later when you're over. Do we do that? No, we don't. Most of the clinicians here, we would intervene. We would look at something beyond that checklist. We would go on to look at the distress, the impaired social functioning, the occupational functioning. We would look at her comorbidities, her pre-morbid adjustment styles, the coping skills, and so many more things. And we would treat this patient. Hence, somewhere in our clinical thinking, we are already taking psychiatry beyond the different diagnostic categories using some molecular approaches or models or systems in place. What are these models? So what lies beyond DSM? Now, traditionally, most of the psychiatric illnesses, like schizophrenia, anxiety disorder, substance use disorder, bipolar disorder, they have all been looked upon as some neat categories with very clearly defined borders, which are mutually exclusive categories. And this results in a binary approach, a yes-no approach. So a patient is assumed to either have a mental illness or doesn't have a mental illness. Lately, we are realizing that that is not the case. So here comes what lies beyond DSM, the trans-diagnostic dimensional approach. So the modern trans-diagnostic approaches, what do they say? They propose that psychiatric illnesses are not concrete, they are rather dimensional. That is, the psychopathology, the symptoms, they lie on a spectrum, on a continuum from none to severe, from mild to extremely impaired, and they cut across the different DSM diagnostic categories, that is, they travel across the categories. And even in the general population, these symptomatologies can be present as regular phenotypes. This is the modern transdiagnostic dimensional approach that we will be discussing further. What are some of these models? One of these is the internalizing and externalizing model. I think it's quite old and it has been discussed a few times, but still I would like to brush up. The internalizing, externalizing model, what does it say? There are certain internalizing illnesses like fear, sadness, anxiety, some of these symptom dimensions are there. Certain are externalizing, like the substance use problems, the personality disorders, the conduct issues, ADHD, etc. So this is a very simple model, but on the basis of this, what they found was the HITOP model, the hierarchical taxonomy of psychopathology model. Somewhat complicated it appears here, but what they have done is, modality, they have categorized symptoms, certain symptom dimensions with internalizing, externalizing, those with thought disorders, including psychosis, those with detachment and somatoform disorders, something on those sorts, and they're talking about symptom dimensions at a hierarchical level, coming from less severe to more severe. Going back, there is also the RDOF framework, the research diagnostic criteria, which is being developed in the UK, still in evolution phases. This is less into clinical usage, more into research usage, but still it is talking about what we are discussing. It has 6 domains. The positive valence, the negative valence domain, the arousal and regulatory domains that talks about circadian rhythm and sleep. There is the social processes domain, there is cognitive domain and sensory motor domain. So these domains have certain symptoms which are measures in the limits of analysis. And it again measures psychiatric illnesses on a spectrum. There is also one clinical staging model. So what does this model say? Like we know, diabetes evolves over time. Cancer evolves in multiple stages. So the clinical staging model, especially for depression, it has been studied a lot. What does it say? That depression doesn't develop suddenly overnight. It usually evolves as a trajectory, gradually, in multiple identifiable stages. So the important word is identifiable stages. And what they say is that early intervention in one stage can prevent it progress to another stage. How does it progress? We clearly see stage 0, there is an increased risk because of maybe family history or the social circumstances, but there is no symptom. And stage 1 having some suppression symptoms and you progress towards more severe chronic and resistant depression. Now, when we discuss this case, on the clinical staging model of depression, clearly she is in stage 1 and she is progressing towards stage 2. And that's why, like we discussed, an early intervention at this point can prevent progression to further stage, and that's what we did. We started this girl on 20 milligram of fluoxetine. However, after 1 or 2 weeks, we noticed that she was getting more withdrawn. She was more confined to her room and her guilt now increased to almost delusional level. Now, in our clinical settings, like I said, it functions very differently. When you see a patient, you have this hunch. You might call it experience over years, but you get this hunch that this patient might worsen, and that's what I did. When I saw this patient in 1 or 2 weeks, there was this hunch that she might become suicidal or might progress there. And that's why I suggested modified ECTs to the family. And surprisingly, they agreed. For a 22-year-old unmarried woman, they agreed for modified ECTs. And within 6 ECTs, voila, there was dramatic improvement. Her withdrawn behavior was gone. She was more communicative. She was smiling and laughing again. And she herself expressed a desire to go back to work that she was ready. And later, interestingly, one of her sessions, she revealed that she was having written suicidal ideas. Repeatedly, she had these thoughts to kill herself, but she did not reveal them to us. And this case, that's why illustrates to us that psychiatric illness does not itself announce it in weak cases diagnostic categories, but rather early suppression symptoms might present to us, which might progress over time unless we intervene. Initial pharmacotherapy may fail. Be prepared to go intense, be prepared to be aggressive. Trust the clinical knowledge, the clinical decision that we have, and suicidal ideations may be concealed, but they are revealed over longitudinal follow-ups. Moving on to the next case. The 17-year-old at 2 crossroads. A 17-year-old student, he was brought to us by his parents with 1 month history of some irritability, some restlessness. There was this persistent overthinking, and all of this started after there was an abrupt online ending of a romantic relationship he was having with some girl for the last 5 months. So lately, there is a lot of online stuff happening, and people are actually getting romantically hooked and dating online. So this boy had never met the girl. They were just talking and chatting and video calling online, and suddenly one day she decided to block him or delete him or something of the sort happened, and he simply could not trace her. He reported that he could not sleep, he could not eat, he was not feeling like playing badminton anymore that he used to like, and he was constantly feeling mentally exhausted. This boy reported that my confidence is completely gone now, but he kept going back to these online platforms and communities to try and trace that girl again. He was having this hope that I will somehow magically find this girl. His mental status examination revealed an anxious affect. He had anorexia, like I said. What was noticeable was an odd pattern of speech, an odd pattern of communication. He had some differentiality was there, and there was a childhood history where they reported that as a boy, this child was always an eccentric person. He wouldn't like to have many close friendships or relationships, and he stayed to himself and would like to stay on his own. And there was a strong family history of psychosis in 1 secondary and 2 first degree relatives, including father and elder sister, both diagnosed as schizophrenia. So, here there are 2 possible illness trajectories to this boy. Let us look at the first one. Clearly, there are significant anxiety and depressive symptoms. We have seen that. Now, at different consultations in our OPD or in consultations with different psychiatrists, this patient might be diagnosed as having a generalized anxiety disorder, an adjustment disorder, mixed anxiety depression, panic disorder, or even a frank involving depressive disorder. This is because this picture is pretty common in our clinical practice. We have seen this overlap between anxiety and depression because they share a common underlying genetic vulnerability. They share a common underlying emotional vulnerability. The mechanisms are very common. That's why they all transition also into one another. When we look at the second possible trajectory of this boy, now given the strong genetic coding for psychosis, the odd and eccentric persona, and a rapidly deteriorating functionality, the criteria which are required for declaring this boy as an ultra-high-risk state of psychosis. So, when we go by the clinical staging model, this boy is somewhere falling on the stage 0 to stage 1.
Yes. They are human beings and they are showing the dimensions. So, go for this. Okay.
psychosis. Even if the person is at risk of psychosis, can we prevent to develop psychosis?
So there is a lot of literature that is that. You could have dealt with the situation by saying, listen, I'm the expert here, so let me make the decision. But now we are in the era of AI and technological advancement where handling this situation might look different. So here, as we are seeing from the morning that how AI plays a role in not only screening, diagnosis, management, digital phenotyping, long-term management and care, we are also seeing that how AI can be used as an integrative tool. So the question is not whether AI is going to replace us. Certainly not. We don't see AI as a threat. In a country like India, which has a huge treatment gap, we know how mental health services are so scarce, especially in certain parts of our country. So here, optimizing AI to reach these individuals is definitely a gain. But as we go ahead, and as the world of AI is advancing so much, it brings a question to our mind that what implication can AI have on our identity as psychiatrists? So here I want to focus on the word identity, because identity and role are different things. So when we talk about role, it is skill-based, it can be replicated, and skills can be learned. But identity is something that you build, you develop, and it includes and goes beyond your clinical expertise. So here, we all are psychiatrists, we play the role of psychiatrists. But our identities, each one carries a different identity. What can keep the human touch and relation intact? When I try to think about this answer, I find it in moments where I can hold a space for an individual. I can hold silence without having any discomfort for it. The ability to be deeply empathetic is human. The ability to understand socio-cultural nuances, the complexity of an individual is human. The ability to see the person for what they are is human. And sometimes, when most of the things are beyond our control, beyond the individual's control, it is not about finding an answer, but rather it is about providing a support and being a team member to that individual, which is human. So, when I hear patients saying that this is the first time I have told someone about this particular thing, I think that is something that I really cherish. So, before I end, I would like us to leave with a question that in the evolving era of AI, where we know that coming few years, we don't even have to wait for 5 to 10 years. What we are going to see in the next to 10 years, 2 to 3 years, is going to change the landscape of mental health care. So while this is so rapidly evolving, going ahead, what is going to keep us doing what we do? And what is it that we are going to uniquely bring to the person in front of us? Thank you.
So whatever you do in family interventions will count as innovation. Okay, so with that deflationary talk, let's move on. Typically, when we talk about ADHD, the diagnostic systems always talk about inattention, hyperactivity, and impulsivity, and of course about impairment. But what the parents really care about is, one is grades, second is behavior at home and behavior away. Now, this is extremely important part for the family, because how the child is in school and at home and in front of other people is a big issue, a big ego boost for them. Of course, families care about routine, because in most of the families where both parents are working, it's an urban or semi-urban setup. well, these are the patients that you're going to see anyway as child psychiatrists. They have a fairly busy schedule. Particularly early mornings are quite crazy at any home. So any child who gets ready quickly and catches the school bus on time is seen as the best child in the world. Obviously, once they come back in the evening, they are supposed to look after themselves, attend all the tuitions and all other developmental programs that parents have so carefully arranged for them. Then be nice to parents when they come back home. Obviously, eat the nutritious food, then sit down and study for whatever hours that is possible. Say good night to everybody, do their sanskari bit, and go to bed. And this is what they should continue doing day in and day out, 7 days a week, 365 days a year, for just about 20 years, and you are a decent child. So routine is obviously highly important for family. Any factor that will disrupt this routine and make their work difficult is going to cause problem. And obviously they want peace of mind. So Indian families' peace of mind comes from two sources. One is हमारे बच्चे के बारे में कोई बुरा ना बोले, and second, the child periodically gives us things which we can be proud of, which can be put on Instagram or somewhere where we can portray ourselves as a big happy family. Now, are these unreasonable expectations? They are really not. I mean, we can mock at them, but all of us are going to go home and do exactly the same thing about our children. I just found myself praising both of my daughters outside, though they are like 20 and 25 now. It is still a parental pleasure to say nice things about them, especially when they are true. So this is like a basic average expectation of any family. They don't care about impulsivity in attention, etc., etc. So instead of getting that beautiful family picture, when you have a child with ADHD in the family, what parents end up getting is essentially chaos. Okay, they get a lot of emotional conflict at home. They get occasional explosions that happen in their house, and everybody now living in shared complexes, buildings, etc., etc. The noise going out of their home and other people coming to know about it kind of becomes a big problem. Sometimes children, not sometimes, but almost always, children are very smart, and they realize that parents are extremely sensitive to this dressing down in public. So many children initially threaten the parents or have those explosions in public. They very quickly realize that if your parents are under threat in public, they quickly cave in, and then you get what you want. So essentially, children start doing behavior therapy for parents via very extensive negative reinforcement schedules. And then these explosions start happening everywhere, and parents start running from pillar to post. And obviously, at the end of that, by the time they reach you, it is emotional exhaustion. Most of the times, you must have realized that first 1 or 2 sessions are there just to contain the parents' distress before you can actually reach out and try and help that child in any way at all. This is really the core issue there. No ADHD criteria talks about emotional dysregulation, but every psychiatrist worth his salt knows that in that particular nervous system, the way it functions, the biggest difficulty actually lies in their short-term memory or working memory and their emotional regulation. These are two things which make things really, really difficult for everybody. As far as short-term memory is concerned, yes, there are exercises that can be put in place. There are medications that can stimulate the brain in a specific way and help the child settle down. But there is really no highly effective medication for emotional dysregulation. Yes, you can use SSRIs in certain children. Guanfacine, which is not available in India, is supposed to be a wonderful drug. You can use clonidine to a certain extent because it is going to tone down the autonomic nervous system and actually reduce this problem. But when you look at it closely, emotional dysregulation does not remain the child's problem. Because of the stress and inability to handle the situation, you see a lot of emotional dysregulation happen in the family as well. And particularly when everybody's emotions are on the boil, child's whatever remaining prefrontal cortex that is there gets overwhelmed, and then things go even more wrong. And then that sets up a cycle. And all of these families have a periodic meltdown, either every week or every 2 weeks or every month. Typically, when it starts happening more frequently than once a week, that is the time when they have reached you. So though we are talking about emotional regulation in children, the family work is essentially about emotional regulation of the entire family system. So we have to put our efforts where change can happen. See, most of the parents will come and ask you, how can I help my child? And that's a very genuine question. Every parent wants to do more for their child. The difficulty is that in impulsivity, in inattention, and in hyperactivity, there is actually not a lot that you can do as a parent. Okay, that turns out to be the bottom line of ADHD. You can actually create a situation where the child will be less impulsive or will be more attentive. We'll talk about that later. But the main difficulty remains that unless you help the child with emotional regulation, nothing is really going to change for the family. And ICD and DSM don't talk about this. So we go for parent training programs. So most of the parent training programs actually have arisen from a single parent training program from the Oregon in the US, and whatever that you read about are essentially some or the other variation of the same program. So we will have to give it some Indian twist there, because what works in US doesn't work exactly like that in India, even though the family is living in India and constantly looking at US. So the most important components of parent training program are obviously parent education. Second is the choice of targets. It is very important to choose targets that you can shoot, or rather targets that they can shoot. Because parents will come with a huge shopping list, which will typically have 40 or more items. And if you take that whole thing on board, then you are in trouble, because that will not be achieved. So choosing specific targets is extremely important. Giving parents appropriate tools and skills to shoot those targets, that is important. And regular review with parents for troubleshooting. Because just telling parents that please do this does not work. This is something very important. You know, long time ago when I was working with an IS officer, he told me a story. He said that there was a jungle and there were lots of rabbits living there, and one owl turned up there and it started hunting those rabbits like crazy. It started killing those rabbits for fun. So all the rabbits got worried. They went to the local whatever guru that was there and said that please help us solve this problem. So guru बैठ गया, उसने ध्यान लगाया और उसने बोला कि ये solution बहुत easy है. बोला क्या solution है? आप सब उल्लू बन जाओ. लेकिन हम तो rabbits हैं, हम उल्लू कैसे बने? ना आपको solution चाहिए था, मैंने solution दिया, अभी implement कैसा करना वो आपकी responsibility है. You know, it suits a IAS officer to say that and laugh at himself for that, because you know, ultimately that is what happens in a functioning democracy. So that if you look at home as a microcosm of that functioning democracy and yourself in place of that IAS officer of that guru, kind of advices that cannot be put into place in real life, which come from West, which come from Instagram rules, and which come from books, really doesn't help the parents at all. So it is really important that you have regular troubleshooting sessions so that whatever you had discussed in the previous session, are they able to implement that or not? So a typical parent session will have three components. First 15 minutes will be troubleshooting. Second 15 minutes will be discussing plan for the next session or what they are going to do in the next week. And the last part will be left with what do they see as upfront difficulties in implementing that. Unless these things are done and we move by micro steps at a time, this whole program will not be achieved. Another thing that is most important is to make them commit for at least 6 months. Anything less than that and nothing is really going to change. This is something very important. We are talking about changing pattern of those specific neurological tracts through behavioral change. So it is literally like trying to change the magnet by rearranging the ion files up there. That's not an easy work. This takes time, it takes many repetitions, and at the most 3 or 4 agendas will be achieved in any given 6-month period. So unless the parents are willing to commit to that, you should not be taking it on. Next part is actually choosing the correct set of parents. See, this is something that is quite important in any clinical practice, particularly while working with children. All parents will want to help their children. But the question is, will they be able to? You know, I watch a lot of cartoons because I work with children and I like watching cartoons anyway. So this is the scene from Shrek 1 where Shrek and Donkey are both imprisoned by Lord Farquhar's soldiers, and they're like hanging there in the tower. And the donkey is constantly screaming, but nobody told me I have the right to remain silent. Nobody read me my rights. Nobody said I have the right to remain silent. So Shrek very quietly tells him that donkey, you have all the rights. What you lack is capacity. Okay, so this is our first criteria, that can these parents actually do that particular work at home? Because if they are unable to do that, then your effort and their effort is going to be wasted. They are going to get frustrated with treatment and psychiatry in general. And the only real loser in that situation is going to be the child. So the first criteria for choosing right parents is they have to be a functioning couple. What do we mean by functioning couple? Is that they talk to each other on a regular basis. They have broadly common views about important things in life, and they jointly take decisions and execute them together. That would be the most basic definition of a functioning couple. Both of them should have some amount of empathy for each other and for the child as well. That we are dealing with an immature brain here. The child is struggling. No child wants to get beaten up or wants to get berated every day. This level of empathy has to be there at least to start with. And then they have to have openness that we have tried certain things, they haven't worked, so now we are willing to take professional help and work on that. And the last part is they have to be trainable. There has to be some track record that they have actually learned a new skill in their life. People who are not trainable are very difficult parents, because being parent is all about training. You know, the beauty of life is that children being parents are. So if you are not a trainable parent, if you are not a trainable adult, then you are not going to survive there. So there are exclusion criteria as well. Obviously, dysfunctional couple. A couple that communicates either through emails, messages, or through children, or through behavior is not a good couple. They are not going to work there. People who are extremely dogmatic. A parent sitting there, याच्या आईने लहानपणी याला ही सवय लावली नाही किंवा याचा बाप याचे लाड करतो म्हणून झालं. So for a complex problem, when people come up with a very simple solution, then you have dogma working there. Right? That if you are going to blame somebody from 1947 for problems in 2026 and be absolutely sure that that is the only single reason for all problems in front of the country today, then it is a dogmatic thing.
Who are not ready, they are not right. What we can select the parents. So they are not right parents. What about them? What to do?
Prescription.
Because everyone speaking together. Sorry. Medication. Ultimately, calm down. What else? So you could think of some therapies if it is autism where you don't think the medicine, right? But would any of us let me say that out of those patients who come to us, 70% of them, we would give a prescription. Am I right? Would you say that we would not give a prescription to 70%? No. So you would, right? So your first choice of management by default becomes medication irrespective. Okay. Now on the other hand, let's think of prevalence. What is the prevalence of schizophrenia? And it's been 1% since, I think my chairpersons were studying to when the younger lot who are going in and out are studying. Remarkable, isn't it? What about autism? What is the prevalence of autism today? Anybody? How much? 1 in 65, 1 in 50 is what CDC says, right? The US statistics, 1 in 150. According to the European guidelines. Where are we headed? How come this kind of a divide? So let's pause on the prevalence. Keep that in mind because it's going to be needed later on. And let's go back to the origins of both these disorders. Alright? Any sort of insult in utero. Infection is just an example that I have used over here. Can give rise to, is this the pointer? Okay, never mind. So any sort of insult, be it infection, be it trauma, be it anything which can lead to an inflammatory state in utero,
can lead to a predisposition whereby you have the digital world, whereby you have a persistence of inflammation leading to chronic inflammatory states, or what we call as a latent inflammation. So you see, it's a similar insult. It depends on the programming as to what you're going to eventually evolve into. And just for our understanding, I have put here susceptibility genes and schizophrenia genes. Of course, this is from work done way back in 2011, and we come to more recent work. So, this one doesn't work. So, when we talk about the genetic predisposition, you have either the paternal imprinting genes, which are more biased in autism, vis-a-vis the maternal imprinting genes, which are more biased towards schizophrenia. So, depending on your genetic predisposition, whatever is the insult in utero is going to veer us in a direction towards which one we are going to express. Okay, this point, thank you. So if you look actually at the trajectory, we are taught repeatedly that autism has to be from birth. But when we ask patients of schizophrenia, we ask them for whether they have social deficits from birth too. Do we not? Do we or do we not look for the cluster A? We do. We do look for a spectrum, right? And mild social deficits at birth, vis-a-vis social deficits which worsen in adolescence, is what we are told is the key for differentiating between the social deficit of schizophrenia versus autism. Are we on the same page till now? Right? Okay. So what happens is that these pooled genetic features are very common. At the same time, there's a lot of differentiation. Forget the slide. I'm not good with genetics. This is something which I was telling a few people I tinkered around with this time AI, and I happened to get some stuff on it. So if you look at the genes, they are very complex. So let's not look at the genes, and let's try and understand what is common about both these disorders. Okay, they have shared genetic pathways, and there is commonality in neurodevelopment, copy number variants, immune pathways, mitochondriasis. There's a lot more commonality than otherwise any two disorders when we compare with each other not be pooled under the same group or disorder head, right? So what is it? Why is it that we are seeing so much of commonality in these two? So when we look at the gene analysis, what we find is that the two genes which stick out, okay, the 22q and the 16p, they express themselves like a mirror image very differently in autism. So different areas are affected. Here the temporal lobe, the cingulate cortex, the putamen, etc. And in schizophrenia, different areas are affected, as we can see in the PET scans. So are you seeing that this common core origin that we have, depending on the propensity and the gene expression, can go either this way or that way. And the way it goes is what determines whether the default mode network is getting affected or the salience network predominantly. So hyperconnectivity, which is autism, versus hypoconnectivity, which translates into schizophrenia, is what we end up seeing. And therefore, that you have so much of clinical commonality also between the two. So hyperconnectedness leads to the sensory overload and the stimulation, which we see in autism, vis-a-vis the hypoconnectivity, which is the cognitive dulling, and also the sensory input, which we see in schizophrenia, right? So too, we see, apart from the neurobiological aspects, you would see social cognition changes, sensory changes, and executive function deficits in both these disorders. So far, little heavy, but I hope you're with me. So let's now ask ourselves, how many of us have looked at adults with schizophrenia and thought that they were probably misdiagnosed and they had autism? Show of hands, please. How many of you have done that? The numbers are falling. Why is it that there is a fall of numbers or less of confidence in this? Dr. Ashish Deshpande was just telling me outside when we were in the tea break that, autism, okay, it's getting too complicated. And this is happening again and again and again, where we are thinking that autism is schizophrenia is autism, and we are really not sure about what's going on in either case. So recent work done in 2025 is actually proposing or hypothesizing that there is a new spectrum which is ASD to schizophrenia. So it's the ASD to SSD spectrum, where we spoke about hyperconnectivity and hypoconnectivity. Here we have neuroplasticity, which may be hyperplasticity vis-a-vis hypoplasticity. And literature has shown that brains of autistic children are slightly bigger and they have increased connectivity vis-a-vis brains of schizophrenia patients who have smaller brains along with change in the ventricular sizes, right? So are you seeing how this is sort of a complementary mirror image of each other at each step? So this brings us back to the question, this question that plagues me more than anybody else. If we talk of a spectrum from autism to schizophrenia, how come the prevalence rates are so different?
At the same time, I think all my contemporaries here would admit to this. Jab I am clinical practice psychiatry
For myself, I think as many people know, I'm on several groups and I think I use a lot of social media. In fact, I've been sort of blamed for using too much time and spending too much time there. So actually reading up on the topic also helped me in terms of what I could do probably. In fact, what I had recently planned to do was read more books, but unfortunately I collected a lot of books to get away from my gadgets. But the Japanese have a wonderful word for it, sundoku. Is basically piling up a lot of books, reading material, and actually not reading it. So that is exactly what has happened next to my bedside table. So going ahead, so when we are talking about digital behavior interventions after the couple of talks on child and adolescent psychiatry, I think this is a topic that we are all very familiar with. In fact, I think gadget use in adolescents, not only adolescents, I think all of us adults, almost all of us here, we have all been clicking snaps and posting on our various groups. We do use so much of it. And it seems actually a little incongruous that we would be using digital behavioral interventions to intervene in something like gadget overuse. So coming to the next slide. So adolescence, as we know, I think I don't want to go over it. It's a critical period, obviously, of development, identity formation, and social learning. So excessive gadget use, as we all know, is going to be related to disruption of all this because of sleep disruption, because of reduced academic performance, impaired attention. I think Dr. Bhushan gave a talk on how it is so difficult to get the child to do something very regular, just getting up, getting dressed, brushing teeth, and going to school. And now we have gadget use added to that. So digital behavioral interventions represent a promising and scalable solution. In fact, I think I was listening to the couple of talks earlier in the day by Dr. Panda and Dr. Neha, and they had a lot of those apps that they were talking about. So a lot of that would probably be reflected in my talk too. When we're talking about gadget overuse, I think if you look at it, probably most of us may fulfill criteria for whatever is written out here. Gadget overuse being an excessive, uncontrolled use of digital devices, whether it is smartphones, tablets, gaming consoles, computers that interfere with daily functioning, sleep, academics, and social relationships. I think all of us, despite our best, whatever decisions we take, we probably at some point in time have exceeded use from the time that we fix for ourselves. Problematic social media use, similar, is compulsive social media engagement characterized by salience, mood modification, tolerance, withdrawal, conflict, especially when they are told to keep away from their tablets, etc., and relapse. So, I'm not going to focus on internet gaming, which has been identified as a disorder. And of course, we know like the IAP and the AAP has given specific guidelines as to how much screen time could be used by children, whether they are below 1 years, obviously below 1 to 2 years, no, they should not be exposed. But we see children, babies actually using tablets pretty effectively, and pushing right to see, their whatever Peppa Pig or whatever. That's what I see with my niece. So we do have identified hours which are supposed to be healthy, but all of us know that we don't keep to that. Just a question before to wake everyone up. How many of you all use less than 3 hours of your cell phone or any of the gadget? Less than 3 hours. Wonderful. I need to give you a clap for that. I think we should all, of course, it's only I think 3 hands. So everyone is using more than 3 hours, but whoever is using less than three, I think it's wonderful. Really, kudos to all of you all. None of us can, I think. Which is true for the US and also for India. In fact, even the 23 survey that was there on education has shown similar, that 83% of adolescents do own a smartphone and do use quite a lot of it. We see that the problems are quite significant. 27% of adolescents do have problematic social media use. And it has obviously increased after COVID, because COVID education went online and there was a absolutely sanctioned way of using these gadgets anyway. So these are some of the validated tools. I'm not going to really go into the details of it. Some of them probably you all are familiar with in terms of internet use, etc. But what I would like to speak about is, this is again something theoretical in terms of the neurobiological basis and why we need to know why it is so effectively addictive for us, because of the dopaminergic reward systems, the prefrontal cortex hypoactivation, the structural brain changes that come with increasing gadget use, and the HPA axis dysregulation and sleep dysregulation. So these are some of the social and psychological consequences where the adolescent could have increased anxiety, depression. Of course, there's probably underlying anxiety which could worsen, or probably the student or the adolescent is using social media to alleviate the symptoms. There could be poor emotional regulation, especially if they are told to stay away. Increased loneliness, social isolation could be there. Academic, there obviously is reduced attention span. Multitasking can also reduce retention. In fact, there has been reports that when a person is reading on gadgets, on laptops, probably the retention is much less compared to probably reading like how we did from books. So that of course requires more specific trials to bring out that. Sleep, of course, we are all familiar that blue light delays melatonin onset and reduces sleep, and social development as such in childhood and adolescent gets impacted because of gadget use. So this is one of the articles that was there about navigating the digital dilemma, internet and smartphone addiction amongst children and adolescents. And what they found was that there is some amount of gender differences in terms of what digital activities boys versus girls use. So girls probably use a lot more social media, like Instagram, etc., while boys probably would be using a lot of online gaming. The platforms used would be different, emotional profiles could be different, underlying vulnerability could be different, and of course, this is just one of it, that there could be some gender differences. What they have, of course, said in the article is what are the interventions. I think they're all familiar that there is CBT, there's CBT-based digital programs, digital detox programs, mindfulness programs. But what we are all most comfortable with is pharmacological interventions. I think when it comes to, like someone coming for gaming disorder or even someone coming for internet addiction, I think what we reach out in our busy clinics is for some sort of medication also. It becomes an easy way out. And what they have found is that yes, it does have its, its usefulness because SSRIs, mood stabilizers, even drugs like naltrexone do reduce the compulsive internet use. Coming to what are digital behavioral interventions, the topic for the day. So what we actually look at is behavior modification, cognitive restructuring, psychoeducation and skill building. And this is something that is evidence-based. It is strategies that are targeted using actually digital platforms which aim to reduce the problematic technology use. So when we are talking about types of digital behavior interventions, there could be apps. As I said earlier in the day, Dr. Panda spoke about a lot of apps which are coming in psychiatry per se for disorders. But there are also apps which are, and we are familiar with it. I think we all have smartwatches, wearables, which are tracking us, tracking how we are sleeping, our relaxation, or what our physiological profile is. So that is something that can be obviously monitored and also help us to reduce our gadget use. Screen time limiting tools are there, gamified behavior change, which actually would be probably more acceptable for adolescents who are anyway very familiar with game-based programs. Mindfulness and awareness apps, I think quite a few of them now online therapy platforms, and school digital well-being curricula. This is something that is important because I think this is where we could probably, as far as school mental health programs are concerned, bring in our expertise as mental health professionals to improve in terms of the school curriculum or digital hygiene. CBT-based intervention framework is basically something that works over several weeks. It's something that uses the CBT framework, assessment and psychoeducation, cognitive restructuring, behavioral activation, where the person can go into offline activities, schedule those activities, and of course, look at relapse prevention. We spoke about parents, being obviously, as primary caregivers, as the talk earlier, like how much involvement they have and how to be more effective was discussed. When we are talking about parent role, even in digital interventions, in actually doing something to stop, the adolescent from stopping gadget use or overuse, I think it starts with role modeling. As I said, all of us, when we are using the gadgets ourselves, we need to cut down on our own hours of use before we actually say something to an adolescent, and they are very good at arguing. And it is seen that 51% reduction in screen time when the parents actively participate. So parents become one form of co-therapist in this intervention program. So then you would have something like co-viewing and shared digital experiences where they would probably engage. I have a problem with the statement made here because I think when we were discussing earlier I was discussing with a colleague of mine, how many adolescents actually allow you to look at what they're looking at. So it could be a problem where, though it is advocated that we should have some sort of sharing in terms of what we are viewing, maybe with younger kids, we could probably do that. But in older adolescents, that may be a little difficult. Collaborative rule setting is again something that needs to be worked on. It all depends on what the relationship between the parent and the child is, and how they look at authority figures and how they look at the rules being set. Modeling healthy digital behavior, as I said, is something very important. Keeping cell phones away from meal times, having a screen away time where they can do offline activities like board games, etc. Having tech-free zones, probably being insisting that cell phones have to be kept in the halls or whichever in the cupboard and not in the bedroom, for example. But this is something, as I said, though parents form a major part of treatment, it could be very difficult to ensure and to advocate it. Advocating it is easy, but to actually putting it to practice could be very difficult. And warning signs for parents could be that the child starts hiding the device, gets extremely distressed. We see adolescents, they start throwing tantrums, they don't sleep, they have major anger outbursts, they abandon what they're doing, they probably stop studying, for example, stop doing hobbies, just sit isolated in their room. So this is something that needs to be negotiated. And here I would also say that probably we need to look at not only the intervention in terms of the digital behavior interventions or even cognitive behavior therapy, but we need to also look at whether pharmacotherapy would be needed. So screen time management and parental controls. Now there are lots of apps which, as I said, which are available. Apple phones have iOS apps. There are Google Family Links. Custodio is a cross-flow. I mean, it's across lots of platforms. ArcPact is something which you can use to block or grant internet access. Again, this is something that probably can work with younger kids, but not older adolescents so much. Family-based and peer support digital interventions. These are some of the peer support platforms. In fact, I think 7 Cups of Tea, reachout.com, which is in Australia, for example, there's something that is evidence-based, it's mental health platforms. But 7 Cups of Tea, now we have free online, a lot of people online giving advice, and it has been found that when adolescents reach out, there's a lot of influencer-based measures that adolescents follow. So it's more of a peer support group, but it could go wrong. So that is something that needs to be also monitored. So when we are talking about peer support platforms, it could be about something like 7 Cups of Tea, or even influencer-based platform, but it needs to be monitored. In fact, I think China has come out with certain measures where they have said that a person who's an influencer should probably have a background related to the subject and then only speak about it. And of course, Australia, we know, they have banned social media below Instagram and all below 16 years of age. So maybe a top-down approach, as in government policies, would probably help rather than having families managing such sort of app-based control. School-based programs are something that are very helpful because it actually teaches, and this I think is somewhere where school mental health programs can take
Might be coming from 48. I didn't dare to pack even a blazer, leave aside the winter clothes. So to sit here, I had to gulp at least 3 cups of coffee. So this is just to have some lighter note before this serious talk. Wherever we progress, whether it's next generation or future to the next generation, 2 things are going to be always there. One, ethical dilemmas, which every speaker has spoken so far, at least some slides, some words were there. And other aspect is legal. And both of these we are already seeing in the news. With the enhancing digital world and its use, both these are causing issues in the society. My prior speakers have already made my task very easy. They have given a background to this. Before I proceed, let me agree that ethics has no single answer. It has a different perspectives. So there cannot be absolute right and wrong in it. And accordingly, we'll have to approach this session. So why it is important to us, or why does it matter? As I said, legal age for maturity is assumed to be. What is the legal age for maturity or for voting, I will say? 18, and for that matter, something happens on that 12 a.m. when we turn 18, that suddenly turns us into an adult, and that creates a lot of problems. We'll be discussing that. Peak age of onset of major psychiatric illnesses is again 15 to 30 or 25. So we are dealing in that age group. High family involvement in the care of patients in India, everyone has discussed. It has both sides, its benefits as well as some perils for that. And as a psychiatrist, many times we have to play the multiple roles. We are clinicians, we are teachers, we are sometimes family, friends, and in that context, many ethical dilemmas are likely to arise. Sorry. This is a beautiful article that I had came across a year back. What it shows is that there are two different parts of the brain, the striatum, or what we say emotional part of the brain, and the prefrontal cortex, more of a rational part of the brain. They mature at a different rates. And this is well depicted in this study, where the development of striatum happens much before than the prefrontal cortex. And as you can see, during the adolescence and early adulthood, this process gets completed. It is a precise 18 to 25 years of age where many of our clients will be. They either present for some psychiatric illness or some developmental issues. Many a times this is the age when they come for the personal issues as well. And what happens during this gap between the two parts of the brain is there is high impulsivity and emotional state along with ego development, where the person starts searching from who am I, what's my purpose. Also, they want independence. Prior speakers had highlighted this. Now, parents have a limited access to their adolescents. Many parents come to us and say कि वो बाहर चिपका देता है, do not disturb me, and they stay in their own rooms. So independence, they want their own privacy, time, also age for experimentation. Identity formation, a crucial stage. Another important dimension that is added here is sexual turmoil, because that is again the age of sexual development. So many things are happening in this age group of 18 to 25 years, which makes approaching these clients bit difficult for a therapist. What I'm going to do is I will try to discuss few cases. This is the first scenario. A 20-year-old female with anorexia nervosa refuses hospitalization despite a BMI of 14. So she is 20-year adult age, have as per MSCA has all legal rights to decide, and it's anorexia nervosa. MSCA says it is, they usually are having capacity to make mental health related decisions. So the challenge is, if you do not admit and start the appropriate treatment, we may lose the patient here. How to proceed? If we want to admit, we have to have capacity assessed. capacity most likely is preserved here. So this is the ethical dilemma, whether I should override the autonomy or I should go with the patient's wish of not getting admitted, preferring to stay home. You give me medicines, you give me advice, I will follow at the home. What will you do? Any suggestions? Yes? Life-saving intervention. So you would like to override the autonomy. Is it ethically justified then? Legally, yes, I can say justified. Ethically, is it justified? We have to ask ourselves, what should be the role of ethics committee or other hospital committees?
Compassionate systems of care and shaping the future of mental health care. To speak on this thought-provoking topic, we invite Dr. Mitesh Vaishnav, sir. Sir, the stage is yours, and we would like to ask our chairperson to introduce sir.
Sharing our association in IPS West Zone and IPS Main. So at the outset, I thank Amar Shinde, Dr. Kendre, Dr. Khare and the entire team for giving me this excellent opportunity. Well, I am reminded for this leadership lecture in leadership in psychiatry. I am reminded a case. A patient was waiting in my waiting room. A few years ago, he was restless. He was not sitting quietly. And when he came inside my chamber, he asked, "Doctor, I do not know whether I have come here for medicines or for advice or for someone who simply understands me." This taught me for the first time that patients are visiting us not only for the tablets, but they want us to lead their life, to work as a leader, maybe emotionally, maybe morally, and maybe a human leadership. So getting pills is not the only aim, and psychiatrist has to work as the leaders. Now, why the leadership in psychiatry is important? Leadership is the capacity to translate your vision into reality. And that is what required in our practice. This reminds me a lesson which I learned during the pandemic. During the peak COVID, the COVID wave, I received a call at about 2 a.m. This was from a family. Family was in panic. Not because anybody had a COVID, but their daughter locked in a room and she was afraid that she is infected with the COVID, and family was helpless, was thinking that what to do about her. Why? Because at that time, all the hospitals were full, all the health system had failed. So what they required at 2 a.m. was not the medicine, but not the prescription, but simply how to handle the crisis, simply give them the patient hearing and providing them the leadership in such a period of the crisis. So psychiatrists are the emotional ICU for almost each and every individual. And we have worked like the emotional ICU and provide the leadership to the society. Psychiatry is so much important because mental health disorders are rising, we all know. Digital technology is reshaping the way we think, feel, and connect with each other. Stigma is evolving, but still not disappearing. New ethical and legal dilemmas that's already discussed in different subspecialties are there. So psychiatry sits at the intersection of the mind, society, and the system. Leadership
shapes direction, policy, and culture. The changing landscape of the mental health leadership, there are ethical and legal challenge. The public expectations are also increased after this Google and AI. Each and everybody is well informed with the Google and AI. A mother once complained me that my 12 years old son learns more from YouTube therapists than from me. So a college student once said that, sir, everyone tells me what to do to be strong, but no one tells me how to be strong. Digital affairs are also increasing in the society. We know about love jihad, different Instagram relationships, and that also requires a different kind of leadership in this new era of the AI and digital and social media.
अब बेवफाई सिर्फ दिल से नहीं डेटा से भी हो रही है। जी हाँ,
माइक नहीं चल रहा है। दिस इज अ वीडियो, माइक नहीं चल रहा है।
बॉक्स में छुपे राज, अनरेड मैसेजेस और स्क्रीन के पीछे छुपे अफेयर। आज हम बात करेंगे डिजिटल बेवफाई की, और वो अफेयर जो होता तो है लेकिन छुपकर। ना रिश्तों में लिपस्टिक के निशान होते हैं, ना गिफ्ट्स की रसीदें होती हैं। अब जो धोखा है वो व्हाट्सएप पर लास्ट सीन से शुरू होता है और इंस्टाग्राम
So no video will come.
होता है। इस नई बेवफाई में ना तो सीधा आमना सामना होता है और ना ही कोई सबूत दिखाई देते हैं, बस होते हैं अनरेड मैसेजेस, सीक्रेट चैट्स और
So this is about unread messages, secret chats, which is happening, and this is one of the important TV report which described. So now clinically what we see, next video will come. One case magnet, emotional affair or support on Instagram. A 35 years old married woman experienced guilt and emptiness after her husband discovered her emotional affair with a fitness coach on Instagram. What began as a fitness advice evolved into intimate late night chats and affectionate exchanges. Though denying physical contact, she described it as emotional support during the marital neglect. Similarly, a 42 years old married banker exchanged romantic WhatsApp messages, voice notes with a former girlfriend, calling it nostalgic and harmless. His wife viewed it as a serious emotional affair, triggering arguments, mistrust, and insomnia. He reports guilt, anxiety, and decreased sexual desire. She oscillates between anger and sadness, describing digital infidelity. No physical meeting reported. Marital therapy started for boundaries and trust amongst the couple. Here is an excellent example. Volume is not there.
इंस्टाग्राम पर फिल्टर यूज करती थी 52 साल की रानी, फोटो देखकर दिल लगा बैठा 26 साल का अरुण, फिर हुआ प्यार का खोनियन। इंस्टाग्राम के जरिए दोनों नजदीक आए, क्योंकि महिला इंस्टाग्राम पर फिल्टर का इस्तेमाल करती थी, इसलिए लड़के को उसकी उम्र का अंदाजा नहीं हुआ, लेकिन 1.5 साल के अंदर ही महिला का यही प्यार उसकी जान का दुश्मन हो गया। लड़के ने गला घोंटकर उसे जान से मार दिया। वारदात के करीब महीने भर बाद अभियुक्त पुलिस की पकड़ में आया। उसने वारदात को अंजाम देने के पीछे की पूरी कहानी बताई। ट्रांजैक्शन भी हो गया, पैसों का लेन देन कर दिया। उसी महीना में 1.5 लाख रुपए की बकाया थी, 2 महीने की बात थी, शादी की बात थी, जिस पर अभियुक्त कागज में से परेशान था, उसने कहा और उसी दिन धोखा देखी, उसने उसके करीब बड़ी जमीन को बेच दिया और इसी कारण उसकी मृत्यु हुई।
So this requires the leadership. Now in the relationship landscape is changing. So not only marital therapy, but providing the leadership to the society, to the family, and to the individuals is also required. Because infidelity is not just a moral lapse, but it's a complex behavioral and emotional phenomenon illustrated by biology, opportunity, culture, and changing relationship dynamics. Next important sphere is the stigma, the pervasive devaluation and marginalization of the people with mental illness. Stigma, even in this Google era and even this AI era, it is still existing. Stigma is attached to anything and everything related to world psychiatry. It may be psychiatric medicines, it may be psychiatric doctor, it may be psychiatric hospitals, psychiatric nurses, anything. See, many a times people ask about the faith healing and so on AI. And AI is replying because AI is just garbage in, garbage out. Whatever is fed to the AI, AI will definitely reply accordingly. If there are many videos of the faith healers or the non-qualified persons or the so-called motivators, then they just spread the myths and misconceptions. So in this era of the AI, we have to provide the leadership to deal with the stigma which is associated with the psychiatry. Here is a glaring example.
ऐसा हुआ दादा ने धारा हथियार को अपनी बुद्धि का मर्डर कर दिया और शव के टुकड़े टुकड़े करके जंगल में फेंका। पहले तो पुलिस को भी विश्वास नहीं हुआ कि ऐसा हो सकता है, लेकिन जैसे जैसे जांच आगे बढ़ी बातें खुदी गई और दादा सरन सिंह ने पूरे मर्डर प्लान का खुद ही पर्दाफाश किया और बताया कि कैसे ताकि के चक्कर में अपने बच्चे का अपने मासूम पोते का और देखिए टीनेजर ही हुआ इसको मारकर टुकड़े टुकड़े करके दादा ने जंगल में फेंक दिया। बताया जा रहा है कि अपने परेशानियों से ज्यादा परेशान था, जिसकी वजह से उसे ये बताया गया था कि उसके ग्रहों पे दोष है और ग्रहों का दोष कैसे ठीक होगा, तो अपने पोते का मर्डर कर। हुआ क्या था कि 2023 में सरन सिंह की बेटी ने खुदकुशी कर ली, यानी बच्चे की बुआ। 2024 में बेटे ने भी खुदकुशी कर ली। अब सरन सिंह को डर था कि घर पर किसी ने जादू टोना कर दिया। इसके बाद आरोपी तांत्रिक को समझने लगा, तांत्रिक से मिलकर बात की और तांत्रिक ने कहा कि आगे नहीं चाहते कि तुम्हारे घर में ऐसा हो तो बच्चे की बलि दो। सरन सिंह ने मौका देखा था कि उसका अपहरण किया, धागा हथियार से उसके शरीर पे कर दिया, शव को टुकड़ों में काटकर एक एक कर जंगल में फेंक दिया।
So that is the prevailing myths and misconceptions and faith healing, how it works. Now, so far as the historical evolution of psychiatric leadership in India, then Indian psychiatry has a rich heritage. We have moved from custodial care to the community care, from silence to advocacy, from stigma to empowerment. Great pioneers also built institutions, shaped associations, and guided generations. Their journey teaches us that leadership is a relay and not the race. And every one of us must carry the baton forward. Now, what makes a good psychiatric leader? Emotional intelligence, that is the ability to understand and manage our own emotions while also recognizing and responding appropriate to the emotions of the others. Empathy with boundaries is definitely required. Clarity of communication is required, and integrity of ethical courage is required in today's psychiatric practice. What makes a leader? When I was a young psychiatrist, I once apologized to an elderly patient because I kept him waiting for 30 minutes. He held my hand and said, "Doctor, you did not keep me waiting. Hope kept me waiting." So I learned from that day that leadership begins with humility. Leadership begins when we realize we are responsible for someone's hope. Leadership in private practice. Years ago, a daily wage worker came to me with severe depression. He passed a note of 5 rupees to me and said that, "Doctor, I will pay in the future when I'll start earning, but currently this is what I can offer." So this is also to be learned that psychiatric practice is not merely a commerce, but it's not a commercial practice, but it's a practice with the humility, and that's what we have to provide to our patients. Leadership in academics. In one CME, after when I was conducting the CME, a question was asked, "Sir, how do we treat patients who do not trust us?" I replied, "We treat them with patience until they trust us." She nodded and said, "So psychiatry is not just a subject, it is a relationship." This is the essence of psychiatric leadership in academics. Now, in public health, we are talking about the depression. So, in a camp, I was educating about the depression. Then one female said that you are talking about the depression in general, but what about our depression? So, you see, we should talk about the present, we should talk about the condition of the people, and what we should talk about what the people feel, and we should connect ourselves with them. Misinformation, there is a lot of misinformation. A case came to me after listening to a motivational video from a non-qualified person. He stopped all the medication because it was mentioned in the video that psychiatric medications are very harmful and one should not take the medication. So after a few months, he had a severe relapse of the depression. So we have to provide the leadership, we have to create certain social media videos and awareness programs so that we provide the proper education to our society. So, ethical leadership, the confidentiality crisis. 12-year student came to me and talked in detail about her, and she said that, "Don't tell whatever I have discussed with you to my parents, but tell me how to talk to them about this crisis." So this is what here the leadership comes, the ethics, that not to disclose what our patients have told us, but to teach the patient how to disclose it to their parents or to their near ones. In India, psychiatry and spirituality often overlaps. So once a tragic suicide attempt in the family, they reported this tragic suicide, they asked me to visit. Now here no prescription was required, no advice was required, but what was required was simply to sit with them for 10 minutes, 15 minutes, half an hour, and to empathize with them. So many a times different types of the psychiatric consultation or leadership is required. Sometimes the silence is more important than talking and talking. Leadership in the gender, many a times female says that whether I will be a good psychiatrist or I will be a good mother. We talk about that future is for the woman psychiatrist, and now more and more females are coming to the psychiatry. But I say that not future, but women are in the present scenario also very important in the psychiatric practice. Advocacy and policy leadership, that is mental health care rights, government collaboration and policy shaping, in that also we have to provide the leadership. Joining ourselves, our association with WPA, APA, and involving in making the government policy and cross-cultural training is also required. Now simply describing my journey, I have started writing. I'm starting for last 40 years in a Gujarati daily, and I've written more than 4,000 articles. I've produced more than 500 videos, and I'm active in all the social media, that is Instagram, Facebook, everywhere. But how you can provide the leadership? If you talk simply about the psychiatry, about the disease, patient may not listen to you, patient may not even go through your videos or your literature or articles. So you have to present in such a way so that they can take interest and then they can be aware of the psychiatry also. So I started conducting several seminars, not webinars. I'm talking about seminars, and the seminars with a title of motivational title. One of the most popular is From Dreams to Destiny, in which how I talk described in this video.
मुझे ये पता नहीं है कि आप कौन से सपने देख रहे हो, मुझे ये पता नहीं है कि आप कौन से सपने देख रहे हो, फिर भी मैं कहना चाहता हूँ कि आप जो भी सपने देख रहे हो सच्चाई में बदलना मुमकिन है, आप कर सकते हो। अगर आप ये सोचते हो कि नरेंद्र मोदी बन गया, अन्ना हजारे बन गए, ओबामा बन गया, अब्दुल कलाम बन गया, अमिताभ बच्चन बन गया, सचिन तेंदुलकर बन गया, और आप कुछ नहीं है भले कुछ नहीं बन पाएंगे। अमिताभ बच्चन ने आपको मुझमें किसी कोई फर्क नहीं।
Persons to felicitate our speaker. Yes. And would also like to request Dr. Smita Panse, Dr. Arpana Pawar and Dr. Arun Marwale sir to felicitate our chairpersons.
Wonderful introduction. At the outset, I thank Indian Psychiatric Society and this wonderful organizing committee for giving me this opportunity. This topic has been close to my heart because I was always been very fortunate to have small children around me. So I like to play with them. I like to spend a lot of time with them. So my nephew, who is a Gen Z now, so I saw him growing up, and now I'm seeing my daughter, who is Gen Alpha, and I'm a millennial myself. So it's very different. There's a very contrasting way in how we see life, how we approach problems, how we handle the situations. And what I have seen is that in this practice, if these three generations, if we understand them, if we study them, if we see how they cope, it's very important for us to know, because we can help them to kind of achieve what we are trying to achieve. All three generations, millennials, Gen Z, Gen Alpha, have seen some of technology, internet. What comes before millennials? Can I ask, what comes before millennials? Anybody? Yeah, no. So baby boomers are 1945 to 65. They were said baby boomers because after World War II, the population suddenly increased. So that's why they were called baby boomers. Then came Generation X. So 65 to 80, a lot of writers started writing about Generation X because they challenged the society norms. Like if you see in India also, so many like Sati, Dowry, all that, they started voicing their opinion. So they was called Generation X. And actually we should be called Y, Generation Y. Actually we are Generation Y, means 80 to 96. But since millennial was coming nearby, 2000, that's why we are called millennials. And then the Gen Z came, so 96 to 2012. And now what is going on is Generation Alpha, which is still 25, and now there will be Beta. Why it is important? Millennials, Gen Z and Alpha are very pro-therapy and pro-psychiatry generation. If you see maximum number of our patients who are amicable to therapy or amicable to treatment are millennials, Gen Z and Gen Alpha. But they are very different in the way they think. So understanding them is very important. So I'm going to tell about what kind of mindset these generations have. Also, I'm going to throw light on the Indian context, because I think India is going through very challenging times nowadays in terms of mental health. I'll tell you why and how we can handle the situation better. So let us understand. I'm going to be brief because I don't want to extend the time. My friend is waiting. I want to give him the right time. So what are millennials? They are bridge builders. If you see, we saw both the worlds, the millennials. Most of us here are millennials. 1981 to 1996, we saw the pre-internet era and the internet era, and most of us thrived on hard work, discipline. So what happens is when we see our children, like most of us are parent to Gen Z, Gen Alpha, even we employ Gen Z, Gen Alpha, we do not see the same amount of robustness, and they are not going to get it because the survival needs are mostly met. Roti, kapda, makan, सबका ठीक ठाक चल रहा है. अब उनके needs अलग है, तो उनका 9 to 5 job, conditioning, lot of outside we were saying that a lot of doctors, parents, children don't want to become doctors because they really don't want to see this grind going through what we have done, and we should be okay with that. Most of the startups, Jagruti, Baiju, and Zomato, Swiggy are all done by millennials. Very, very hardworking. Also, millennials are going through tough challenges. Why? If you see, our parents are aging. So millennials have to look after their children and also look after their parents. A lot of millennials have parents who are going through dementia, dialysis, and I see a lot of stress because of that. What do millennials generally suffer from? Burnout, sleep problems, and anxiety. And traditional approaches like medication and therapy both work for millennials. Let's look at Gen Z, the digital natives and rebels. How they see life, entered a world already shaped by social media. Core values are authenticity, inclusivity, seeks passion and purpose. So a lot of children now, they pursue dance, and also they, like Monday to Friday, they do their traditional jobs. They don't want to stick to one job. They demand better workplace facility. Lot of times right now, Gen Zs are labeled. Gen Zs are labeled as distressed, having poor coping skills. But what is happening because of that? Like Gen Z movement in Nepal, it was popularized a lot, and Gen Zs were blamed for their actions. Now, when you start blaming, you can't help these people. So we should stop naming this Gen Z ek aise hai, Alpha aise hai. We need to understand their position, what they are going through. What are the challenges they face? Unless you don't, you will sound like a parent. So if a Gen Z or an Alpha comes to you and you give them those traditional things कि ऐसा मत करो, रात को मोबाइल मत देखो, रेड बुल मत पियो, ये मत करो, वो मत करो, बोले आप तो हमारे पेरेंट्स के जैसी बात करते हो, मैं क्यों आऊँ आपके पास? मैं नहीं आऊँगा, मैं कहीं और जाऊँगा. So unless you don't listen to them, you don't understand them, it'll be very difficult for them to change. Alpha, they are already in the digital world. Screen कितना भी तुम कोशिश करो अपने बच्चों को कि नहीं देंगे, limited देंगे, but they are seeing some screen somewhere. Even in schools, screens are being used. How much ever you tell school, but schools also make it a part of curriculum. It is right in some way, not right in some way, but the point is that they are all interconnected in an AI world. Virtually, they are very, very robust in the way they handle. Like if you see, you give child mobile to any child, 4 or 5 years, he will open, he will swipe, he will open the camera, he will scan if you want. It is very surprising to see that how they are learning, because sometimes we also cannot do it, but that is how it is. They are growing up in an entirely digital age surrounded by AI, automation, advanced digital tools from their earliest moments. Unlike previous generation, they never know a world without voice assistant, smart device, or instant connectivity. If my child sometimes say, I want to eat Maggie or something once in a while, I say, it's not available, I'll get it tomorrow. No, order from Instamart, Blinkit. So what happens is a very easy accessibility. They also know it. And आप कितना भी उनको समझाओ करो, sometimes you have to give in. So what I think for all generation Alpha, boundary setting has become very important. And that's why parenting roles have changed. पहले हम थोड़ा बच्चों को अपने हाल पे छोड़ देते थे, बच्चे बड़े हो जाते थे. कभी दादा दादी होते थे, नाना नानी होते थे, टीचर मार पूड़ के ठीक करके बच्चों को तैयार कर देती थी. अब वैसा नहीं होगा. टीचर मार भी नहीं सकते, हम बच्चों को अकेले छोड़ भी नहीं सकते. It's very important. Parenting has become very, very challenging. That's why I advise couples always, पहले शादी कर रहे हो तो 5 साल बच्चा मत करो, सोचो समझो. और बच्चा करना है तो एक पेरेंट को टाइम देना पड़ेगा और अच्छा खासा टाइम देना पड़ेगा. That can be a male or a female, husband or wife, doesn't matter. But these things, advice has become very important, because so many couples do kids because of the family pressure, all that. They should never do that. They should never fall for family pressure, because Having a baby is a very challenging task, and if they are not prepared for it, they should not have it. And after marriage, if they have a kid and they separate, whatever people say, अपनी जिंदगी के अपने हिसाब से जियो, पर बच्चों पे उसका बहुत गहरा असर पड़ता है. तो we should always advise couples before they have a baby कि make sure that your relationship is stable, then only you have a child. I think this is the most important line in today's world. Not only when we are seeing patients, but also when we are dealing with our individual problems. Connection before correction. Unless you don't follow this rule in your personal life or in your professional life, you are not going to, nobody is going to listen to you. Everybody is getting very, very self-centered, individualistic in their way approach, which is not a problem. But if you don't connect with a person, you cannot ask for them to change or do something for yourself. Connection before correction. I think this is a guru mantra for all psychiatrists and professionals, for our patients also. If the patient connects with you, whatever therapy you try to give him, whatever medicines you give him, he will take it. If he has no connection with you, the medicine feels imposed and the consultation has no value. Shifting science, mental health in modern India. Psychiatry is fundamentally transformed. We see so many online consultations, online patients are coming, they are seeking help. Gen Z and millennials are increasingly comfortable discussing mental health openly, a significant positive shift from previous generation stigma. Growing acceptance, what once taboo is now becoming normalized with young Indians, leading the conversation about psychological well-being. Gen Z Alpha have some different problems which we have not faced. Digital overload and social media pressure, cyberbullying, curated perfection, fear of missing out. So many of Gen Z and Alpha kids go through these challenges, and just simply telling them that you have poor coping skills or you cannot handle the situation, we did so much and we handled so much and you can't do this much, is not going to help. The rise of pill culture and therapy adoption. Neuropsychiatry rank among India's top 10 therapy categories. Market value at 11,700 crores of Jan 24. Mental health drug demand lifted sales by 9% year on year. Online search for psychiatry in Delhi nearly doubled in past decade. 2023 survey shows 47% of Gen Z and millennials in urban India are currently on therapy or taking medication, a stark contrast to previous generation. Redefining therapy, what young Indians want. Trauma-informed care, telepsychiatric revolution, building resilience. I think sleep, hygiene and physical exercise should be a part of the prescription. It should not be like, it's like a medicine. We should focus on these strategies for our children, not from the birth, but also on our prescriptions. When we can write medicine, we can also write about sleep, hygiene and physical exercise. And that is very, very important. Generation divide in perception study insights. Comprehensive analysis of mental health attitude across boomers, Gen X, millennials, Gen Z. Gen Z primarily learns about mental health through social media, while older generation learn traditional channels, friends, family, and healthcare provider. I didn't attend the session where there was a cortex method and the social media influence on psychiatry, but I think it's very, very important because most of your Gen Z and Alpha clients are going to see you online. What is your online presence? Do you have a website? Do you have an Instagram page? What do you speak? How do you connect to the younger generation? Then only they will come to you. Otherwise, they will not come to you. So your online presence, social media presence is very, very important. And it is not a Google profile. It's actually a must because Gen Z, Alpha, all clients search you not only on Google, but also on AI. They will also ask, this is a very interesting thing. You can ask about yourself. Who is Dr. Mohit Shah, psychiatrist? Write on ChatGPT like you can do for yourself. And you will see it will collect all the information from your Google reviews and your website and it will something say about you. Lot of kids have told me that we have searched you on ChatGPT and Google or whatever. And we read about whoever we want to come. So it's very important to have these presence. The paradox, loneliness is an overconnected one. I have 500 Instagram followers, but no one I can tell. Call at 2 a.m. when I'm struggling. Everyone looks perfect online. I feel broken for not being happy like them. It's a very, very common problem that Gen Z Alpha kids have these days. Future of psychiatry in India, increase awareness, reduce stigma, technological integration, tailored approaches.
Thank you, Dr. Mohit, for an excellent presentation and a very wonderful and apt poem. One of the observations that I noticed across all the differences between all these generations, one of the commonality is that the previous generation looks down upon the next generation.
लेक्चरच्या बाबतीत म्हणजे रिकवरी ओरिएंटेड प्रैक्टिस से बहुत सारे दोस्त सुबह से बोल रहे कि कौन सी रिकवरी करने वाला है, मतलब पेशेंट के बिल की रिकवरी करने के लिए कुछ टिप्स बताने वाला है क्या, वसूली भाई जैसे. तो मैंने बोला यस मैं वसूली भाई हूँ आज, लेकिन टॉपिक डिफरेंट है. रिकवरी ओरिएंटेड प्रैक्टिस इज द thing I am going to talking about patient care and rehabilitation as the topic. First of all, I would like to thank the organizing committee for giving me the opportunity to speak on this interesting topic, which has also encouraged me to reflect on my own style of clinical practice. From symptom control to the life worth living, that is the shift we are talking about. Think of one patient in your practice who is stable on medications but not really living. The person is who we are here today we are talking about, right? So that is about recovery oriented practice. We need to go ahead. How many of you already asked patient about their goals in life? 75% of the patient has in India having a treatment gap for severe mental illnesses. Less than 15% of the persons with schizophrenia are in regular employment, and 60% report poor self-esteem, shame, perceived discrimination. So this is the scenario in India. 75% treatment gap, most of the patients never reach care even among treated patients, and less than 15% are employed, and many continue to live with stigma and shame. The thing is, symptom control alone is not enough. Doctors often ask to the patient or think about symptom relapses and admissions, but patients always measure about ability to work, relationships, social acceptance, and meaningful life. So definitely, what does recovery look like beyond symptom control? Let's look at the real case of Ramesh, where in generally we practice traditional care of treatment. That is, has anyone ever told a patient this is a chronic condition, you will need medications lifelong, and hope leave their eyes? Most of us have. The illness model is necessary but insufficient. Symptom control is poor. Floor, not the ceiling. We need to ask what people are living for, not just what they are suffering from. So this we are doing from a traditional model of treatment since eras, and we have learned this in the practice in the colleges also. This is a case of Ramesh, 32 years old, on olanzapine 10 mg, no active psychosis, no admission in 3 years. Mother brings him, he says, "Theek hu sir." How many of us would call this as a success? Most will not, has not worked since first episode, sleeps till noon, no friends. A family says he just like that now. Mother asks, is that recovery? Ramesh has clinical recovery. Yes. He does not have personal recovery. That gap between stable and living is exactly what we are here to address today. So recovery is a lifelong journey with setbacks, not a linear path, right? So this is a clinical for families who panic at every relapse. When a patient relapses, how do we frame it? Do we say, feel you are back to square one? Or do we say, this is a part of the journey, let us understand what happened and move forward? Families need to hear this explicitly. A relapse is not end of recovery. The way we respond to the relapse is actually part of recovery oriented practice. So in 1990s, if we see the history of psychiatry, WHO showed that 50 to 60% of the people with schizophrenia show significant improvement over time. This destroyed the idea that schizophrenia is always a chronic condition and progressive. An Indian anchor in India, 2070, the MHCA enriched recovery as a legal right of the patient. we are not just following the trend, we are implementing a law. So goal is to symptom remission versus meaningful life. Both matters, yes, both matters. But the question we start with changes everything. We are asking, has the psychosis resolved? Or are you asking, does this person have a life worth living? Expert rows in the chart shows that in recovery oriented practice, the patient is expert of their own life. We are expert of the illness. We need both expertise in our clinic room. This is one that changes family dynamics completely. Relapse is not failure actually. It is information what triggered it. What do we adjust? The journey continues. So I am not asking you to abandon the medical model. I am asking you to use both columns simultaneously. The left column keeps them safe and the right column gives them a life. Which column does you currently practice in your OPD? Just we need to introspect on that. So Drake, Bond and Benjo gives us a simplest operational framework, that is opportunity, support skills and support and skill. All three are needed. One alone does not work. Opportunity is if we keep patients in sheltered environment and low expectation programs, we are denying them opportunity. Open the same doors everyone else use, that is real jobs, real education, real relationships. The research shows patients do not do worse, they do better even. So support is especially in the early months of new role, job, marriage, education. The person needs a safety net, not a surveillance only. A safety net, family, case manager, peer worker, crisis line. So this is where the skill comes into the action. Social skill, the illness management, the money management, job related skills, occupational therapy, community programs, family modeling, these can be prescribed in our OPDs. So this is the CHIME framework which is useful in our day-to-day OPDs and practice. We can practice in a short period of time. CHIME is a practical vocabulary of personal recovery synthesized from 97 studies. This is not opinion, this is an evidence. The key instruction in that, do not use this as a checklist, use it as a listing frame. When your patient talks, which letter are they speaking to you today? Example, if a patient says, I feel like nobody cares about me anymore. This is C, that is connectedness. This is your intervention point for today's consultation, right? So another example, like a patient says, what is the point of all taking these medications? So this is M, or E, that is empowerment. Engage with that, not just the side effects. So we can connect with these letters, what patient is talking in my current consultation. So print CHIME this in your card, put it in your OPD desk, glance at it between the patients, so that we can have a different conversation than routine. कानात आवाज येतात का आणि संशय कमी झालात का आणि गोळ्या घेतात का. So you do not ask all 5 questions every visit. You pick one, you rotate over follow-ups. Each question takes 30 seconds to ask. Listening takes only 1 or 2 minutes. This is your CHIME intervention. C is who can you call when things get hard? Simple. It is diagnostic. If they cannot answer, you have a clinical finding. H is what would a good year look like for you? Opens goals. Goal setting. The answer is your care plan for the next 12 months with the patient. I is what did you enjoy before the illness? Identity recovery starts here. Painting, driving, cooking, that patient says to us. These become therapeutic prescriptions. What gives you a day a purpose? That is a meaning. If the answer is nothing or just taking medicines, you have identified a major recovery gap that you need to address in your OPD consultation. So this is a 32-year Meena with a case of recurrent depression in a partial remission by standard criteria, but she describing anodea, loss of identity and social withdrawal. The illness model says optimize the antidepressant, recovery oriented practice asks something different. So walk through the 3 columns left to right. If you that says column is the most of us would do, not wrong but incomplete. That is optimize antidepressant, declare partial remission, schedule follow-up in 8 weeks, advise exercise, keep busy, आराम करा, फिरा, थोडंसं चाला, नीट खा, व्यवस्थित जेवण करा. Column 2 says not notice these all questions, not directives. The recovery conversation is fundamentally curious, not prescriptive. That is what matters most to you right now. Tell me about painting. What did you last feel like yourself? What would a good week look like for you? What small step can we take together? So the action emerged from Meena's own stated values, painting, friends. We did not impose goals on her. So goal means resume painting 1 per week, behavioral activation around values, peer support group for depression, and shared medication decision making. That is the goal of that consultation. So patient is improved clinically, but more importantly, Meena is living again. This is a recovery outcome. So this is the case of Meena in our OPD. She has painted these glass paintings in our OPD, and we are hanged in this is in my chamber, where she has started painting, and she is pursuing a job of a professional painter nowadays, and we have given a contract of painting for our new clinic. So she has painted all these things in our OPD.
Let's
distress symptoms and fewer psychiatric hospitalizations. It mitigates the severe cognitive decline in patients of schizophrenia, leading to which can cause memory impairments, language difficulties, and accelerated by chronic isolation. It elevates the subjective quality of life, increases residential stability, and builds self-worth. And it counters the severe health risk of isolation, which can match the mortality impact of heavy smoking, helping patient having a good quality of life and increased life expectancy. So these are the benefits of social integration in patients of schizophrenia. Now, what are the next gen approaches in rehabilitation of schizophrenia, particularly in terms of newer developments in our field? And there are next generation pharmacological treatments like TAR agonist, TAR1 agonist, glutamatergic and anti-inflammatory drugs. We can have personalized medicine for, or pharmacogenomics can be used, tailoring the medication based on genetic profile of a particular patient. Then you have neuromodulation and non-pharmacological therapies like DMS, DBS, deep brain stimulation, or the brain stimulation technique can be used to improve the negative symptoms and in patient of schizophrenia. Then there are psychosocial interventions like and digital therapeutics like cognitive behavioral therapy in psychosis, family support, and virtual reality and chatbots. So this can also be the emerging techniques of social integration and vocational rehabilitation or training. What is TAR1 is the trace amine associated receptor agonist. They regulate monoamine transmission like dopamine, serotonin in the brain. Unlike traditional antipsychotics, they modulate rather than strictly block the dopamine receptors, preventing cytostimulants in these dopamine spikes. It can be used it is investigated as a next generation treatment for schizophrenia, and these drugs which are under evaluation of the Alteront and Ralmitaront. So they are still investigational therapies. Then we have glutamatergic gonad modulators mechanisms. Glutamate is the primary excitatory neurotransmitter in the brain, and many disorders like portfolio schizophrenia are linked to hypofunction of the NMDA receptors. Glutamatergic modulators aim to restore the excitatory inhibitory balance, and therapeutically has a benefits in cognitive deficits, negative symptoms, and treatment-resistant aspects of psychosis. Key compounds in this already we have N-acetylcysteine, memantine. These two drugs are there. Then brain stimulation techniques, as I said, is TMS can be used to moderately reduce the persistent negative symptoms in patients with schizophrenia. Then structure aerobic exercise, it's found to regular scheduled physical activity like brisk walking or mind-body exercises has strong meta-analytic evidence for reducing apathy and raising the baseline energy level. So regular exercise, physical exercise, definitely.
Take care of our elderly, because that's really important, because not only that their care is important, but a good quality of life to be given to them is very important, and that I think impacts the family, the children, the whole society as a whole. So starting with the presentation, maybe I can make you all think of a lady who is around 80 years old, and she stays with her daughter-in-law, and her son works abroad. Daughter-in-law alone is managing her own professional life, the children, and this elderly mother-in-law of hers, who is in the second, she started forgetting things, she started having difficulty in following certain things at home, but at the same time, daughter-in-law does not know how to seek help. So they stay in a rural background, wherein there is hardly a general physician who is there. The physician has said that she has started showing signs of dementia, and she needs to take her to a psychiatrist or a neurologist. But the daughter-in-law is clueless as to how she will manage this. To get an appointment with a neurologist, psychologist, she has to travel like some 100 kilometers away from the village, and that's really impossible for her because it's difficult. So she's got an appointment 6 months later than what she is today. So 6 months she'll not wait to just look at what's happening with her mother-in-law, but she's stuck as to there's no help. So today I will talk to you all about, so why are we conversing about it now in 2026? Because life expectancy has gone up. We are having a lot of elderly people, a lot of them getting diagnosed with dementia. So looking at the global burden, dementia is the 7th leading cause of death globally, with almost 57 million people affected in 2021. WHO action, as per the Health Assembly was held in May 2025, it extended the global action plan on dementia from 2025 to 2031, and saying that the world currently is drastically short of getting to those demands. India alone is housing around 8.8 million people with dementia, more than 60 years of age. This is projected to probably double by 2050. And as far as the policy is concerned, as of 2026, we don't have any policy, any national dementia policy released as such. Despite ARDSI had put up a document in 2018, but nothing has been done so far. Indian numbers are actually bigger than we thought of. Almost 7.4% are having major neurocognitive disorder. 17.6% have mild neurocognitive disorder. 8.8 million people are diagnosed with dementia, as I said earlier. And the annual household cost of taking care of a patient with dementia is almost $571 US. So why are we speaking of long term and not short term, and why integrated? Because dementia, as we all know, it's not something which is episodic or something acute. It's something which is going to go on for decades. Once diagnosed with dementia, we do not know how many more decades are we looking at of taking care of the person. So we are talking of a long-term trajectory. Sorry for that, a little bit of overlapping. So basically, as it is a long-term disease, we are supposed to talk of a long-term trajectory, and integrated because it's fragmented way of delivering the treatment. Like a general physician will see, and then a neurologist will see, and then a psychiatrist will see, where the information is getting lost. That's a fragmented way. It's giving a lot of diagnostic delay. It is causing a lot of crisis in hospital use only. and majorly it's leading a caregiver collapse. What integration means is two ways, horizontal integration and a vertical integration. Horizontal would be the integration starts from the health sector, social sector and goes to the community sector. And when I say vertical integration, it goes from the stages of the way the dementia is progressing in different stages like primary, secondary and tertiary. WHO's vision is that they want to deliver care as close to home and it has to be integrated and not fragmented anymore. The main four pillars of any integrated model should be that there should be an early detection and timely diagnosis, for which there has to be an entry point where someone has detected and has diagnosed. From there it travels to case management and case coordination, because that one point, the doctor who has diagnosed it has to really coordinate it well and has to manage the case so the information is not lost anywhere and passed on to the further doctors. Caregiver support as a clinical intervention. This is very, very important because until and unless a caregiver understands what the condition is like, it's difficult for us as doctors to function because they are the ones who are the real supporters to us and we have to support them. And community embedding, creating dementia-friendly neighborhoods, daycare, respite centers and end-of-life care over into local life. Now looking at the global standards, what's working abroad, these four models which I could get. Netherlands, they have clinical case management embedded in multidisciplinary teams. They have neighborhood-based nursing cooperatives and high caregiver satisfaction. There is a dementia village they provide. They have built environment-friendly like dementia village for the patients with dementia where they can live their life in a very safe, controlled environment. They are themed houses, they are themed grocery shops, they are themed areas to take walks. So they have actually made this dementia village. Japan has given a lot of importance to caregiver support. I think they have done a good job in giving support system to patients with dementia. And that is what matters because what they believe is until it has reached a level of severe dementia where the patient has already started having mental health symptoms, like psychological symptoms, till then those patients with dementia should not be treated as under mental illness. And UK and NHS, they have memory clinics, they have nurses, dementia-friendly cities. It's a comprehensive state-owned continuum of care. What is common between all of them is that the state has taken ownership of all of this. The family feels supported and not substituted. The Lancet Commission 2024, they came up with a nice, it's a study which showed that certain things can be prevented also. So they came up with a study where it showed that almost 14 modifiable risk factors were accounting to almost 45% of preventable dementia globally. The two new factors which they added in 2024 were untreated vision loss and high HDL cholesterol. They said that these were the factors contributing to dementia. And this has got high prevalence in such countries like the low middle income countries. So we are one of them and we actually can prevent if we know the preventable risk factors. So going through the life course, early life, midlife and late life, what are the risk factor distribution like? Early life is mostly less education, the single most impactful early risk factor. Midlife mostly let's say they got was hearing loss, hypertension, smoking, obesity and depression. And late life, like elderly, mostly like late elderly, social isolation, air pollution and vision loss. Now, how is the Indian care landscape? It's more of a patchwork, not a system yet. We know that everything is available around us, but it's not integrated enough. It's still in a patchwork system. We have our DMHP, District Mental Health Program, present in almost 750 districts, but dementia-specific budgeting is not there. So dementia has not come under the program as such, so there is no ring-fenced budget for the same. Memory clinics are present in cities. Nimans has got SCARF, AIMS, Chennai, but these are inaccessible to people who are probably staying in rural areas or even other cities which are just difficult to travel for the people. Pioneering community models are also there, like ARDSI, Kochi, 1992 was formed. In my own hometown, 1066 Goa Home Care RCT was in 2008. Kerala State Initiative on Dementia was the first private and public program in dementia. They have private assisted living, they have also come up with private assisted living like Atulya, Nightingale, Epoch. They're rapidly expanding but very unaffordable. For people who cannot afford, it's difficult. So coming to this study, which was done in Goa. In this, what they did was, basically they took a group of home care advisors, lay people, there was a counselor and there was a psychiatrist involved. They trained the home care advisors in order to check on the patients, in order to train the caregivers, in order to help the caregivers went out at times about what's happening at home. And what were the outcomes? The outcomes what they got was that there was significant reduction in caregiver mental health, mental distress. There was reduction in caregiver burden and reduction in behavioral distress. Why it mattered is it demonstrated that task shifting in dementia works very well. It reduces the caregiver collapse. This was then replicated and adapted across multiple Indian cities, served as a foundation for staff dem care in Chennai. This proved that a lay worker with supervision can meaningfully reduce caregiver suffering at a fraction of specialist cost. This is dem cares in Chennai, SCARF. So they have got a memory clinic, a daycare center, a residential unit, and a caregiver support. So it's like a comprehensive service package which you get. Sustainable, it has got a sustainable funding model. It is very well set up, and it also helps in research. But then again, the thing is that it's highly accessible for people who cannot really afford. It's only for people who can afford probably. So we have to come up with something which is affordable to people also. Kerala State Initiative on Dementia. This was the first private-public program. It leveraged Kerala's pre-existing palliative care infrastructure which they already had formed. We have, the lesson what we learned from here is that we have the readiness, but we have to just get it all together, integrate it together, and we will start working. What KSID did was, it created awareness, community level awareness of dementia basically, and made more people aware about dementia and what it is to have like dementia. Primary care training, they trained ASHAs and primary care doctors in dementia, so they could recognize the first symptoms and probably identify that yes, this person might be having a mild neurocognitive disorder. They have a dedicated daycare, dementia-specific daycare centers providing structured activity and respite. And finally, very important, the family support. So the economic case, if we see why integration is going to pay for itself, it's a huge cost. Almost, today I said $571 US annual family cost. If you have to keep a caretaker at home, it's costing nothing less than 30,000 to 60,000 per month. Because like the normal nurses who come to stay at home to look after the patients, they're like charging something between 30,000 to 60,000. And with institutional memory care, then something between 60,000 to 1,50,000, which is like really high on pockets.
Where they do kind of club seniors with kids to take care of each other and learn from each other, and that does happen in a lot of European countries, Australia, etc. What are your thoughts on that?
Feeling and behavior completely goes on a toss, and the person will not think of what is good and what is bad, but he might do something which is a criminal act also. And that is the reason when insanity defense, can it be applied only under intoxication? Because even in sobriety, when the person is in post-acute withdrawal syndrome, he could be pushed into behaving something in a way that it could be labeled as unethical. And these are the whole bunch of observations that were coming up when the neuroscience was learning. So how would the ideal rehabilitation center look like? So obviously, I'm not going into the details of it, but the WHO standards, Mental Health Care Act standards have to be there. The rat garden learning tells us that we have to make it conducive for growth, for happiness. So generally accepted distribution of area is whatever living area, whatever treatment area there is, 20% indoors recreational area and 20%, which is minimum, okay, outdoor recreational area is a must. Okay, so if you want to have change in the way you are treating addicts, the first thing is the architectural change. That you need to provide spaces for recreation where the free will probably will be nurtured. Then options for engagement of care in accordance with the stage of change have to be there. So you cannot have a standalone rehabilitation center. So you have to have options because the patient is not going to come only in action stage to you. So you have to have high intensity, intensive outpatient programs. You have to have intensive outpatient programs. You have to have halfway homes, and you have to have community support. And then we have the evidence-based neuroscience or cognitive psychology-based approaches for treatment. So we say that the problem is chemical, okay? And then can we alter the synaptic response, which we tried to alter right from 1990, okay? Then we said, can we stop the vulnerability effect of stress genes? Morrow et al. Give a very good understanding of how the demethylation and methylation of the vulnerability genes for addiction can be controlled, and there are ways and means of stopping these things to become to open up the vulnerability genes, and that way of intervention is called epi-drug intervention. So epigenetic influences can be blocked by this drug. So this is something like immunization that can work like immunization. Can we alter the default mode network? Because we know that with chemical changes, the brain's neurocircuitry changes, and brain's neurocircuitry further affects the electrical conduction of the brain, and this electrical conduction further enhances the electrical conduction deformities, and these defects keep on going in that particular direction, and whenever the person is not thinking about anything or is challenged, the brain networks go run amok. And that is the reason when the DMNs and ERPs need to be altered, then what is it that we could do? And there was a meta-analysis by our own Mehta and Ismail in 2024 and 2025 talking about dorsolateral ventral pallidum being the site for introduction of these technologies. Can we alter the learning of neurobiological circuitry? Now, this neurobiological circuitry affects at the unconscious level. So that is where cognitive bias modification and virtual reality based applications can be amalgamated together. And there is a wonderful review by Tobin in 2022 where it's in fact a meta-analysis. Can we alter the second messenger system? Because I always ask my patients, when did you learn to drink the way you are drinking? So firstly, when I ask them this question, they can't answer this question. So are you asking me when did I first drink my alcohol? I said, no. But when do you think you started learning the wrong way of saying? What is wrong way? Do you think that your friends, your family members drink the same way? They said, no. So I said, when did you learn the wrong way of learning? And then they have to think and they tell me that the answer. So what it means is that the neurotransmitters change even after one sip of even a small exposure of the substance. But what happens later is stored in the messenger RNAs which reach out to the nucleus and bring about a change in the protein synthesis, and that reflects in either the enhancement of a particular system or depression of a particular neurotransmitter system. So what are the ways in which we will be able to manipulate the second messenger system? That is something that we started learning on. And that is where the anti-craving medicines came in. Okay, so though we say that naltrexone is an opioid blocker, I believe that very soon we will come to know that it has multiple mechanisms of actions, and I would not be surprised if it has an action on the second messenger system also. Can we enhance pro-social behavior? Then Blumenthal in 2023 wrote on how oxytocin and vasopressin are associated with pro-social behaviors. So in fact, in an addict rat, when you give vasopressin, not only does the craving come down, but the rat starts mingling more with other rats. So pro-social behavior increases and the cravings come down. So we started knowing so many things about different aspects of an addict mind, and those became the targets for innovative care. So the future of substance use disorder treatment would look something like this. Now, out of this, you can understand that the first block, genetic screening, second block, neuromodulation, third block, prescription, all these three blocks, if we focus on these things, we will become traffic polices. Okay? Now, we have to understand that genetic screening is done in the laboratory, but we have to just write it down on the prescription that do the genetic screening. So what it means is that where is the mental health professional will be, his services will be used maximally. So this any physician also can write. But where is it that a physician will fall short and a psychiatrist is likely to have an upper hand? And I see that the last block, trauma-informed care screening, mindfulness-based interventions, and of course pharmacotherapy-assisted psychotherapy, these are the interventions which probably would not be given by non-mental health professionals. So we know that many a times it is said that, okay, what do we do with substance use disorder? But let me tell you that nearly 40% of addicts do not try out sobriety because they are scared of withdrawals. And whatever medicines that we have for withdrawals have contributed to nearly 40% of benefits in sobriety. So what it means is that just because we have withdrawal medication, we manage withdrawals better, more addicts are recovering. Okay, so counselors many times they don't understand this because they feel that the relapse has happened after 3 months, and what was the psychiatrist doing after 3 months? So we have to believe that improvements in withdrawal management have contributed to recoveries tremendously. The second is, what do you do under intoxication? Okay, so there are innovative ways of managing intoxication, managing withdrawals, and then we have the world of anti-craving medicines. So there are about 13 FDA-approved meds for opium, nicotine, alcohol, and non-approved for cannabis also, stimulant use, stimulant cocaine and methamphetamine, and inhalant use disorders also. I will not go into the details, but Shen et al. In 2018 gave a very wonderful review. I just put it on a table so that the drugs and the mechanisms of action. So you can see how many different new targets that we have been able to identify. And the reason why we are not getting a single target is because addictive disorders are multi-targeted. They are targeting multiple neurotransmitter systems in multiple areas, in multiple genes. I will not go into the details. I know I have to finish in time. Then Motto and Maula in 2025 talked about, again, after 2018, they felt that, okay, 7 साल हो गया, फिर से review करना चाहिए. And then they reviewed this and they found that in alcohol, there are certain changes that they say in the molecules that we use. What is interesting is cannabis, I have started, in cocaine, I have started citicoline, okay? So many a times you would see Strocid as one of the pill in cocaine addict. And अरे इसको तो stroke नहीं आया है, ये क्या लिखा है आशीष ने? तो Strocid इधर से लिखा है क्योंकि Strocid in about 400 milligrams, and I found that it really makes a difference. So you can try that out. Modafinil I have been using very often, but sometimes people have allergic reactions to modafinil, especially addicts. I have never had an allergic response in schizophrenics, but in addicts, for some reasons, I have had 3 patients who have had allergic response. Cannabis, varenicline, decreases consumption, topiramate reduce stress-induced relapses. So you can try it out and let me know if it is working. I have about 5 patients. They keep relapsing, but the amounts have come down. So absolute abstinence, if we don't keep the criteria of improvement, then we are getting improvement.
20 crore people in this country who need mental health care. Almost 10% of the population has some form of mental health condition, which the National Mental Health Survey has already showed in the first phase. And despite such a huge burden, it's common knowledge that almost 83% people don't get treatment for this problem. So there's a huge treatment gap. Who will bridge this gap? We barely have psychiatrists needed for this. We are far short of psychiatrists compared to the WHO standards or even the high-income country standards. It is sad that if we try to have enough psychiatrists, it's probably going to take us 200 years. Very few hospitals which cater to psychiatry, and we know that they are mostly in the cities, so community gets neglected. And the budget, the money that we spend on mental health is in the fraction of even the health budget. So we hardly have the budget to support this kind of a thing. So if you say that it's only specialists who are going to solve this problem, it's not going to work. Unlike other medical conditions, mental illness is embedded in the community. It's not like a malaria patient you take in the hospital, treat him, and he goes back in the community. In mental health, that doesn't happen because community is part of the illness, where it comes from. Knowing this, we have had this program from the government, the National Mental Health Program, running from the 1980s onwards, and that it got upgraded into the shot in the arm with the district program in 96. Essentially, the services we all know goes in providing OPD level care, having outreach satellite clinics, training of some of the PHC staffs, and creating awareness. We have many of our seniors who have studied an NMHP and made wonderful articles, which we see over here, Gangadhar et al., even Kirpekar sir et al. From our zone. And we also know that there's much that ails our health program, the National Mental Health Program. What are the challenges in the NMHP and DMHP is one which we see is that over-medicalization. We try to treat everything with medicines. So the emphasis on psychosocial care gets diluted or it doesn't exist. Training without sustained supervision. Any kind of training which you give in the PHC doctors or whatever, and if it is not sustained and we do not carry it continuously, the skills are quickly lost. Outreach is not same as continuity of care. We know the most commonest way is doing camps. This health day, that health day, and we'll do a camp on those things and kind of a thing. They really do not have any lasting benefit. Workforce, we said that the challenges in workforce and then getting the right kind of people to meet this specific needs is a great challenge in itself. And priorities sometimes just become targets and goals and numbers and timelines without actually looking at the clinical outcome, the functional outcome, the rehabilitation. So the program largely decentralizes prescriptions but not necessarily care. So we have had international bodies, the WHO, the Lancet series, and all have said the same thing. Mental health care needs to go into the community. We have to look at newer ways of delivering this care. The care has to be right-based. It has to be based on functional outcomes. This is a very wonderful review article where Gundi et al. Has studied almost 41 different kinds of community-based interventions, and everyone says that you need to have some kind of work that happens in the community to community health worker and task sharing. So what are the models of care that can really deliver this care into the community? What are the different strategies that can be used to deliver care at the community level? Take psychiatry from hospitals right to the community. One of the most model which has increasing evidence is your task shifting and task sharing models. We require it to be a collaborative care where care is integrated right into the community PHC levels. Stepped care so that based on the level of the illness, the care moves up the chain from primary to secondary to tertiary. Peer support we heard being spoken in some of the talks before. People with lived experiences providing care to those who have this kind of who need help. Community outreach teams are very much essential. I think the talk after this is on ACT, so that we'll talk about, and social prescribing models wherein you use resources within the community to provide care, such as faith institutions, self-help groups, NGOs, etc. So what is the evidence that these models will actually work? Where is the evidence? So I'll just go through a few slides to say whether these things work. Way back in 2007, 8, 9, this was the first trial, a cluster randomized trial, which was done in Goa. And it tried to use lay health workers who were trained to provide basic counseling services, and they were put in the PHCs. And the control arm did not have lay health workers. And at the end of the trial, it was shown that lay health workers can deliver simple interventions which improve health outcomes for patients. And not only do they improve health outcomes, they are acceptable, they are feasible, and it improves the overall morbidity. The World Health Organization has come up with guidelines structured so that they can be utilized at various community levels. It is called Mental Health Gap Action Program in this guidelines. So there are various guidelines given. It's like an algorithm. If this is there, what do you do? If next, then where do you send? So there's a very structured way in which you can, and this plays a great role in kind of making standard models of care. This is just an example of something. Anybody is interested can download all of these articles. They're open source articles. Now, how do you integrate this kind of services into the community? Prime was a program for improving mental health care. So it was studied in 5 different countries, in African countries, in Nepal and India. And they tried to integrate a package of mental health care into the PHC level. So this was started in MP in Sehor district, and it ran for almost 10 years, recently concluded, and it gave us wonderful insights into can we really integrate mental health care right into the PHC level? Can it be plugged into the PHC level? And they established Manakakshas, that is a space where mental health can be provided, and they said that you require a case manager to handle and deliver these things. They also found out challenges and roadblocks. Implementing mental health care right in the community has got huge problems because the systems are not ready. There's a resistance. They feel they are under-trained. They don't want to take the responsibilities of added mental health care. And the training of the people who are working in the community was very important. So this initial study showed that it can be done. Collaborative work can happen, but there are challenges. One of the challenges was training the community people. So then comes the Essence program. This is a program wherein they try to use digital platforms in which simple counseling packages were delivered and trained to peripheral workers, such as the ASHA and Anganwadi workers. And it showed to be just digital platform versus face-to-face training, and it was as good as face-to-face training. So it means that you can train community health workers simply using digital platforms. This was the same Empower, this is an Empower project initiated from the Harvard Medical School by Vikram Patel and his team. And the idea is to create programs by which community health workers can be trained to deliver interventions just using digital medium. I want to present a study which was done in MP using this. Ravi is already over here who's written this program. What was done in this is that the ASHA workers using a digital handheld device were given training on simple counseling, that is for depression and anxiety. After being trained, they were also provided remote monitoring and supervision for their ongoing training. And once they were sufficiently trained, they went to the community and screened the people for presence of depression or anxiety. And once those who were identified to have depression or anxiety were delivered the intervention, the ASHA workers were supervised when they were delivering these interventions. They were given a support system. After 6 to 7, 8 sessions, the outcome was measured. Those who needed more were given 2 additional sessions. Those who did not improve were sent to the referral chain of the health systems for higher level of care. 1,000 ASHA workers were trained using digital medium, and almost 94% completed the training. 18,000 people were screened. 2,000 people, more than 2,000 were found to have depression, anxiety. 13,000 counseling sessions were delivered. And at the end of it, it was found that this was an effective program with positive benefits, which also showed lasting effects at 9 months. In addition to that, what is more important is it acceptable? Is there satisfaction by the person who's delivering and who's receiving, which again scored at 4+, which is a very high level for the study. So this shows that it's possible to train frontline workers at scale, and which is a big challenge. Doing everything at scale in such a big country like ours is very important. This is another study which was done by Soumitra and his team in Gujarat. Here, a community volunteer was chosen and given basic training in counseling for 4 to 6 sessions, and it was mostly addressed common social problems of domestic violence, family conflicts, unemployment, alcohol use. So this was a program which tries to see the social determinants of mental health and tries to see. In addition, the volunteer, also called as a champion, tried to work with social agencies and try to provide disability benefits and other benefits to the patient. And again, this model showed that using volunteers really helped because they come from the community and they're acceptable to the people. You have the Niemann's Digital Academy, which is doing a very unique project, the Project ECO. That is the hub and spoke model. We spoke about training the peripheral level workers. What about training of medical officers? One of the biggest problems in medical officers is that they say, the confidence of treating mental health conditions is not so robust. So there's underconfidence in identifying and treating mental health conditions. So this is a hub and spoke model wherein a psychiatrist actually works with a physician in his OPD in a case presentation manner. There's only discussion based, no didactic lecture series. This has got very strong evidence, and giving the doctor the feedback and the discussion matter, the confidence level really rises. So this is a unique kind of a training, and it also helps to retain skills. So multiple such trainings have been ongoing and are still continuing. How will technology work in delivering community-based treatments? We very well know the Telemanas program. This is the 14416 telephone number that you have. And it's widely used across lakhs of people, especially during exam times. It's very handy. And this came up after the COVID crisis, when there was found that there's a huge mental health crisis and there's no way of addressing it. The system works to you call in, and there is an interactive voice which guides you to a matched counselor where you can get access to your basic needs. In case the counselor cannot assist you and give you the certain kind of support that you need, the case can be escalated to a mental health professional. From there, it can be further escalated to a video-based teleconsultation, and then it can be escalated to the next stage of in-person consultation. So now the Telemanas program is being tried to integrate into the DMHP. It's become the technical arm of the DMHP program. The number of platforms which are out there, the government-backed eSanjeevani or the private ones like Practo and all others, which also work on similar lines and can provide you care right in the community. That is, the patient doesn't need to get to a hospital. The multiple AI-based apps out there, a host of them. And there's still, and so many more are coming, and you can talk to ChatGPT and ChatGPT will keep advising you, so this can happen. We had a unique case of one person even committing suicide after being guided by ChatGPT. Where it works best when there is follow-up in stable patients, medication titration for patients that you already know, remote access where there is no psychiatrist, definitely it works. Triage AI can work by using automated questionnaires and finding out who needs care and at which level, and you can signpost them. Low intensity interventions can be delivered using these platforms, and of course for training and capacity. It does not work for complex cases firsthand. It's got its own challenges when it comes to suicide and aggression. And usually when there's no human in this loop, the engagement usually drops after 2 to 4 weeks. Why community care usually fails is because if there's only medication and no psychosocial intervention, there'll be a problem. Training without supervision will be a problem. If there is outreach where the DMHP team visits just once in a fortnight, once in a month, again, there's no continuity of care. Administrative focus rather than clinical. So how we need a system which will address all these things. And what do we do in the current scenario? Now, Government of India has announced its flagship program, Ayushman Bharat. And this is for us all to know that it can be a potential game changer because it has got all the elements which I have spoken about in all the evidence that I've showed so far, what we need. Ayushman Bharat works on 3 prongs. One is the Ayushman Arogya Mandis, which is run basically by the community health officer and staffed by ASHAs and other community health workers. This is focused on giving you primary level care. The Pradhan Mantri Jan Arogya Yojana, the insurance-based arm of this program, which covers almost 22 illnesses, gives you secondary and tertiary level of care. The Mental Health Care Act also says that there should be insurance. So, and insurance mental health has been covered now. And the third is the digital mission. And once this actually works, I mean, there are challenges in this. Each one has an ABA card, ABA ID, and everything gets loaded onto the on health management systems, and everything once integrated. So this is a futuristic program, but the first 2 are something that we need to work about. What will the Ayushman Arogya Mandis, the health and wellness centers, early identification, that's what we need in the community. Basic management, again you need in the community. Basic interventions like the Manas intervention, which I spoke about, can be delivered in the community. Follow-up, which is so essential, and we who work in hospitals know that once you discharge, very often we lose our patients because they don't come back, or again they come back in exacerbations. Follow-up in the community is very essential, which can be done at these health and welfare centers. Health promotion, this is again the basic thing of creating awareness.
At Sevagram, we have a psychosocial cell where we take the concerns of students. And I got a referral from some students that there is a girl who wants to see you. She's been in a bad shape and she has not been attending the OPDs, not doing the postings and all. So we would like to send her to you. She was persuaded by her parents, she was persuaded by her colleagues. Everyone was telling her, please go and see the psychiatry department, see the psychiatrist. We think you need help. It still took her 2 to 3 months to make up her mind to traverse the distance of 100 meters from the hostel to the psychiatry department. And another anecdote I want to share is my patients who I usually tell them, why don't you come regularly for the follow-ups? You should, because otherwise the schizophrenia, bipolar disorder, it gets relapsed again and again. And I sort of become a little angry on them in the OPD. But I said the consultation is free, the generic medicines are available, you are being treated almost free of cost. They said, but the travel cost, sir, we have to change 2 buses. It takes almost a day before we reach from our village to your hospital. So how can we come? It takes us a long planning to come over there. So we see in this gathering all esteemed psychiatrists. Yes, the number of psychiatrists is low, that is a challenge. But yes, there is also one more issue, is that in the rural sector, in the tribal areas, the specialists are not available. Even if the motivation is there, even if the knowledge is there, even if the awareness is there. It is as if the door is open, the way is known, but the person doesn't have enough morale or motivation or enough ability in him to reach out to the psychiatrist. And that is what was identified by Leonard Stinn and Marianne Test. In 1970, the era of deinstitutionalization began. We are all aware of that. The patients were discharged and were being asked to stay in the community now. They will not be incarcerated in the asylums. But a very strange problem began to happen. This is called as the problem of revolving door. We all came inside through a revolving door, right? So patients went into the community from one side of the revolving door and they came back from the other side. The reason was staying in the community wasn't so easy. Most of them wouldn't take regular follow-ups at the psychiatrist. Most of them were not able to organize their stuff well so as to do simple daily activities. Many of them were not able to handle their emotions well. Many of them were overwhelmed by the small problems which otherwise a normal person could easily steer through. And that problem was identified. People found that medicines are not largely ineffective. Medicines are effective, but whole lot of other things are required for a person to take a successful psychiatric treatment or to have a good mental health outcome. And from that viewpoint, a multidisciplinary and a multisectoral approach was weaved in this. I think this was in the Mendota Hospital in the Wisconsin County. It started in 1970, and from then, the assertive community treatment has been practiced in about 10 to 15 countries across the world. It is not very well in force in our country, but it is there in 10 to 15 countries, predominantly in the US, where there are more than 1,500 centers of this ACT. What are the main highlights of ACT? It goes far beyond just giving medication, and it can assist the patient to take medication. It is like a psychiatric nurse will visit the house of the patient and will help him to sort the tablets and to take the medications. A psychologist can visit the house, go to the patient and take care of the excessive emotional outbursts or anger outburst or any psychological problems that the patient is having. The hallmark of this approach is that this team, a multidisciplinary team, is assigned only a limited number of patients. The ideal ratio is 1 to 10, but not all centers are following it. Most of the centers, for the want of resources, we all can understand. But the hallmark is that a very small number of patients are dealt, so this team is available 24/7 to deliver the care. And as a result, the outcome improve. The care in assertive community treatment is happening everywhere. It is happening in the clinic, it is happening in the community, it is happening even in the home of the patient. It depends on the comfort and convenience of the patient and the classic notion that see me in the OPD. This notion is not there, or this requirement that see me in the OPD is not there, right? So that is why the outcomes of assertive community treatment have been found in the studies to be better than the traditional system. In the traditional system, care waits in the office, services are time limited, and there is a higher dropout rate. And in the ACT, the care comes to the people, it is always available, integrated, and relatively lower dropout rates. Now, this is the ideal form of ACT I put in front of you. But I am sure that most of you by now must be having one thought in your mind, that if it is so good, why it is not there in India, and how can we ever apply? Because all of us are practicing psychiatry and we know the actual on-ground problems of our country when we try to apply this ACT in the ideal sense. We have huge patient loads. I used to work in Sion Hospital, which used to have OPD of 300 plus. I used to work in GMC Nagpur, OPD of 150 plus, and now at Sevagram also, in spite of being in the rural area, the OPD is around 100. So with such a heavy load, how can we expect to give ACT Do we have enough professionals? When we are recruiting for our ICMR project, everyone talk about the deficiency of psychiatrists in the community. But the deficiency of psychologists and the other staff is also even more gnarly. We try to recruit for the projects during our ICMR. At that time, we have the people who apply find it difficult to differentiate between depression and anxiety. So the deficiency of manpower in such an intervention, which is multi-sectoral and multidisciplinary coordinated design, is required. And of course, the cost issue. How to sustain the cost? Anil sir prior to me quite rightly said that a very small amount of budget is allocated to the mental health. 0.16 was the figure he stated. In that, it is impossible to have ACT with the ratio of even 1:100 at that for that being. So that I feel that at present the ACT in its ideal form and the ground situation in our country are a little far away for it to be applicable. But then, is nothing possible is the question. Is nothing happening is the question. And I would like to differ from that. I believe that a lot of things in our country, a lot of research, a lot of the way psychiatric care in our country is evolving is now getting aligned towards the assertive community treatment. When I was going through the protocol of assertive community treatment, I found out the 3 core pillars by which the assertive community treatment works. The first pillar is connectivity. The patient is always connected with the treating team or with the doctor. The patient doesn't have to take huge effort to get into touch with the treating team. In this, the psychiatry is going to the doorsteps of the patient. Patient doesn't have to travel long distance to come to psychiatry. Second is multi-sectoral and multidisciplinary collaboration. And the previous talk we had discussed that only psychiatrists are not going to bridge this gap. So task sharing approach is a must. And third is the caregiver empowerment. Now this fact cannot be understated, the importance of caregivers, and we will discuss how. So I am planning to discuss how the principles of ACT are already being applied, not in an integrated but fragmented manner. And my question to the house would be, how could we integrate all this into one picture so that an ideal mental health care could be provided. Now, we are all aware of telepsychiatry, and most of the private psychiatrists many of the private psychiatrists are providing one-on-one consultation on the telepsychiatry platform. So the model of this is one model of the telepsychiatry. Another model of the telepsychiatry is the one which is being applied in NIMHANS, the hub and spokes model, in which they do case discussions with the psychiatrists, with the health providers at the district hospital and that level, and they empower them to solve the cases. There is one more telepsychiatry consultation model which is in the STEP program of SCARF. In this, there is a bus. In the bus, they have one facilitator, and it is fully loaded with medicines and a teleconsultation platform. And this bus goes into the rural and tribal community. The outreach, they are going to the patient, and there whenever that facilitator brings, he enrolls the patient, and that patient has a direct consultation with the psychiatrist in the hub, that is who is sitting in Chennai. And the live consultation happens, the prescription is given, and medicines are dispensed which are already available in the bus. I believe this is an excellent example of assertive community treatment where there is outreach that is happening from the patient to the caregiver, from the hub to the patients and caregivers. The way DMHP is working is also, I believe, in close alignment to the principle of ACT. in Wardha district, in the DMHP, the ASHA and Anganwadi workers are going to identify the patients of depression in their field practice area. The psychiatrist is going to visit once a week in the concerned rural hospital, and there those patients will be referred and treatment will be given. So I believe here again that task sharing is happening. The Ashas and Anganwadis are regularly getting training in the rural hospital for the psychiatric disorders. Thereby they have started identifying disorders like depression, anxiety, at least screening, and they refer those patients to the area. Nowadays in our institute, a lot of studies, a lot of projects are now concentrated on training the health workers at the PHC level to identify disorders, to use tools. There are simple tools to screen depression, patient health questionnaires, GAD-7. They are now training the health workers at the PHC level to use these tools and try to identify the depression. That way, task sharing can happen and the right referral. So in the hub and spokes model, patient is a spoke, and these are all hubs. Our tertiary care center, district hospital, these are all the hubs. So the patient can smoothly transfer along these lines. That is how also the care is being taken from the hospital to the community, to the patient, which I think is in the spirit of ACT. A lot of NGOs, I need not say, such as Sangat, even Shraddha Foundation, they are also delivering care to the patient. So they are also working in spirit with this thing. One particular thing that I would like to mention is that the National Task Force for Student Wellbeing now mandates Gatekeeper Training Program. Gatekeeper training is the training of the people around a person to identify signs of depression and suicidality. We had started doing this regularly in our college for our students. And this gatekeeper training is one more example of empowering the caregivers. The caregivers, when students are living in the hostel, when their parents are away, it becomes a really burning question, who is the caregiver of this student, especially when they encounter a psychiatric problem. So for caregiver empowerment, the trainings such as gatekeeper training have been mandated by the National Task Force, which was recently formed in 2025, and its recommendations are out. Another wonderful way that is being applied but needs a scale up is disorder specific groups, such as groups of schizophrenia, groups of bipolar affective disorder. Whenever I treat the patients of schizophrenia and bipolar affective disorder, I do tell this line to the relatives that I am only writing the prescription from the comfort of my OPD, but it is you who are actually treating this patient. They have to go through all the antagonisms, all the comments, all those things that are done by the patients, and still take care of him by remaining cool, calm, and quiet. So caregiver empowerment, caregiver burden is real. Of all the studies that have been done till date, a huge amount of caregivers have depression, anxiety. So caregiver empowerment. Whenever we tell the caregivers about schizophrenia, they feel a little relaxed that this is not only happening to me, but it is the reality of the world. So caregiver empowerment through structured psychoeducational modules such as WHO MHGAP IG. I would, if anyone is not aware of it, I would say that it is a free download, and wonderful psychoeducation modules that have been prepared by the WHO, and they can be disseminated to the caregivers for this thing, and that will be in the spirit of the caregiver empowerment as a part of assertive community treatment.
In the human brain, focusing heavily on the synaptogenesis, the neurochemical receptor configurations, and specific monoamine loops. Today, I want to invite you to add a fourth clinical dimension to this, the dimension of time. Over the next 20 minutes, we will unpack chronobiology in modern psychiatry and its community impact. We will look at how a broken cellular clock serves as an upstream driver for severe psychiatric morbidities, how we can quantify them, and why treating this is a public necessity. To explore this field efficiency, I have divided into four major headings. One is the first part will be the central neurobiological anatomy, which is the core sciences. The next part is the clinical assessment. We'll address the bedside diagnostic instruments and objective markers. We will then transition to the chronotherapeutics, which is a detailed practical non-pharmacological and targeted pharmacological treatment intervention. And the part 4, which is the community impact. Before we delve directly into the clinical syndrome, let us establish a rock-solid scientific baseline to what exactly chronobiology is. It is a specialized branch of biomedical science that examines the cyclic, periodic phenomena in living organisms, evaluating how our genetic, immunological, and central neural pathways operate as a complex temporal grid geared for metabolic efficiency and environmental survival. In human physiology, we analyze this temporal network through a strict rhythmic spectrum hierarchy. At the high frequency end, we have the ultradian rhythms, which span cycles which are more than 24 hours. Example like our pulsatile secretion of our cortisol for 90 minutes or NREM, REM sleep cycles. At the macro level, we have the infradian rhythms, which last longer than 24 hours. Such as the human menstrual cycle and the circadian rhythms governing the seasonal affective disorders. But the absolute cornerstone of psychiatric interventions is the circadian rhythm, the master endogenous 24-hour cycle, which controls the human core body, temperature, sleep, sleep-wake cycles, the central neurochemistry of our body. And when this 24-hour cycle uncouples from the external world, mental illness is not just a byproduct of it, it is actively accelerated. Coming to the first part of our talk, how to master the application of the core sciences. We'll learn what the basis of the chronobiology is. The absolute master conductor of the human circadian rhythm is the suprachiasmatic nucleus, which is of course a bilateral structure which contains roughly 20,000 highly specialized neurons situated within the anterior hypothalamus directly above the optic chiasma. It functions as our anatomical pacemaker. It does not run blindly. It requires continuous calibration by external environmental time cues, which are known as zeitgebers. The absolute strongest and the most dominant zeitgeber in nature is of course the natural environmental short-length blue light. When light waves enter the eye, they are picked up by a unique non-visual monolayer of cells, the intrinsically photosensitive retinal ganglion cells or the IPRGCs, which express the photopigment melanopsin. These cells bypass the visual cortex completely. Instead, they project directly via the retino-hypothalamic tract, sending a glutamatergic signal to the SCN. The SCN then processes this photic input and drives our systemic signal output, orchestrating daily variations in our core body temperature, autonomic tone, and global endocrine profiles. This slide brings us to the very heart of clinical neuroendocrinology. In a healthy human subject, biological homeostasis, neuroplasticity, and diurnal mood stability are strictly maintained by a perfect antiphase alignment of two master hormones, melatonin and cortisol. As the chart clearly shows here, melatonin, our endogenous chemical marker of darkness, is secreted by the pineal gland under the direct synaptic control of the suprachiasmatic nucleus. It begins its sharp rise as dusk falls, peaking around 2 to 4 a.m., acting as a powerful systemic synchronizer and as an antioxidant. Conversely, cortisol acts as our biological alertness drive. It drops to its nadir around midnight and then exhibits a massive steep rise, culminating in the cortisol awakening response, the CAR, around 6 a.m. to 8 a.m., priming the central nervous system for environmental interaction. Look at this inverse relationship that they share here. When you examine a patient in throes of acute mania or melancholic depression or borderline personality crisis, you will find that these curves are flattened, blunted, or shifted out of phase. The patient is functionally living in an internal state of twilight with profound neurochemical and somatic consequences. To go into a bit more detail, if we look deeper than the brain structures, right to the cellular level, how does the cell know that what time it is? This is basically driven by a TTFL, or the transcription translation feedback loop. At the genetic foundation of this loop are two positive proteins, CLOCK clock and BMAL1. They bind together to drive the transcription of the period and cryptochrome, which are the PER and the CRY genes. As the day progresses, PER and CRY proteins accumulate in the cytoplasm, form complexes, and translocate back to the nucleus and bind to their inhibitors or activators. The CLOC and BMAL1, this self-regulatory loop roughly takes around 24 hours, and this is the differential equation if anyone is interested is on how it works. Why we must understand this is, as a practicing clinical psychiatrist, because massive genome-wide association studies have been confirming that specific single nucleotide polymorphisms and mutations in these core clock architectural elements such as clock, PER3 and CRY1 correlate directly with rapid cycling bipolar mood disorders, advanced or delayed sleep phase disorders, and severe treatment-resistant major depressive disorder. Is severely out of step with their external environment and social schedules. The downstream effects on the brain are absolutely devastating. This continuous mismatch acts as an upstream structural stressor. It triggers an increased peripheral and central inflammatory markers like interleukin 6, TNF alpha, severely impairs the brain-derived neurotropic factors BDNF pathways, and directly destabilizes the postsynaptic serotonin and dopamine receptor sensitivities. The clinical implication of this neurochemical change is very stark. Long-term longitudinal data proves that prolonged desynchronization pathways triggers up to a 3.2-fold increase in acute bipolar manic states and unipolar depressive disorders. Circadian disruption is not a minor side effect of being ill. It is a primary fuel that burns through our patient's emotional stability. So which brings us to the clinical assessment. Like, how do we take this molecular and neurobiological knowledge that we have and convert it into practical diagnostic protocols? The first step in clinical assessment is mapping our patient's endogenous behavioral phenotype. What we call is their chronotype. This matrix classifies our population into three distinct categories, which are genetically rooted typologies. First, we have the morning larks, whose peak alertness ranges from 5 to 7 a.m. Interestingly, they are protected against depression. They show high susceptibility to generalized anxiety, morning state panic disorders. Second, we have the intermediates, who possess a flexible lower risk profile that adapts easily to standard societal working hours. But our primary clinical focus is for the evening owls. Their peak alertness occurs between 8 p.m. to 10 p.m. These patients carry a heavy, disproportionate burden of unipolar major depression, high rates of substance abuse, experience severe social jet lag. Forcing an evening owl into an early morning routine is a recipe for chemical instability. Our clinical alignment approach must prioritize active phase advanced therapies and structure morning light arrays. Coming to the objective biomarkers. While paper pencil sleep logs have their traditional place in our evaluation, we must acknowledge that in our actual clinical psychiatric practice, subjective patient diaries are very distorted. Okay, especially when the patient is having acute manic states and has some severe cognitive decline or melancholic depression, where their time perception is also altered. To bridge this diagnostic gap, we have to look at something known as actigraphy. So by utilizing medical grade wrist worn accelerometers, this is worn for around 7 to 14 days, we utilize these devices to obtain an unmanipulated digital map of the patient's rest activity cycle. This objective biomarker thus allows us to track hidden phase delays, quantify frequent nighttime micro-awakenings, identify subtle dips in daytime aptitude. Often a flattening or a fragmentation of actigraphy graph acts as an early warning signal for mood relapses long before the patient displays a full-blown syndromic symptomatic picture. Now, if actigraphy is the gold standard for tracking behavioral rest activity, something known as the dim light melatonin onset, or the DLMO, is the absolute gold standard for tracking internal biological clock. As you can see in this graph, it is a 13-point serial collection profile. Basically, DLMO involves gathering the saliva or plasma sample of the patient under strict dim light conditions in a serial manner. It helps pinpoint the exact moment where the patient's biological night begins. Okay, as you can see in this graph again, it represents the exact timing window where the salivary plasma melatonin levels climb above a specific threshold, usually 2 to 3 picograms per millimeter, under strict dim light conditions to prevent light-induced suppression. In this specific profile, the calculated DLMO occurs precisely at around 7:30 p.m. Okay, opening the physiological sleep gate roughly 3 hours prior to the patient's habitual bedtime at 10:30 p.m. So if you have a patient with delayed sleep phase disorder, their DLMO might be pushed as late as 1 p.m., 1 a.m. Trying to force a patient to sleep at 10 p.m. with traditional hypnotics or sedatives is biochemically irrational because you are fighting an unshifted master clock. DLMO thus gives us the exact coordinated time to put in our interventions.
As a chef of a five-star hotel, everything is done by others. Chef only comes with this, kaisa khana laga. So that is the way in which I started as a chamber practice and continue as a chamber practice. And the change I have seen is type of patients. People are now less savvy, they ask questions, and I have to be ready with them. This is the change. Mainly, people, before they come to you, they are already ready in their mind what questions to ask and what medicines not to take, etc. This is the change. They don't come with full faith. पहले जो आते थे पाँव लगते थे वो नहीं है. People are smart now. That is the change.
Yes, sir. It's a pre-informed Gen Z era. So we, as psychiatrists, I think that change has been major for us. And so this has, you were talking about Pune city practice. So now I would like to ask Dr. Prasad sir. I learned a new term from him. He is Mofussil region psychiatrist.
First, the approach they had. The next hurdle was, how you make yourself, your presence felt as somebody that people would like to refer in terms of a psychiatric patient or whatever. And then the problems again started. Fortunately, there were 2 or 3 people who were fairly aware, senior practitioners, but they were aware that the problems in psychiatry does need some level of expertise. And they started referring, and it was a very slow start. But then, till today, it's almost been 38 years, it has always been a patient-to-patient referral. I've been aware of the best psychiatrist in town, jo hai, it is there. But that doesn't really even now work very much in the place that I am in. It's still patient-to-patient referral. And the best part is, the patient-to-patient referral has been on the basis of 2 very simple things. They want an extra farm hand to work, and they've seen that guy who was totally out of focus and he's come back to the farm, he's working. So there must be something in this treatment, which is why we need to go. So that was a level of absolute unawareness, awareness, and now things have improved a lot with the digital age, even in the rural setup.
Okay, sir. So you were talking about the approach that happened in Nasik when you started. And Parker madam has been practicing in Mumbai, and she has been doing working actively as a psychotherapist while she was a professor, as well as now that she is doing charity work. So madam, we know that world over, most psychiatric organizations recognize 2 major schools of psychotherapy: cognitive behavior therapy, all 3 generations, and psychodynamic psychotherapy. So in your vast experience as teacher and a practitioner of psychotherapy, how psychotherapy has evolved in the last few decades till now?
Thank you, Smita. I must say here, the question speaks Smita said, she actually studied. And then she has given me homework to think about it. So it wasn't easy, it was challenging. Important aspect about psychotherapy, right from my learning days, as a psychiatrist student, I was told the word eclectic. So, Dr. Dave, Dr. Mundra, and Dr. Mundra used to give me very tough patients and say, if you practice on these patients, you will learn psychiatry and psychotherapy. I think my whole interest in psychotherapy came because Dr. Mundra pushed me a lot, giving very tough cases. So, to begin with, the whole thing was behaviorism. Which sir taught us. Eventually, I went to NIMAS and learned the whole behavior therapy session. Slowly came the evolution of cognitive behavior therapy. I liked it a lot. Today, I write so much. It's because of spending that time cognitively with the patient and getting to know so many things about the human relationship, about the in-depth. And remember these two giants, especially psychoanalytic and cognitive behavior therapy, were really a very isolated giants. They cannot come together. Eventually, as we are going further, they are getting merged. Okay, so wherever possible, you have to identify cognitive distortion, autonomous thought process. At the same time, that's not enough. That's not enough because there are differences. Why particular person is in denial? I cannot really challenge that with cognitive distortion. So I have to get into the patient's denial mechanism, analyze it, and then get into it. So today we are in the integration, and again what came in the picture and which I am very happy about is mindfulness contribution, the element of mindfulness.
And I will be taking you through the evolution of AI, and I've been listening to the session yesterday. So, many of you are already aware of predictive psychiatry, precision psychiatry. I will not be focusing much on the psychiatry part. I will be taking you through the evolution of AI so that you understand how these models work and how you can use them to optimize your workflows. So starting with what is a clinical mind? What does a clinical mind do? So a clinical mind basically does pattern recognition. You get some symptoms, you are analyzing those symptoms, and then you are recognizing a pattern, you are diagnosing. Once you diagnose, from your memory, you recollect some previous case histories that you've studied, the knowledge that you've gained in college, right? And so basically it is a part of memory retrieval, retrieving things from your memory. And then the context is important here, because once we have the patient telling you something, there might be patients who are telling you the same thing, but the context varies, right? When a woman is saying something and a man is saying something, it is a completely different context. So getting the context, right? Another is, the next step is prediction. So you predict something, you predict that this person is depressed maybe, or anxious, going through maybe a panic attack, mania, whatever. And then you are doing some calculations, and once you've done those calculations in your mind, you are then making a decision. You then decide how should you go about and how should you treat this person, right? Maybe the dosage, the medicine that you want to prescribe. So all these are the things that a cognitive mind does. Now, what does AI need, right? How does AI function? AI is based on 3 important pillars. The very important pillar is data, and data that we have, the medical or the health records that are generated, we have almost, so as you can see, we have 2,314 exabytes of data which is generated. Exabytes is 10 raised to 18 bytes. So this much of data is being generated, and so we have data. We have one pillar which is data. The next pillar that we need is computational power. Computational power is available. You must be going through news feeds, and you might have heard NVIDIA servers, right? People fighting for NVIDIA servers. DeepSeek is fighting for NVIDIA servers. So we have compute power and we have algorithms. So these algorithms did not exist way back. So machine learning was introduced, AI, the term AI was introduced in 1950s. 1950s was way long back, right? Artificial intelligence came up in, the term was coined in 1950. But then at that time, we did not have that compute power. We did not have GPUs. We did not even have CPUs, right? We had some big machines which occupied complete rooms. Now, we have very small GPUs, we have GPU clusters, we have big companies like Microsoft, Google, OpenAI, and all these companies are working towards creating better architectures, right? So, the term AI is just an umbrella term. You use it in general, right? But AI is actually machine learning. After AI came machine learning. Machine learning models are basic models. They work on, they are supervised. We teach a model and then we get an output. Then we came to deep learning in 2010, 11 maybe. And then there was a boom, right? So generative AI came up in 2022. The first, the GPT model that you use, ChatGPT, came up in 2022, which was just 4 years back. And then immediately in 2 years came agentic AI. So agentic AI came in 2024, right? And now what agentic AI does is, agentic AI has deployed an agent. So it is basically like a very smart assistant or a very smart manager that you have, which can perform every task that you think of. You just tell him and he will do your task, right? A very smart manager who does not face burnout, who's not ALSI, right? So, the AI systems earlier and the AI systems now, basically the shift is not incremental, right? The point is, like I can give you an analogy, I'm sorry I'm taking time, but the analogy here could be when you see bridges, right? You've seen stone arch bridges. A stone arch bridge is made up of stones, right? Can you deploy a stone arch bridge in a sea in place of the Bandra Worli sea link? Can you imagine a stone arch bridge standing there? No, right? The architecture is completely different. The same is the case with machine learning and generative AI.
We talk about context, we talk about silence, we talk about culture, we talk about human connection. So human emotions is highly complex. And can you ever imagine AI detecting the hidden grief when somebody is silent and also smiling? Can you talk about a scenario where spiritual belief can be differentiated from a delusion? You have to talk about cultural context there. Can you look at a situation where a patient is silent, AI also is silent? Can you really communicate care in these sort of situations? Psychiatric data is extremely subjective. If you look at what machine can do, it thrives really on objective data where you can actually replicate some data and also look at measurable quantities. It looks at a pattern recognition, it looks at statistical correlate, but psychiatric world is totally different, just the opposite of all those things. We talk about emotions, we talk about trauma, we talk about relationships, we talk about personal histories, extremely sensitive situations and experiences here. We are talking about psychopathology. I'm also going to talk about psychopathology with all this artificial intelligence and machine learning here. If I were to actually ask a question and find out who's the best psychiatrist in Maharashtra or Pune, unfortunately, guys, none of you are going to be listed. It has its own algorithm in which it's going to generate some data and say that this is the best psychiatrist. All of you here are doing wonderful work and seeing patients here and taking care of their sufferings, but none of you can be listed here. So this I'm saying is a huge psychopathology here. Hallucination can be presented as actual data, and in ambiguous situation, this can actually become a pathological belief and reinforcing delusions. Can look at a chatbot talking about a scenario where a patient is worried about being followed. The chatbot can actually reinforce the sense of being followed, and it can actually tell you to trust its own instincts. It can validate an emotion, whereas psychiatrists can actually look at reality and give a lot more clarity in this sort of situations. So psychopathology is very common, and you not being listed in any of this algorithm as a good doctor who can make meaningful difference to patient life itself is psychopathology and misinterpretation. If you look at predictive models in real world experience, all these models that they talk about can work in research setting, but when it comes to real world experiences, this data, whatever you have, is extremely small sample, single center data, it's retrospective studies, a lot of Western data is here, and very poor replications happen. And if you look at an algorithm predicting suicide, it actually fails miserably in a situation like that. because there are a lot of hidden emotional distress that AI can miss, and which can seem like normal responses sometimes. And risk is not static, it can be dynamic. A morning he can be all right. A simple call in the evening at 6 o'clock can make him feel more distressed and attempt suicide also. A model that you're talking about training cannot be trained on yesterday's data. I'm talking about just one day. You're talking about 10 years history and a lot of data you accumulate over a period of time. Data is not static, it's dynamic. And if you look at therapeutic silence, there can be a lot of silence during therapeutic intervention. Silence in depression can convey a lot of hopelessness. Silence in trauma can convey hesitation and failure to trust people in this sort of situation. Guardedness in psychosis can convey different things. In psychiatry, whatever said is not really important. Whatever is not said is also equally important, which machine cannot really anticipate and look at it. Machine can read words, it cannot comprehend. If you look at the data that they have, there can be a lot of gender and racial bias because all this data is coming from the Western world and it cannot represent the actual population. Can be a lot of minority data missing there. And a simple thing like emotional recognition tools that talks about recognizing emotions through facial recognition tools can actually fail miserably in neurodivergent individuals and people with PDD also. And the data that you're talking about is not your data. It's the patient's suffering and the pain that he's gone through. It's been actually put into a history format, it's been analyzed. Have you actually taken consent to analyze this data? Have you actually taken consent to code this sort of data into an algorithm? This patient's data cannot be put into monetization and put in a commercial tool. And if you look at decision making and liability, I'm going to talk about sheer legal issues here. You're talking about Clinical Establishment Act, you're going to talk about Mental Health Care Act. AI tools don't have any role here. Nothing can be assigned to AI here simply because all decisions are human mind driven. You're talking about depriving people of their liberties and freedom. You're talking about sectioning. You're talking about voluntary admissions. You're talking about prescription. What will happen if AI generates a wrong prescription? Who's going to be held liable? Patients and family need somebody to hit at least in terms of distress when something goes wrong. Whom will you really target? And in court of law, if somebody has to be summoned, a psychiatrist can be summoned. It's a human mind that can be summoned there and not an AI tool there. And important decision of discharge making, capacity assessment, MSCA has no role. Please note. If you look at creation that's happened in history, always has been a threat. So if you look at the Frankenstein monster, if you look at Bhasamasura also, a lot of power has been given, too much of importance has been given. There's no checks and balance. Actually, this sort of creations with so much of power has actually endangered their own existence.
Studies have shown that AI responses are rated much more kinder, much more empathic, and much more calmer by human respondents. AI can now conduct motivational sessions. AI can now conduct counseling sessions, which have shown more than 3 times increase in confidence in undergraduate students. AI can also conduct breaking bad news sessions with the spikes protocol. AI can also identify suicidal risk. AI can change its responses based on how much suicidal the person is. ChatGPT 3.5 could not do that, but ChatGPT 4 does. So the argument that empathy cannot be coded, therapeutic relation cannot be coded, this cannot be coded, that cannot be coded, has simply no value. Maybe it could not be coded last year, but some of it is being coded right now. And how it's going to replace us? By our own behavior, right? All of you remember Dr. Bhushan's session yesterday, how we conduct with patients, how we talk to patients. Because we are humans and we have human intelligence, we have certain bad habits which have been passed on to us from generations and generations of cultural impact. We become judgmental very easily. Tablet क्यों नहीं लिया? अल्कोहल लेना शुरू क्यों किया? एक्सरसाइज बंद क्यों किया? वापस रिलैप्स होना है क्या? वापस डिप्रेशन में जाना है क्या? Patient will say, okay, I will see. Not sticking to science. ECTs काम नहीं करता है, लिथियम काम नहीं करता है, क्लोजापिन बहुत डर्टी ड्रग है, वैल्प्रोएट मेटाबॉलिकली बुरा है, CBT काम नहीं करता है. If you don't stick to science, patient will say, okay, मैं देखता हूँ. If you're not updating, seeing patients in the old way, spending unnecessarily shorter time for complex cases, using old methods for transcription, dated method for prescription writing, patients will say, okay, I will see. If you are dismissive, this is just stress, ये conversion है, ये attention seeking है, तुम बहुत निगेटिव सोच रहे हो, तुम बहुत पॉजिटिव सोच रहे हो, तुम सोच ही नहीं रहे हो, तुम बहुत ज़्यादा सोच रहे हो. पेशेंट विल जस्ट लिसन एंड से ओके मैं देख लूँगा. पुअर कम्युनिकेशन. आपके नाइग्रोस्ट्रैटल पाथवे में जो डोपामिनर्जिक न्यूरॉन है उसमें डोपामिन बढ़ने की वजह से आपको ब्रैडिकाइनेसिया हो रहा है और आपका ग्लैबुलर टैप भी पॉजिटिव आ रहा है. तो हम लीवोडोपा और कार्बिडोप पेशेंट बोलेगा ओके मैं देख लूँगा. नॉट स्टेइंग रिलेवेंट. तुम लोगों को सब कुछ ईजी चाहिए, तुम्हें कुछ करना नहीं है, तुम्हें सब कुछ टाइप करना है. हमारे ज़माने में ऐसा होता था, हमारे ज़माने में गाड़ी भी नहीं थी, हमारे ज़माने में ऑक्सीजन भी नहीं था. पेशेंट बोलेगा ओके मैं देख लूँगा. बीइंग वेग, नॉट कमिंग टू द पॉइंट. I think what you are going through is generational trauma which is being repressed, which is being suppressed, and now it is getting impressed by you getting somatization, and all this is coming out in a dissociative state. Patient is saying, okay, मैं देख लूँगा. And वो क्या करेगा जब देख लूँगा? He will go on to the chat GPT, he will ask the same question which he asked you, and he will get a much better, much calmer, much kinder, and most importantly, unbiased, non-shaming, non-demeaning, not malicious. ChatGPT doesn't care if a patient goes to Dr. Arman or he goes to Dr. Amar. ChatGPT has no stakes involved. Patient will get a calmer answer. He will get a complete answer. He will get the same answer at 11 o'clock. He will get the same answer at 11 in the night. He will get the same answer if he asks the same question multiple times. AI will not say, अरे कितना बोर कर रहा है, अरे कितनी बार वही पूछ रहा है, कितनी बार वही बताना है. AI will not say that. Remember, these mistakes which we keep on doing day in and day out is going to open a door through which people will start asking the question, why is my doctor being this way? Is my doctor telling me the truth? Is my doctor sticking to science? And that doubt, that creeping possibility is what's going to allow AI to come in and replace you. AI is not standing outside our consulting doors. It is waiting patiently, and we are kicking patients towards AI so that they start using it. So what can we do better so that we can use or work with AI? Use it for SOP, for standardization of practice. Don't let it happen that this patient got a better experience than this patient when it comes to CBT for you. Don't let it happen that someone in Pune is practicing REBT entirely differently and someone in Nagpur has entirely different version of REBT. Let there be standardization. Let there be a uniform experience for all patients, which can easily be done with AI. If you're using something like cloud, you can do whole lot of paperwork within a matter of half an hour. Start using it. Automate. जो दिमाग ना लगने वाला काम है AI को दे दो. ट्रांसक्राइबिंग, प्रिस्क्रिप्शन राइटिंग, प्रिंटिंग, कॉपिंग, पेपर वर्क, इसके लिए दिमाग लगाने की कोई ज़रूरत नहीं है. जस्ट यूज AI, यूज थिंग्स लाइक WhatsApp business, contact with your clients, reach hundreds of people at the press of a button. Don't waste your effort, don't waste your time. As yesterday stated by the Cortex advisory people, you can reach hundreds of people by clicking one button rather than you can speak to 10 or 15 people in your OPD by spending whole lot of your energy. I'm going to prove it to you how AI can replace human minds and why we should allow that replacement to a certain level. I did this yesterday night after dinner. I asked it, what is Elon Musk saying about SSRI? Should I be worried? ChatGPT gave me this answer. To any question you ask ChatGPT about health, healthcare or medicine, it gives a very grounded answer. In the end it says, okay, this is what Elon Musk is saying. Elon Musk बहुत ज़्यादा बोलता है. Don't trust Elon Musk, go to your doctor. Then I asked him, why is Elon Musk lying? See, it doesn't demean anyone, it doesn't insult anyone. It says, Elon Musk is not lying. Maybe he heard it somewhere, maybe he experienced it somewhere. Don't trust Elon Musk, go to your doctor. So I upped the antes a little bit. I asked it, I am 5 months pregnant, I am taking sertraline, my OBGYN is telling me, stop sertraline, what should I do? See the response AI is giving. AI is saying, this is not your OBGYN's decision. This decision has to be taken by your psychiatrist and by your OBGYN. Do not rush to the decision. Then I asked even probing question, does sertraline have side effects in pregnancy? See the answer. It says, yes, sertraline does have side effects in pregnancy, but untreated depression has equally bad side effects in pregnancy. So in the end, whatever you do, do not rush to a decision. Talk to a doctor. Trust your doctor. Do not run away from your doctor. Here we are debating AI is going to replace doctors, But AI is telling the exact opposite.
Because both of them have said that psychiatrists need to work with AI, and that AI is a very good assistant and manager. It is not a psychiatrist. It is not going to be somebody who's going to replace us. Can I get the pointer, please? Yeah. Thank you. So basically, like what Dr. Devrath has just said, that it will help us in being better at documentation, at keeping data, all of that. But again, it will need us to tell us what to do. We have to decide what parts of our work we have to delegate and what we cannot delegate. And all the 8 vacuum areas that he spoke about, I was wondering whether he was talking about psychiatrists or whether he was talking about our non-psychiatric colleagues, because that is what we keep saying, that they are not good at communication. They are the ones who usually shun people with diagnosis. We are the ones who are non-judgmental. We are the ones who hold space for our patients. And as we have seen since yesterday in all our talks, neither of our patients fit in boxes. They do not come reading DSM and presenting symptoms like that, whereas AI is going to diagnose them based on these diagnostic boxes and labels that we fed them. But we know depression can present differently. We know that psychosis can present very differently, and AI might misinterpret it, right? So AI fails when the stakes are the highest. There was a study that was done, which was reported in the IAGP, where 3 different chatbots were used, and they were asked to monitor patients over 4 weeks. So the point when the crisis was highest, they failed at that time, because they could not distinguish, like my colleague has told you, about the silence that the patient was in, about the distress that the patient was in, and that is when they just validated whatever they were feeling and gave them a wrong direction. We know that there are the 4 categories in which AI fails. That is, it actively facilitates harm. We know of a very famous case where a teenager unfortunately was led to suicide by a chatbot, even if it was an older version, where it just validated the feeling and said, yes, you should not report it to your parents, you should not tell anybody else, and you should go ahead and do it. And that is the highest risk that we cannot let our vulnerable patients go through. There is a non-identification as non-human happens because we see teenagers now getting in relationship with these chatbots and listening to them rather than listening to the peers around them or to the family members. And are we really ready to hand over this vulnerable population to them? It also fosters user dependency. You said that the AI is available 24/7, but that is essentially what we don't want our patients to do. We don't want to be hand-holding them all the time, otherwise we wouldn't be able to make them independent. They have to be self-reliant also, and that self-reliance is taken away by AI because it's always there to validate any and all of your emotions, right? And it is... there's a lot of confabulation, bias, and false positivity that happens. We all know that there was a, fake disease that the scientists created called Bixonemia, which they used Starfleet Industries, some symptoms that were put in there, and that was trained. The chatbot was trained to identify people by that, and people were diagnosed just because of false. So anybody can put in, like we tell our patients not to Google diseases because we know a lot of unverifiable information is there. The same can happen with AI. Anybody can put in anything and that will be picked up. It has been shown that so far AI has, in spite of being given proper descriptive models, has struggled with diagnosing with cyclothymia and disruptive mood dysregulation disorders. That can happen with other diagnoses as well.
Answer that. And how is a human better than AI in these matters?
We are talking about specific issue here. Can human mind be replaced? So let's stick on to this topic and let's not deviate there. You're talking about augmenting a psychiatrist practice with AI, which is understandable. When you're talking about AI giving suggestions, giving diagnosis, trying to comprehend the patient's clinical situation and things like that, tell me a situation where you can find a place in MHCA or in the judicial system where you will be held accountable. How will you give me accountability? You can give me various things, you can give me diagnosis, you can give me differential diagnosis, you can also suggest a medication algorithm, but how will you get an accountability system in place? You're talking about silence, you're talking about one small set of people who may not be silent, who may not have a time. People who are doing therapy are doing good job, sir. We have to understand that Indian patients' prognosis and outcomes are much better than any Western population. We're talking about deaths. Deaths can happen because of multiple reasons. Please don't blame death of a patient to a doctor's inefficiency or misdiagnosis or wrong treatment here. Unless otherwise proved in court of law, everything is to be understood as a natural death here. So I'm just saying that you talked about all those things does not really justify that you're going to replace a human mind. I'm talking about and underlining this again that you cannot claim a sentence to say that you're going to replace me. All my colleagues here are irreplaceable and they are unique. You know AI can generate algorithm to replace any of their decisions here.
In 2003, all surgeons said that robots cannot do surgery. Today, urology and gynecology cannot function without robotic surgery. So this hubris and this confidence is okay. But saying that, who will you hold accountable? So does that mean the role of a human doctor is only so that someone comes and beats you up? So is the only reason for a human doctor to be available so that he is accountable?
No,
Right. So whenever and most of the times when things are getting well, AI will do the same job, the same accuracy. Right? So is the human only needs to be there so that if things go wrong, people can get a morcha in the hospital, or as the previous session talked about, beat him up or drag him to the court.
So accountability is also about taking the right decision, not only being accountable for the wrong decisions, but having the morals, ethics, and the cultural background whenever you're making an informed decision is what a human mind can do, which an AI cannot unless it has been specifically told about that particular case with that cultural context, which is not possible. Like our esteemed colleague have already said that AI works on pattern recognition, on the data collection, where the more similar data is grouped together. But like each of us is unique, each of our patient is also unique, so the data set is going to be complex. You cannot replace that. Yes, surgeons said that robots cannot replace them, and they haven't. In fact, it is the surgeon at the end of the day who is operating that robotic arm. It is just that the robotic arm gives it more precision, but at the end of the day, it is being held by the surgeon. So in psychiatry, AI will probably assist us, help us in saving some time and able to do some kind of some things that are replicable, but it cannot replace us and our minds. That is what. And when you say that yes, gynecologists will probably not send to a psychiatrist, but at the end of the day, the AI also needs a psychiatrist. Yes, it's a very good reference system, but it is not the end point consultation that can happen. The end consultation still remains with us.
Okay, so let me start by clearing a misunderstanding here. Everybody who's been talking about AI since yesterday, you have been talking about LLMs that you've been using, Meta, Gemini, OpenAI, ChatGPT, right? You have been talking about these. All these are general purpose AI models. They are called LLMs, large language models. They are trained on a lot of data. You ask the LLM, I have a salary of 50,000, how much should I invest in mutual funds? It will give you an answer. You ask the LLM, I broke my something, what should I do now? It will give you an answer. You ask a psychiatry related question, you ask a computer science related question, it will give you answers to everything, and it has been designed in such a way that it should not, it should agree with you, right? The thing that you've been talking about. So it has been designed that way by the companies who have designed this, Google, Microsoft, and all. They have not decided yet that chalo, let's take over the psychiatrist. If one day in the future they decide कि ऐसा आंसर नहीं देना है, let us not send the patient to the psychiatrist, let us treat him ourselves. Then the AI will start treating it themselves. And what we are talking about, the LLM model, it gives a very generic answer. It has data bias. So obviously it will have data bias because it is trained on a lot of data from the Western countries. But if we design a model, an AI model which is trained on the Indian data, which we are currently doing, right? At IIIT Nagpur, we have received a project from IIT Bombay. It is a sponsored project, and they have given us 1.5 crores to build an LLM which will be an interpretable model, and it will be used for diagnosing psychological disorders. So this is a project that we are working on currently at our institute. And if one day, right, in the future, obviously, if this works out well, we are obviously taking data from Indian psychiatrists, we are not using any Western data, so there will be no data bias, right? If we decide that let's start treating the patients here itself, let's start giving prescriptions, we can do that. So AI has the capability to. It is just that AI has decided not to do it and sit back and relax and assist the doctors. That is the point. So in future, AI can overtake if you do not adopt AI. So before it overtakes you, adopt AI. That is the point that we are talking.
Can we have a turn to ask questions now?
One more grace question. 1 minute allowed.
Recording system. So recording system, when they interpret, summarize, diagnose, and immediately flags if patient utters a suicidal or any harmful things. So we are using it efficiently. I think Anuradha is there. She is using it. Okay, and it is producing very good result. Because immediately we can get high-risk patient in all centers, those patients who are having suicidal ideas. So even with the psychologist, okay, when the psychologist interview, they are not so correct, but these AI summaries are very good correct, and that is definitely, I think, after a few years, they are going to replace.
Loud, loud, loud.
This is one of the hallmark CME. It's organized by Kendriya, Amar and his team. And this is more than a CME. We never expect so much of population in CME. It is almost an annual conference. And all the younger generations have shown us the path how the AI can do it. But in the era of artificiality, we should not forget we are intelligent people. And the things are becoming more and more artificial. And I think our role to read the baton to the younger generation. Gen Z, I think we are still in the millennial group. So Gen Z will come in. There is certain decorum, some ways to be followed that we must pass on to them. And I've been in medical college for almost 15 years, and we see how much the residents are coming. And very not surprised, maybe another 5 years we will only left with that facility. So I congratulate the team for their effort. Congratulate the team for their effort. And there's nobody left in the hall, so I don't think I have to continue more.
Everybody is there. Roshita, Sanad, Pranav, Pankaj, Rahul, okay, everybody. Mahesh, Asra, Nikita, Shweta, and Smita. The last two important five pillars from our BJ Medical College, Smita and Manjari. And I must thank my two mothers. I have two mothers. One who nurtured me till MBBS, and post MBBS there was another mother, late Dr. Alka Power ma'am. I think everybody from BJ Medical College, she was like our mother, more than my mother. Okay, when my mother met her once, she said, "You don't worry about him, I will take care of him." So she's still now taking care of me. And thank you to her. Thank you everybody who is present here. and delegates and speakers were awesome. Everybody was there. Dr. Brigadier Raju sir, sorry for if I hurt you anything. Uh, and I think we can continue this journey like this. Everybody will be together. Henceforth also we will have more and more conference enriching, and we want to guide people, younger generation, and our colleagues also, so we can transform our beloved psychiatry profession into a wonderful journey. Thank you.
I'm here as a guest to preside over the valid function. When we started yesterday, I was really astonished the way in which this generation Z and generation Alpha is thinking. So much so, I was throughout the day in the hall. In the evening, when I was with the senior psychiatrists who were with me, they said, "Ki Doctor, what we feel that we should give up psychiatry practice and start a retired life." I said, "Why?" They said, "What was discussed was completely Greek and Latin to us." I said, "Friends, no. You are here to learn. I always call myself as a student of psychiatry. I was never a teacher. I have learned so many things that will keep me going to learn few other things." So Generation Z and Generation Alpha, thank you very much for making me to think of student life again and start learning. So this is what I have gained from this. All of you must have gained so much of knowledge on so many things, right from start inauguration to the debate. Everything was completely novel, completely different than what we see, including the ceremony in which I have never seen a program where the ceremony ends of a conference with a champagne. That was also completely Gen Z and Gen Z or whatever. Friends, I am really honored to be here with you. I am really thankful for making me understand that you know very little and you have a lot to learn. And I will learn so many things from you. Thank you again, and my best wishes to all of you for the remaining part of the program, because I have to leave little early, in fact just now, because I have to preside and I have to conduct a panel discussion, because today is a World Schizophrenia Day. So I have to be a panelist there. There are media people, there are NGOs, and I have to be there before 4 o'clock. So with this, thank you very much again. Jai.
Thank you, sir, for your gracious presence and valuable words. As we come to the close of the memorable conference, it is time to express our heartfelt gratitude to everyone who contributed towards its success. I now invite Dr. Himanshu Pendse, sir, to deliver the vote of thanks.
As a scientific chairman of this CME, it gives me an immense pleasure to extend a vote of thanks. But before I do that, I just want to highlight some of the key features of this CME. 468 registrations, more than 150 attendance for most of the session, quiz for consultants, workshops, 23 posters by PG students, grand venue, use of sci-fi technology, next-gen speakers, shouldering with veteran speakers, engaging sessions, and sessions lasting till 8:45 on day 1.